also. But ACL, if it is non-competent, arthritic knee, which is clinically stable, I think fixed bearing UK works well.
So that there are some papers on that, but
Yeah.
I think that we should leave to independent surgeon to take a call.
Right.
So I would agree that you can do a slope correction with a fixed bearing uni.
Yeah.
Sometimes in our part of the world, the number of unis have actually come down. I don't know why. Patients are not very keen.
So is this thing surgical field okay? I think the light, you can take it out because there will be some glare.
We can see nicely actually.
Okay, I'll start. Yeah. So most of the unis, I'll be taking a mid-vastus approach. So take a small incision.
Yeah.
But I'd like to tell people that even if you have to, the main thing is to have the uni absolutely perfectly placed rather than, going for a small incision. If you want to take slightly bigger incision, it doesn't matter. The sutures will heal in 10 days as it is. So if there is a heavy patient or slightly, tight knee, then you can actually take slightly bigger incision. There is no problem. So it doesn't matter. So here I start coagulating right from beginning. So later on you don't have to, put it. Now mid-vastus approach, so I palpate the patellar superior pole, and from there I will be taking a oblique incision in the vastus medialis, then change the direction of the knife and go down and just expose it about a couple of millimeters below the articular surface. So nicely now we have taken it out. Rakesh, laterally. This is okay. So I will put this retractor, a small retractor. I always try to use very gentle retraction, and I put it below in the intercondylar notch here. So you can then resect the fat so that the joint is nicely exposed. Retract. So you can see the bone of medial condyle.
Yeah.
And take out this fat so it doesn't come in your way. The most important thing is that in unicompartmental, you should not release any ligament. So it's mainly a resurfacing surgery, and you need not do any releases. Only you have to expose it so that your burr doesn't damage the soft tissue. So at this stage, this is not a release actually, because the ligament will start from below, and now it's nicely seen. You can see the condyle completely worn off. You can see that tibia is nicely exposed, so you don't need to really expose more than that. After this is done, then I'll be putting my pins. In totally, I put the pins inside the incision now. But in UK, with a smaller incision, it is always better that we take it about 3 to 4 finger breadths superior to the superior pole of patella. Then I put this inside the bone, ensure that it is sitting absolutely in the middle of the bone. You have to be sure that the pins are unicortical. These are thick pins. I have had some fractures in early practice where it was cortical or bicortical. So you have to be very careful. I always tell my fellows that the most important step in robotic surgery is to put the pins. Baki to sab, easy hai, but the pins you should take some time and put this. The lower pins are on the about 45 degrees to the surface and about 2 to 3 finger breadths below the tibial tuberosity. Again, should be sure that they are unicortical. So the moment you feel the torque, then you have to stop it. Okay.
Vaidya sir,
Yes.
what is the youngest age you have done UCAF?
45 or so. I have done one case, Rakesh is reminding me, where there was a very youngest, I think it was 20 odd years, and the indication was really very unique. The girl had a traumatic, stiff knee, and she had completely both compartments. So I did resurfacing in the unique on for both the compartments. So she, and then with that quadricep plasty, along with some, hey, tourniquet छूट गया है क्या? नको नको, tourniquet I think is deflated. एक पिन दे हरी छोटी, छोटी आपली जिग ची पिन नहीं, ठीक है. So generally I put a small pin here so that in अंतर भी. टूर्निकेट का देखो यार क्या हो गया. I think we should release it and elevate it again. छोड़ दो. Just give me a couple of minutes. So that girl, which was 20 years old, because I had no option. Articular surface was completely damaged, and she had a stiff knee, almost fibrous ankylosis, you can say. So that girl, I did medial and lateral uni with Cori robot, and she's doing fantastically well. And that was just a time buying procedure. Maybe when she is elder, going beyond certain age, she will require a revision. But today she is happy. Her knee is mobile. She's got a good range of movement. So I think age is a relative thing, and if required, you can use this because you are really not resecting any bone. But generally, for arthritic knee, I think 45 was my youngest this thing. That case which Rakesh was mentioning was, one of case where I've done in 20. So youngest is 20 years.
And a well done robotic uni, how long it should last? What do you think?
See, it has to be, like
Long.
if you see the literature, then a 20-year survival of a uni, it's almost 92% now. 90 to 92%. And the registries are showing almost the same survival rate, like, whatever total knee is going to survive. Negative. Lateral retractor. Okay, sure, fine. So now next step is to start the mapping and registration. Please feel free to, ask any questions. So I take the points on the tracker itself, though the system says that you put this small screws on this thing. You can take this and ensure. So medial malleolus, lateral malleolus, and take the limb through the small circle. Try to remain as close as possible to the main internal circle so that you don't have errors. This has to turn green. Then you have to collect the neutral position. Once this is done, I put this small Z retractor inside the medial compartment and apply a thumb pressure here. I think you can see that. Hey, tourniquet se kaitari gadbad hai, Rakesh. You have to understand here that you should not apply brutal pressure here. Just be gentle, and that should be enough. After this, retractor spike. So I put up this small gelpy here and put this retractor here so that mop.
टूर्निकेट प्रेशर कम है क्या पूछ रहे
वो कुछ तो भी गड़बड़ हो गया, वो टूर्निकेट छूट गया है शायद. एक पिन क्यों है देना अपना. हाँ यार, आई कैन पुट दैट के वायर.
प्रेशर बढ़ा के देख सकते हैं कभी कभी.
I think it is working now. It had got deflated in between, so I think it is better now. So just take watch the open. They cut करायला द्या, wire cut रहेगा हरिबो. So I put this small pin here, so it acts as a self-retaining retractor. Out. There. ते लागेल हाताला. Okay. I generally put this jig, conventional jig का जो ये रहता है, that I put it suction. Yeah, I think the tourniquet is okay now. Now you have to start mapping. So take the side mark that is there, then the knee center, most distal point, posterior point, and then just go on moving this probe on the condyle. So this will create a three-dimensional virtual image of the medial condyle or lateral condyle, whatever you are operating. In this case, medial condyle.
Do you think it is important to remove all osteophytes before we do?
Yes, 100%. In this case now, there are not much osteophytes. If you see here, there are not many osteophytes. So in this case,
it is
yeah, but it is there. And a very good point that you have to always remember, sometimes there are osteophytes in the intercondylar notch, and they will be indenting on the ACL, and you should always remove those osteophytes also. So I am taking these marks, then I put this in the soft part, which is, just parallel to the condyle here, and take this axis. So you see here now, you can just correct the rotation, go back. So I always, one more. So I'll always try to keep it parallel here to the blue line, which is seen there. So your tibial rotation is absolutely perfect. And then again, now just go on moving it. I always try to paint the intercondylar eminence also, because that will help me in getting the slope as well as the medial placement right. Now, sometimes you have to just, for getting to the back of the knee, the external rotate curve. With the pins, I just ask my assistant to rotate it externally so that I can map all the condyle here.
A lot of the times it's very difficult to map the thing.
Yeah. You need not go all the way posterior. It's mainly because whatever way you can map, you can do that. See that you have mapped anteriorly properly. So I think that should be fine. Now with this, now we come to the planning screen. Now I start with the cross-sectional image. You can see here that I've got a size which is 1, which maybe I can take it to 2 and then just try to align it. So I'm moving it slightly anteriorly and distally. So it is absolutely okay. Now the implant is going more in the intercondylar side. So I am taking it to the medial side. Then I move my finger and see this. So you can see it is nicely sitting now, absolutely center to this thing. On the left hand upper image, you can see posteriorly I'm aligned. On the right hand side, I can see that, this image which I'm moving now, it is absolutely aligned to the cartilage. There are 2 types of robots now. Let's go to the basic. One is with the CT scan, like Mako or the QVIS, where you do the CT scan. But a problem there in CT scan is that you are actually having the bone mapping, because CT scan doesn't see the cartilage. The beauty of such robots, Cori-like robot or Wales-like robot, we are mapping the cartilage. So we are actually getting to the cartilage, and that is what we are going to restore. But CT-based this thing, the planning is done on the bone. So you have to always take in consideration about 2 millimeters of cartilage. And there's some humming, just.
Also, the shape matching will not be accurate because it is a CT
yes,
base.
Absolutely. And there is huge radiation. I think I have a talk in the. So now on the tibial side, what I do is that I'll take 2 sides right now. And first I start with the upper and right image where I try to match the slope. You can see a yellow line here. I'm moving my finger and my yellow line is absolutely matching to the natural slope. So right now it is about 5 degrees. Now if you recollect, my graph, which was on the stress graph, we had laxity in extension and slight tightness in flexion. So I'll just increase my slope to 6 degrees. My tibial planning is always standard. Then I'm taking it on the medial side so that my intercondylar notch and this thing, I'm again moving my finger. You can see a yellow the line which is going up. That is the intercondylar eminence where I'm going to align it. So I can just move it medially and then go to the lower part where I can align it anteroposteriorly. So I think this is a good sort of this thing. And
do you align it also with the tibial NPTA? Sometimes the tibia is in varus. So
sorry, I didn't get you.
So if you look at this is a zero cut.
Correct.
The native tibia sometimes is in varus. So will you align it with that, or you just go with this zero?
No, I always go with zero. My tibia is always standard with about 5 to 6 millimeters of cut, slope 5 to 6 degrees, sometimes 7 degrees, but it is almost, I try to match the natural anatomy. If you see this particular knee, then there is no, bony defect, or there is no sort of lot of erosion there. So I will just match the natural anatomy, whatever is there. So now this is the planning. Now I'll go to the next step, and you can see now from 5 degrees we are getting to 1 degree, but my knee is pretty tight in mid flexion, so we will have to align it. The beauty of these robots is that you can now move the implants in all three directions. So here, instead of going for tibial cut, what I will do now here is that I'll slightly increase the
just hang on there, hang on. Just explain the graph to the people.
Correct.
Don't understand that.
So on the left hand side, you are at neutral. The midline, the horizontal line shows that there is no this thing. Anything below the line is tightness. So around from 30 degrees to 60 degrees, I am having tightness in the knee, and again it is opening up when it is flexing. So here I am going to adjust the femur, and I'll take it anteriorly slightly. And I may increase the size of the femur to 3 so that once it is size 3, then I'm getting a flatter this thing. I'm going for a higher implant. Now you can see that I am tight in extension and I am lax in flexion. So to increase the gap, I just move the femur slightly superiorly, and you can see the line flattening up very nicely now. So my graph is absolutely stable now. And my aim in unicondylar is to, arey yaar, kya ho gaya? It's light, huh? So my aim here, Krishna, is to correct the deformity to about half of whatever is there. So from 5 degrees, I'm going to 3 degrees, but my graph is absolutely stable. So is it clear, or should I go back and again tell them?
Yeah, I think you should just go back once. It is clear to us because we do it regularly.
No problem. Yeah. So my graph initially was like this. Okay. Something like this. And I was at a size 2. Yeah, ऐसे कुछ weird दिख रहा था. Okay. So from there, I increased the size first of all to size 3 femur. Okay. And then I'm now pushing superiorly. So I'm cutting some more distal bone. Just like in TKR, you have to remember that whatever deformities are there, tightness in extension, you have to resect more distal femur. If there is, tightness in flexion and you are doing the anterior referencing joint, then you take the implant anteriorly or undersize it. It's the same principle. But here you have a luxury of moving the femur, and if you saw, I'm not touching the tibia at all, because most of the complications happen in the unicondylar knee with on the tibial side. So tibia should be standard. I do all my adjustments on femur. So here I have taken the femur slightly superiorly. No, that means proximally, not superiorly, proximally. So it has opened my extension gap, and I have increased the size from 2 to 3. So that is how I have come to this thing. So I think this planning is absolutely fine for me. Then you have last option where if you think that you have to still correct more deformity, you can increase the size of poly when you are putting the final poly by 1 millimeter. So from this 3 degree, I can go to 2. But I am very happy with 3 degrees, because another complication which happens in UK is that stuffing of medial compartment, which will lead to lateral compartment osteoarthritis. So you should be very, very careful and correct it half. And patients are really happy. From 5 to 3 degrees is perfectly fine. So I think here most of the surgery is done now, actually, because my planning is absolutely spot on. And now here I'm seeing the articulating surface. Now I move my finger to see how my tibia is going to articulate to the femur. So I'm moving this. If you want, you can still take it a bit laterally so that it comes in the center. On the left hand side, there is a button here where if you push it, then this is going to be a load bearing, weight bearing, and this is non weight bearing. So on both sides, my centering of the femur and tibia is spot on. So I don't need to worry about it.
So in this graph, I have a question.
Yeah.
In this graph, it is shown that tibia there is edge loading, but actually
No, I don't think there is age loading. It is we are pretty in the center, so don't worry. Age loading means
more on the medial edge.
yeah, but it is a flat on round design, so don't worry. And because our bones are pretty small, so there is very little space to move the femur or tibia. But if you really want it, you can still take it. But one click, about half millimeter, and it has come inside now. So I think this is absolutely fine for me.
It is showing completely red or something, then you're worried. Otherwise,
Yeah, exactly.
it
If
okay.
you are on the edge, this is a perfectly
not
okay.
on the edge.
Exactly. So now you have to ensure that your trackers have not moved. So I'll take this picture here on the tibia again here. So you get this 3D sort of a virtual image where red is going lateral retractor. Rakesh. Red is about 3 millimeters, blue is 2 millimeters, and then okay. So I'll start from the Naveen bar na re baba. This I have used Navi also, I have used Gori also, but this handpiece is pretty ergonomic and it doesn't give pressure on my MP joint, and it's really fast also. क्या पाहिजे इरिगेशन नहीं होते इरिगेशन ऑन कर रहे बाबा इरिगेशन नहीं हो रहा है सही करा सलाइन just watch that.
When you made the plan for I think the surgery is over. Now the Darwin just execute it. So
Sorry?
I'm just telling the audience that
Yeah.
As soon as the plan was made, the surgery is over.
Exactly. Now this is
So
really like
execute this.
exactly mechanical work only. It's like just you have to burr it, and most of the part is your planning. That is the most important thing, like Krishna is saying. Sometimes it may be a bit difficult to go all the way posterior, but what I do is that I go from the exposure control to speed control so that my burr can reach posteriorly. External rotate cup. So this position, it is better to flex the knee so that you can go all the way posterior. And if there is some bone remaining there, don't hesitate to take it off with osteotome or a small sort of a saw. Then I make this starting point for my burr. एकदम ब्लैंक का होते मेरे okay, so I think I'm done now. I'll just remove the sleeve now and suction, make the lug holes. Yeah, I'll show that one. I'll make this holes now. यार हे का होते मला कळत नाही. मध्ये जाते का पिक्चर? People take, when you are a beginner, people take slightly more time for making this lug holes, but now it is really very fast for me. That hand-eye coordination I have developed for last some years. Yeah, sort of watch it. So femur, you can see nicely done now. You really have no dents or anything like that, and you can see it is as good as a saw. तो पीपल हैव एप्रीहेंशन कि बरिंग से सरफेस कैसे होता है. आप देखेंगे तो एकदम सरफेस इज एब्सोल्युटली ओके एंड इट्स रियली वेरी गुड सरफेस फॉर सीमेंटिंग. Then I take tibia and I put this picture like this so that, yeah, okay. And for the tibia, I start from the front here and I do something called as a tunneling technique. हलवू नका. So all my instruments are replaced with one hand piece, which is a smart hand piece, which is what I call. So you don't have to, rely on so many things, because UK, if you see the conventional instrument, your life depends on the first pin of tibia. If your tibia pin is wrong, then your femur cut is depending on tibia. So everything will go for a toss. So here, now my intelligent hand piece is actually doing all the work for me, and it really works very fast. This new handpiece and camera of Cori is really excellent, because the reaction time, because the camera is very, very fast, the reaction time, that means if my burr is going outside the cutting zone, then it will stop immediately. So it is really fast, and you don't really see all those red marks which used to be there in earlier system Navio. I think it is the fastest in the market now, this Cori camera. Velis, I am not sure, but overall, it is the most, rapidly working this thing. So the burr will retract immediately the moment it is outside the cutting zone. I think this is fine with this. The tourniquet somewhere is actually not functioning well. Anyway, Krishna, can you see it now?
Yeah, it was very, very sleek. Very
Great.
nicely done.
Very good. So now at this stage, I will be removing the meniscus. So with a nibbler, I'll get hold of this meniscus here and then retractor, medial. Sorry. So here, again, I'll emphasize that in uni, you should not release any MCL or any ligament. That should not be released at all. It is a resurfacing surgery, and you should be just resurfacing the cartilage which is worn off. Suction. टूर्निकेटने आपली आज काहीतरी कार्यक्रम केलेला आहे. I hope that people don't understand Marathi. कृष्णा को आता है, कृष्णा knows.
I can understand, but the thing is, आप सबको लग रहा था कि आप पुणे से ऑपरेट कर रहे हो.
नहीं नहीं, यहाँ ऊपर ही खड़ा हूँ मैं यार.
क्योंकि टूरने के काम नहीं किया तो थोड़ा हमको समझ में आया कि
yeah. So Shubhang's hospital is like a Pune hospital only. Shubhang का और मेरा कुछ अलग नहीं है. So
yeah, amazing actually.
Yeah, I don't know where is he. I have not met him. Now I'll put this tibial, trial. Again, you can, change your size if you think that it is overhanging or something like that. So I am using a size 2 tibia. There may be a slight overhang, so I will just cuddle the osteodome. So I always come, Krishna, with my team. Dr. Rakesh, he is assisting me. Hari is always there. Ashwini is there. So they are like, Jay, Vijay. They will be always with me. So I can, be very comfortable with my surgery. So I'm just undersizing it because I thought that size 2 is slightly,
Now you're in a stage where you should challenge yourself with unfamiliar situations.
Okay, call me to your hospital. Okay, so my femur and tibia I have put. Size 8. Your poly should go very easily inside with thumb pressure. So you can see now, just focus here, very nicely aligned. And I don't know who was asking, I think it was Dr. Pasi, who was
Yes,
saying
sir.
age loading. अभी आप देख लो कोई एज लोडिंग
No,
नहीं है.
and that
It
is what I
absolutely,
wanted to point out, sir. In that graph, sometimes it looks like it is edge loading, but during
yeah,
the trial, it comes in the center only.
absolutely. No,
That is
it
what
is
I
such a
wanted to say.
nicely, centered implant.
Yeah.
And then take throughout the range of movement, check for stability. I think we are spot on and we are ready to go for final implant. क्या हो? No, no, it's okay. I think that angle is bit this thing. So I'll now go for this thing. I may try for a 9 poly and I'll take the graph again. If it is going easily, yeah, 9 is going very easily. So I'm opting for 9 and let's see how it is looking on the graph. Take a minute. So from I think it was 5 degrees earlier. So I'm coming to 2 degrees. I increased the size of the poly by 9 because I thought it is actually doing good and it is not getting lifted off also. And you can see the graph is absolutely centered. So if you see now, we actually had 5 degrees of virus. We planned for 3 degrees, but today, now at the end of the day, I'm getting at 2 degrees with 9 poly, which is going on very easily. So this graph is fine. Anything, Krishna?
Looks perfect. Yeah.
Yeah, it's perfect. So we'll now go for the final implant, lateral. Yeah, implant above. Cockers. Any infiltration you want to give? Local? Okay, block the क्या क्या? What is your protocol? Do you give any local or no? Generally, my practice they are giving adductor canal and IPAC, and I also infiltrate inside the joint also. Ospia capsule. Give a copious lavage. एक minute. Forceps. Forceps. ये यहाँ रखाओ. यहाँ लगाओ. Right.
Sir, do you think that this kind of surgery can be daycare surgery?
100%.
This kind,
100%. Especially with IPAC and adductor canal block, you don't need to give a spinal anesthesia also. ये काय पडते खाली आहे? Shit. I make some couple of holes here for better cement penetration. 100%. But the problem with our great insurance companies is that they say that daycare surgery will not be reimbursed or something like that. कुठलं पहिला कॉस्ट आहे का सिमेंट कुठलं आहे? हा. So I use Palacos generally with antibiotic gentamicin cement. You have to ensure that you give a copious lavage because this burying system can leave bone dust inside, and you should give a lot of lavage here to remove everything. And it's just here for to make the surfaces dry. Mop. हाथ हे करा. Krishna, incidentally, it is a very big day for me today. I am doing today's is a 75th live surgery which I am doing.
Only 75. I thought you would have done more.
नहीं आप बुलाते नहीं हो तो कम हो गया थोड़ा.
मैं करते ही नहीं हूँ robotic meeting.
So it's a great privilege, yeah. And with you,
I think we must appreciate you for standing up to a lot of adversity and bringing out robotics in this country. Actually,
yeah, I think I faced a tough time, and a lot of people were apprehensive about this thing, but nothing personal. People took it personally also sometimes, but now I think most of them have understood, and there is a role definitely. It's not only. ए, यहाँ रखो. So especially in Pune now,
Dr. Rakesh is saying that you converted everybody to robotics.
Rakesh, yeah, definitely, maybe. People who are very apprehensive and very not really appreciative, because I think our practice has really changed. Now, I have been now trying to do all my revisions also with robotics. And I think it's not a FDA approved sort of a software right now. But I think in coming few months or year, we'll have a completely robotic revision system also.
Uh, uh, I think it is getting approved soon.
Yeah, it's getting approved.
Already approved. But you can use the standard primary thing also.
Correct, exactly. You can use that. You can mark the special points and full kill it.
So you are planning that in September conference, no?
Yeah, I am planning, but this Smith and Nephew guys, I don't know if they are going to launch in India or not.
We don't have the revision implants. That is the problem.
Sorry?
We are not able to supply the revision implants.
Revision? They are not able to supply primary also. वो आनंद रहेगा उधर. वो मेरे को बोलता है सर रोबोटिक करो लेकिन 8 का पॉली नहीं है 9 पे एडजस्ट करो.
That is because of your volume, sir.
वॉल्यूम नहीं, वो बोलता है एडजस्ट करो. स्मिथ एंड नेफ्यू है क्या उधर कोई?
You thought that you will say this, so they're not there.
Ensure that you remove all the cement from the posterior side also, and it is sitting nice. So थोड़ा टैप है नहीं मतलब mallet दूसरा. I have sometimes one case I had fractured the medial condyle. So I'd like to tell all the people that you should be very careful in hammering. Don't use your handle here. Use the hammer here and just have a gentle listing. Generally in my hospital, I'm using a Teflon lightweight hammer and to get my tibia in place. So I have ensured that all the cement is removed. Anyway, there are some surgeons who cement the holes also inside. I don't really like that, because if you anytime you have to do a revision, then if you have injected cement inside, then it will almost completely remove the condyle. So don't do that. Don't cement inside.
And also linear peg growth.
Sorry?
I think it was recommended when the pegs were perpendicular to the bone.
Yeah, this is at a 45 degrees.
These sort of pegs, angular pegs, are very stable.
Forceps, chota, Addison's.
Femoral peg.
So ensure that you remove all the cement. Okay, thoda external rotate kar, slightly. Okay. And the poly should go very easily inside. And it is gone inside. You can see it is nicely centered. With one tap, it should lock. And I think we're done. So I'll check the graph again. With there was a study which we are doing, incidentally, Krishna, in our hospital, where earlier I used to remove the pins and did not take a complete sort of a picture after cementing. But you generally get 1 degree of correction. You see here from 2 degrees, I am coming to almost 1 degree. So with cementation, you always have a 1 degree sort of a correction. Now you will see that I have not changed the size of the poly in the planning. That's why you are seeing this big tall sort of a graph. So if you have to align, then you have to go back and then change from 8 to 9. So my graph will be straight. Otherwise, with 1 millimeter opening, whatever we are seeing here, that is because with 1 millimeter poly, my sensors, they have gone 1 millimeter apart. So that's why it is showing laxity. But actually, it is not lax. If you have to really get it right, I skipped that step. I should have changed the planning screen to 9 poly when I changed it. So that's why.
But I would actually accept a millimeter or two laxity in
Absolutely.
bearing.
Yeah,
So
yeah.
this looks perfectly good for me.
Yeah. So I'm done now. I think.
Thank you very much. That was actually a very nice, elegant demonstration of how to do a robotic fixed bearing UK. We'll see you soon here.
Yeah, yeah. I'll come down. Yeah, yeah.
Bye.
Thanks, Krishna. Always pleasure.
Thanks a lot, Dr. Narendra Vaidya, for such an elegant performance of this live surgery. And I thank the moderators for this session. And kindly please stay on the dais, sir. Moderators, please. Can I request Dr. Rakesh Rajput to give a token of love from our side to all the moderators? Can we have you on the dais, sir, again for the nice click? All the moderators, Dr. Pasi also, please.
ये निकाल दो माइक.
That's fine. And can you join us on the stage, sir, for the nice cake?
We should also comment that there are some other they were here before any of us.
Yeah. Thank you, sir. Kindly stay for the nice click also, sir. Just one click. You can edit it afterwards, sir. In the filters you have, I think you can do that. We are just checking the live feedback of the second surgery, which is going to be performed by Dr. Shubhang Aggarwal, robotic THR, distal burr. So just give us a minute. Dr. Shubhang Aggarwal is director of NHS and HOD of Orthopaedics department of NHS hospital. He's a man behind this mega show, and he always has that inclination of doing this kind of surgeries and sharing his experience with his fellow colleagues. And yesterday's session, as you know, that was quite a busy session. We had a lot of live surgeries, 2 live surgeries with around 20 sessions, speakers coming on the dais and delivering their experience. This day also is going to be a great one with the complete power pack, 4 live surgeries. One has already taken place, and another 3 are also aligned. They're all Cody robotic surgeries. And I think NHS hospital is the first one to have Cody live surgery workshop conducted for THR. In fact, our is the only center apart from Kolkata, Mumbai, and Chennai to have the Cody total hip replacement center. And this is a great honor for this reason that in this northern region, our is the only center which is having this facility. And under the leadership of Dr. Shubhang Aggarwal, we have risen, I think, in NHS to a great heights. Because I'll also give you another insight into it that NHS hospital in last 1 year has also got, I think, the unique distinction of one of the few institutes which have DNB seats for 3 different specialties. One is for neurosurgery. We have that DNB seat. We have also earned the DNB seat for neurology, that is DRNB in fact. And then we have 3 seats for orthopedics also. So 3 different specialties under one roof, the DNB would be there. So it's not a hospital anymore. I think we can call it almost an institute now. So that's a great honor we have. Can we just have the confirmation of the right sir? So can we just go with the presentation then? How much time we have got today? Meanwhile, can I request the moderators of the next live surgery, Dr. Ajit Kumar, Dr. Vaibhav Bagaria, Dr. Ravi Gupta, Dr. Amandeep Bakshi, in case he's there, Dr. Prakash Dhillon from Amritsar, to be on the dais, please. Escort team, please escort these dignitaries on the dais. Sir, meanwhile, you can say a few words about it because it's taking almost a minute time, I think, board. Maybe you can brief something on this, robotic knee replacement by disturber. This is going to be none other than Dr. Shubhang Aggarwal performing it. So just it as is yours.
नहीं नेक तो नहीं
Mic is there.
उड़ते थे लगा रहे
Fine.
अंदर जा रहे कोई नहीं कर दे भाई इधर ध्यान
So I
से
think we are all set here. So Shubhang, can you hear us?
yes can you hear me
Yeah. Loud and clear.
they're just adjusting my mic
Right. So Vaibhav here, and I've got this team panel here with all of us, and we'll keep disturbing you in between.
so
You want to give a brief of the case, please?
yeah so she's a 59-year-old lady with bilateral osteoarthritis knee we are doing the right knee today so she's got are you done okay so we've just inflated the tourniquet she's got no fixed flexion deformity okay she's got about 10 degrees varus which is partially correctable clinically and she's got a range of movement to almost 120 degrees so what we do is we give an Dr. Vaibhav, you know the pre-operative cocktail that is given so we are going to start now
For the benefit of audience, let us know what cocktail do you and how do you infiltrate?
yeah so we just give a pre-operative intracapsular and subcutaneous infiltration okay it's got lignocaine with ADR it's got saline and it's got Hylase starting
The camera, the top camera, the surgical camera is not visible. If someone can switch that on.
so
Can
we are
you
doing this
overhead the operating camera on?
Emra, I need to okay take it please
Shubhang, good morning. I'm Ravi here, Ravi Gupta.
morning sir
So, can the cameraman show your hands and the surgical
yeah
field?
it's not on where are you आगे आ जाइए और आगे आ जाओ और आगे आ जाओ थोड़ा इस वायर को ऊपर कर लो ये टच होएगी वायर खींच लो थोड़ी
And in the meantime, what was the duration of her symptoms? And if someone can focus on the X-ray, that would be great.
yeah so duration of symptoms is 4 to 5 years okay can you see now the operative area
Yeah, now it's much better. Thoda glare, if the glare could be reduced.
okay I can't see what's being shown there ये light थोड़ा पीछे कर दो maybe is it better now वो light
But it can be still
better.
more better.
So I think you can reduce the intensity of that light उसको पीछे ले लीजिए उसको पीछे ले लो
Dr. Shubhang, Dr. Prakash here.
yes sir
So, what the BMI of patient?
what's the BMI she's not I don't know I'm sorry there's no calculation here but anesthesia what's the
She's not.
28 is the BMI okay so we are doing the standard medial parapatellar approach. Suction, please. She's got history of multiple steroid injections. Is it okay? Can you see clearly now? Or is it too bright?
Can be still better actually. If the cameraman can do some tricking with his adjustment of the camera.
Can you? हाँ yellow है ना इसकी yellow बंद करा दो please. You can take this at the back. इसकी yellow कम कर. Come on.
Yeah, I think this is the best.
उसका भी yellow बंद कर दीजिए.
So Shubhang, if there is history of steroid injections,
Yes.
do you want to space it with the last injection, your TKR surgery?
Well, I would normally wait for 6 weeks, but usually, sometimes the history itself is dubious.
Okay.
And in our patients, they take definitely more time than that. They wait for the injection to act. And if it does not, then they would come for surgery.
Okay.
If the camera can be rotated 90-degree clockwise, that will make
Camera?
understanding
Okay,
the
इसको
whole thing.
rotate कर.
90-degree clockwise.
Image को rotate कर दो. मतलब ये ऐसे vertical कर दो. Flip it to 90 degrees. No,
The
उल्टा.
other way around, clockwise.
Okay. Okay, just turn it that side. Can the other camera focus on the X-ray in the meanwhile? This camera, can you focus on the X-ray? So the idea is we don't do any releases. We just make an entry point just to get your spike in under that medial osteophytes.
That's the difference from the traditional TKR, right?
Yes, yes.
Okay. Are you removing the meniscus?
Yes, I'm removing the meniscus. Focus. So
Femur is almost
Choto.
totally worn out here.
Yes, it
Right?
is.
So
It is.
this is, one of the ideal indications for surgery.
Yeah, so if you look at the X-ray, I first thought of a uni, okay, but she's got a lot of patellofemoral involvement also.
Yeah.
Even though your X-ray does not show much patellofemoral involvement. She's a little tight, but seems a little osteoporotic also because it's very easy. Okay, knife please. Removing the lateral meniscus now.
This is the difference with the other robotic surgery. Like,
Sorry?
we can remove osteophytes in this case, but in other cases like Beko, we don't remove osteophytes before
Give
registration.
me a small lecture, please.
So that is the difference.
Yeah, that difference is there, but there's image-based like Mako, image-based systems. They somehow relax. निकाल दो इसको. Put a retractor there, please, medial side. So we'll be doing a PCL retaining knee. So we just recess the PCL. The ACL is already taken out. That's it. So we're going to put the pins now. Okay, knife please again.
So patella is also worn out.
Yes, patella is gone. That's what. Knife. Did you move the power by any chance? Okay, no problem. Just leave that out, direct output. You stick to focus on the camera. So I like to put the pins here. Earlier we used to put the pins in the mid thigh. Wait.
So this is in the suprapatellar area.
Yes, it's in.
Are there any bony landmarks for this?
No. So you just need to know the implant that you're using. It shouldn't come in the way.
Okay.
And whatever suits you. And it has to be a unicortical purchase. That's it. The moment it hits the other cortex, you will know. So you have to re-register. So we just make the markings.
It's a horizontal pin, meaning you put two pins not
Yes.
in the line of the femur, but sort of line
I have just put it oblique.
oblique. Okay.
Yes. So you can put it vertically like this also, but I don't like to put both the pins there. So earlier I used to put both of them on the medial side. Now this is, then if you're using this, that works when you're doing the subvastus. In the medial parapatellar, you get a lot of strain on the proximal edge of the incision. So just started doing it like this. So we made the surface. Okay, hold tight. Put the pin.
So now you are using the tibial pins.
Yes.
So any landmarks?
So I normally stay 4 finger breadth below the joint line.
And they are vertical in the same line, right?
Yeah, so they are perpendicular to the medial tibial surface. So they are actually anteromedial.
In fact, your proximal pins are acting like a retractor also.
No, this is what I was saying. So if you put the pins medially, they will act as a retractor. This is actually just parallel to your medial quadriceps. The split that you have created is just almost parallel to that in that line.
Okay.
So we just use this spanner and tighten the pins. This is the femur scene. So we had to switch off the robo because of the camera setup. So it will take a minute to just recalibrate. Okay. Give it to me.
In the meantime, can the cameraman show us the placement of the computer system?
Okay. You just
Zoom out and
zoom out, zoom out, zoom out. Okay, so zoom out पूरा और पीछे ले लीजिए और पीछे लीजिए. Yeah, zoom out. Okay. So this is how we are, the foot and head end, the scrub trolley, the implant trolley, okay, and the extra trolley for drills and everything. Perpendicular across is the robo because the camera needs to see and the assistant can just move out. If you focus on this, this is a trolley. It's just a stand. You see this, it's a bowl and it has got a stand. Like in the olden days in medical colleges, you know, our bosses used to wash their hands after rounds. That kind of basin stand this is. So we just put the, we put the robotic drill and everything in that. And whenever we need it, we can slide it in and we can move it out. It's got wheels. Okay, come back here. Okay.
So there was a question from the house.
Adjust karo, kind. Yes, please ask.
So what is the incidence of femoral fractures after this surgery?
Touchwood, we've not seen any so far. And hopefully we don't see any.
Okay.
I think seniors in the house will be able to comment if they've seen any. I don't think there is any femur fracture related to pins. Okay, thoda aur niche karo. Yes, okay, please.
I have fractured 3, bones. When I started robotics in 2016, I've got 2 femoral fractures and 1 tibia fracture. All of the fractures happened about 3 months after the surgery, and they were at the pin site. And retrospectively speaking, that time I used to do a couple of robotic companies. They, especially the Johnson & Johnson release, they say that you put a bicortical pin. And I think it is very dangerous, especially our small patients with osteoporosis and who have BMI which is high. And you put a transcortical pin or bicortical pin, then you will have fractures. Fortunately, after that, I have not fractured, but those 3 patients, and they went home happily. 3 months after getting on chair or commode chair, getting up, all of them, reported same history. So one should be very careful, and that's what I was telling when I was doing it, that the most important thing is that you should be very careful. After you penetrate the first cortex, just let go the cortex, stop.
So
Okay,
I think he rightly mentioned that it has to not be bicortical.
Nibbler. So we are now registering the femur. So if you map the anterior 2/3 of the tibia, it's usually sufficient. You really don't need to go right till the back. The algorithm will calculate. Okay, plant off. Next. Continue. Okay, collect. So that's the deformity. In fact, we've got some hyperextension here, almost 7 degrees of hyperextension. So we will count this as 0 because, the femur bow, 6 to 7 degrees is for the femur bow. And it's correctable like this. Hold it, please. So we are just now giving a valgus strain throughout the range of movement. And then we'll put in the Z retractor and check if it opens out further. So they have been telling us about the spacer which is coming. It's not come so far. So there's a gross lateral laxity, almost 5 to 6 millimeters. That's it. Okay. So what we can do now is, Okay, externally rotate the femur. Just do it there. It's not bright. It's too bright for me. 3 degrees karo. Okay, इधर lateral. A दबाओ. इस तरफ. इस screen में आ जाओ. A दबाओ. A. Anterior eyes. A. Okay. P. Posterior eyes now. P. Okay. Once more. P. Posterior eyes. Yes. नीचे जाओ tibia. Okay. Varus दे दो. Cube दबाना. Cube. Okay. 1 degree varus.
So for the benefit of audience, anything above that line means laxity. Anything below
Okay.
that
ऊपर.
is exercise.
Okay.
It must have been
1 degree varus.
explained in previous talks, but just to make it simple, you can see that
Okay. So
all
I
that is
दबा
the
दो.
orange is the medial side,
I.
the
I-
wallet is the
I-
lateral side.
I-
So clearly the
Take it down,
extension
take it
space is
down.
more. So he's trying to
Okay.
reduce
Tibia पे.
the extension
दबा दो.
space here.
Okay. फिर से ऊपर जाओ. ऊपर. No. I वापस. Go to femur. Inferior eyes further. I. Okay.
So what he's
Okay.
doing is basically exploiting 6
So-
degrees of freedom that we have.
Yes. So most of the manipulation will be done on the femur. Cube on. A. Okay. So that is it. Because she's quite lax, we are going to take this as our final thing. Now in the flexion, we can externally rotate 4, make it 4 degrees. Okay. Right. Go that side. Press A once. A. एक बार और. Okay. That's my final balancing. If you see on the medial side, the orange, which is medial side, is just below the line in both flexion and extension. And the lateral side, in extension, it's just above. And in flexion, it's opening up about 3.6. Now, this is what you usually desire. You cannot make the flexion in lateral side in flexion as tight as the extension, because then, your normal knee has got a little lift off there on the lateral side. Next. Next, right? So as Dr. Vaidya sir was saying, I don't use the checkpoints because they tend to come out in osteoporotic patients. So we take it from here. Okay, but section level. Irrigation on karo. Yes. Yes, okay. Karo. Okay. So very little bone is to be removed here. Normally you would see that butterfly, medial, lateral and the joint on top. But because we distalized our femur here to take care of the hyperextension.
While you're at it, there's a question. How much of laxity would you accept in flexion on the lateral side?
I would accept up to 4 millimeters. This was 3.6. Now see, it also depends on the force that you have used to get. I use quite a lot of force actually. So you have used to get the. So for the benefit of the audience, there's the green is the front of the robotic handpiece and blue is the back. So you just have to test your Xbox skills, go to that hole, mark it, and then match it. That's it.
Dr. Shubhang,
Yes.
this is Dilbans.
Yes, Dilbans.
My concern is that you're taking the fixed point on the trackers.
Yes.
So the sole purpose of having that fixed point is to cross-check and confirm in the middle of the surgery that nothing has gone wrong with the trackers.
Yes.
So if you take it on a tracker and your tracker pin is loose, then you lose the opportunity to cross-check.
Yeah, you're absolutely right that the checkpoint will give you 2 reference points, right? So between the tracker and the checkpoint, you can have a comparison if it has moved or not. So the company guys will tell you that this is how it is, but it really doesn't matter because it's better not to lose the checkpoint. And then intraoperative registration, you have to sometimes just go back and do intraoperative registration. I think you take that. Can you all see clearly there?
Actually, what you said is absolutely right. The sole purpose of putting this, checkpoint is that if something moves, then you can readjust the trackers. But the problem was these guys used to give the pins, which was fixed in the cancellous bone. And while burring, they used to get loose. So वो lose होता है तो then you have nothing to actually do. So generally, what I take that laser mask, or I take that no, you have that white.
Lap hammer, please. Curved osteotome. Okay, flex the knee. It's not curved. Feels like a straight osteotome. It's done. Nibbler. That's okay. We don't need it. So one thing I like to do here is just come out burr then. See, when you use the hybrid, like we did a distal burr. No, yeah. Okay. Everything okay there? Leave it. So can you see this? So go to refine once, please, quickly. Image niche karna. Image niche karna. Bas, that's it. So now see if you just okay. So what the saw did was actually leave some bone behind. Okay, here. So we are just going to burr all kar do. पूरा दबाओ please. Okay, that's it. So this takes care of when you're doing conventional and you get that femur trial onto this and you get a very nice tight snug fit. It's usually because your saw has splayed. You have a narrow. So the Robo gave us the size 4 narrow. We just went by that completely. Yes, hold it. Tracker. So we are preparing the box now. Please hold the femur. Yes. Flap hammer. Okay. Flex the knee. Lateral spike, please. Wait. No problem. So you leave the medial side. This guy will hold it like this once. We'll just remove that osteophyte. So that much release, just top is needed so that the saw doesn't damage anything. Now here we have the option of just going for burr all. So you can leave this. Leave this. Let him go out, please. Yes. So you'll be shown an all burr later today. But what we'll do is we'll just make the mark. Okay, so that's you match the white. Now saw please. We'll take a tentative cut and remove this extra sclerotic bone in the center. Nibbler. And this decreases the load on the burr saves a little time and saves the burr. Divya has not seen. Change, put the camera this way. Wait. Okay, that's good.
To make a choice, PR and PS. Is that the question? Shubhang, any preference why you did PS, or is it a routine habit, or anything on the planning screen dictates that?
Sorry, I can follow that. Can you say that again?
Are you a routine PS surgeon is the question.
Yes, I am a routine PS surgeon.
Okay. So he's a routine PS surgeon, but many of us will decide based on the planning screen. For example, for me, I started as a PS surgeon, then I became completely CR surgeon, and since robotic came, I'm like 70-30 today. And what dictates is the flexion gaps and the tightness. So if I feel that the flexion gap, so all the screen that you are seeing, if the flexion is too tight compared to the extension, I would not hesitate to convert it into PS. Because I believe that PCL is also a contributing factor. So either you resect more bone, give more slope. So a CR surgeon can do all cases CR. There's no doubt about it that you can get away with any kind of deformity by doing CR. But you are, in effect, when you are doing it, you are juggling with your bone cuts. So you increase your slope, use an osteotome to release PCL, take more tibia, or just resect PCL and get along with the surgery by what is dictated on the screen. Now you have more objectivity. An experienced surgeon will do with his experience, but with the objectivity on planning scene, you can decide based on your planning scene whether you want a CR or a PS.
Yeah, that's good.
Okay. PCL is not contracted that much.
So,
do you feel there is any advantage of a CR over a PSC?
No. So again, I will not be dictated by what has happened before the surgery. I will be dictated what has happened after I have made an incision, made some primary relief, and then put it through the range of stress range of motion. It's that screen that tells me, because everything changes once you have made the incision, you have done some primary relief. And I'll talk it in when I talk about that. That for me, the surgery is 3-stage. Primary release, juggling with bone cuts, and fine-tuning the soft tissue.
Come.
So the second stage determines what I'm going to do with the choice of implant.
No, TBL.
So obviously, when you have got a knee which has no flexion deformity, your grafts will be very smooth. There will not be much mismatch between extension and flexion gap. And these will be the people who will obviously be more amenable to CR. But I will make that as a second check when I have the planning screen in front of me.
Yeah, but you know, it's a debate which has been there forever. It makes sense to use robotics to decide, yes. But CR versus PS literature has not been able to prove one is better than the other till now.
Yeah, I agree. And for me, the CR-PS debate is only about whether you want to remove more bone. So if someone has got femur less than 4, I'm a bit hesitant to use a PS knee.
Yes.
Only for that sole purpose.
Okay.
If you look at the long-term results, the PS people have slightly more flexion compared to the CR. So as a very broad, large study, that's the only difference that has been found. But intuitively, if you've got a very small femur and you're removing a box, then you are putting at some stage, because all the things will not come in registry. Or they will not be directly attributed to the fact that you have used a PS. For example, someone has fractured a medial condyle. It will not be reported as a complication of PS, but a complication of intra-op complication of the surgery. So there's no way of actually reporting what is happening. So there is some thing that a surgeon has to do intuitively. And I think that's where we come in. Less than 4 femurs, try to be conservative in terms of bone stock observation.
Yes. So we are just showing you here, we planned a 2-degree varus. I've just put the spacer block, no trial implant right now.
So
and we
what's the size of the spacer you are using?
This is the standard 9 millimeters.
Okay.
Spreader. I mean, please. Yes. So there's a part of the meniscus which was left in.
Shubhang, any comments on that? Do you use multi-radius implants? Anyone who's using it? Krishna? Implant, femur. Yeah, but single radius? Yeah. Yeah. Anyone
This
using single radius?
Smith and nephews, not single radius is striker.
That's what I'm saying.
That-
Anyone using single radius? Yeah.
The single radius was actually defined by people who were like professing the kinematic alignment, because their theory is that the knee evolves around a single radius. And the multi-radius was designed by the people who did not believe in kinematic alignment.
Krishna, you are doing kinematic with multi-radius, I believe. Correct?
I think we are cheating the basic concept of kinematics.
I think alignments are going to get demystified soon in the day, first half of the day. You know, because, okay. So all these patients are patients, they get adductor canal block. So like what Dr. Vaibhav did, we are also doing a study comparing adductor canal block versus surgeon administered block. So
Actually, for pain control, we have recently published in journals that if you give the preemptive analgesia, it works very well. So along with adductor canal block, all my patients, they'll get pregabalin, they will get analgesic starting 1 day prior. And these patients really, their forgotten knee score and everything is much better if you have to give that. So you can give that. Only problem sometimes is that pregabalin can give some giddiness and things like that to the patient. But 1 day prior, you can start it.
Yeah, so we also do that gabapentin and eucoxia in the morning. So this, I'm a almost 100% patella person. So this knee is 20, this patella is 22 millimeters. So you've got the patella button thickness of 8 and you leave behind 14. Should not go beyond the protect the femur. Wait. ऊपर उठा. Yes. Okay. Kori ras. Okay. Vernier caliper again. So just want to show camera. Can you guys see this? So we've left behind, we've taken out actually 7 millimeters. Focus on this, yes. So this is 15 millimeters of patella left behind. Okay. Okay. 29. This is a 29 patella jig, which looks like a crane, but works well. So okay. This way. Okay. Take final implants. Decrease the temperature to 16. That's it. Support the knee, please. Niche se. Support the niche se, yes. Okay, that looks good. Nibbler. Small nibbler for patella. This is not small nibbler for patella. Yeah, we are good. Okay. Spreader. Wash. Okay. More, please. Okay, start mixing.
If I anticipate that my surgical time will be more than 45 minutes, I don't use tourniquet. If it's a straightforward case, I use tourniquet only for the convenience of it, less blood. So I believe that if you're finishing a surgery in less than 45 minutes, it's okay to use tourniquet and it makes your life easier. But if someone is obese, short females where I'm going to take more time, I don't prefer tourniquet. Of course, there are other contraindication to using tourniquet, that apart. In a routine practice, that's the same. Anyone else?
Even if I do not use the tourniquet, I do use it for cementing.
Okay.
Disposable tourniquet. I
Fresh
think.
mop here, please. Remove that.
So the short obese patient using that. But
Hold,
always
please hold the femur. Tibia femur
My
spacer.
patient would have pain in the thighs more than the pain in the knees if your surgical tourniquet time is more. So just to avoid that, I think long term it doesn't make difference.
Spike.
actually for thigh pain, I've started giving as a protocol matrix therapy to all my patients. Matrix. It's like an interferential therapy with a probe. So second day they get matrix therapy by default. Physiotherapists they'll start it. So that thigh pain, which is actually nagging tourniquet pain, it's almost now reduced to nothing.
Tracker.
Great.
Not hitting the
Anyone else
tracker.
has experience with that therapy? So it's like a look. It's like an interference therapy, local ultrasound. What is it?
Sorry, what's that?
Something like ultrasound.
So this is a lesion implant.
So you use the Palacos with antibiotics?
Yes.
Okay.
I don't use the antibiotic routinely.
What's the size of the tibia?
3.
Okay.
So there is you can have a mismatch of up to 2 in this Smith and Nephew lesion system between the femur and the tibia. So our femur was 4 narrow. Punch, I need punch. Tibial punch. Aram se. Okay. McDonald. If you see, the cortex is very flimsy here, anterior cortex, but we are good. Okay, come on, out. Lift, retract medially, please. एक सिर्फ बाहर की तरफ से, please.
The coverage is excellent.
Yes. So that's the advantage with robotic. The coverage is always excellent. So we've used the 4 narrow femur. So we keep standard and narrow both on table. Okay. Lift laterally. Locker. I just like to hammer it once here. Okay, looks good. Okay, just remove this. Yeah. Come on. So I'm going to show you the range of movement quickly before I put the patellar clamp. Okay. Sometimes it gets a little difficult with the clamp on. You can't remove it, otherwise the patella will come off. We still have cement time. So we'll show you the range of movement. Wait. Can you come out? So without the patella, okay, this is what we have achieved. On pressure, it goes on to extension 5. So, okay. So it's just above. Okay, on all. This is it. Any comments?
Excellent range. Little opening on the lateral side in flexion, which is good, perhaps, because one of the recent studies have shown the patient satisfaction is best who have lateral opening in flexion.
Yes.
So I think it's looking very nice.
Yeah, this is what I aim at actually. So even, it's always good. And here, in fact, we have rotated our femur to 4 degrees. And still we've got this. We could have gone to 5 also, but then we have to anteriorize the femur to avoid notching.
So do you always take the range of motion while the cement is setting, or you just?
No, I do it after this, but I do it now at this point because sometimes if the cement is thick anywhere, you can't see it otherwise. Okay, that's it. So, any question?
Good. No, I think looks very good. A warm round of applause for you for such a brilliant surgery.
Thank you, everyone.
Any questions from the floor? Any questions? No, I think they are all mesmerized by the surgery. It's looking very good. Both you and Robot did very well.
Okay, thank you, and we'll join you in the hall soon.
Thank you.
Cut the feet. Sound.
Thanks a lot, Shubhang sir, for such a eloquent presentation of your live surgery. May I request the moderators to remain on the dais, please. Can I request Dr. Ramesh San to honor or give a token of love to our moderators and have a nice pick? Meanwhile, I will request the next session's chairpersons, Dr. Dalveer Chauhan, Dr. Ranjan Beg, Dr. Davinder Lal, Dr. Inderpreet Singh, and Dr. Vinder Puri to be ready for coming on the dais, sir. I thank the moderators for giving such a nice moderation for this session. Thanks a lot, sir. For the next session, please, NHS escort team, please escort the next chairpersons on the dais, please. Dr. Dalveer Chauhan, Dr. Rajan Vig, Dr. Davinder Lal, can we have the next chairpersons on the dais, please? We have Dr. Dalveer Chauhan, Dr. Rajan Vig, Dr. Devinder Lal in the gathering, in the hall? Or else we can just change the chairpersons. I think Dr. Ajit Kumar, you can be there, sir. Dr. Ravi Gupta, can you just continue with the chair as a chairperson? Dr. Prakash Dhillon can also join. I think the last moderators can continue because, yeah. So, as a start, we have got some special requests from Dr. Narendra Vaidya to be on the dais first as a speaker because of that his flight is leaving little early. Dr. Lal is here, I think, in the gathering. Please. So, first talk is on ensuring functional alignment in robotic total knee replacement by Dr. Narendra Vaidya.
I think alignment philosophy is one topic which everybody is talking about, and there is a unique approach which I think is very practical, and I'll be talking on that. So I think now with robotics, mainly the alignment is one thing which will make our patients happy. So like in this picture, the biomechanics of all the bicycles is different. Our knees are also different. So we should have more personalized alignment rather than going with some philosophy like kinematic, restricted kinematic. It is really, Krishna is there. He talks on kinematic and restricted kinematic, but I think it's pretty confusing. APAC, CPAC classification, which was developed, I think there are limitations to this. Because this is just by name itself, it says coronal plane alignment. No, coronal plane is not the only thing. Knee is a three-dimensional structure. They are not taking sagittal alignment at all in the consideration. Number two, it's a bony alignment. You are not taking cartilage also. So people who are doing non-CT based robotic, I think only CT based robotic, this classification works. But CPAC, I think, has a lot of limitation. If you have a typical patient in my practice will be having 20 degrees varus, medial tibial defect. So where are you going to find out the joint line? Where is the apex? So it is all going to be very hypothetical where my technician who is 10th grade pass is going to tell me the APEC class, CPAC classification. So I think it has a limitation, and it's of, it has been driven by certain companies, but I think it is not there. Now, today, there are a lot of philosophies. Mechanical, we have all been doing since last many years. So we were getting mechanical alignment. So with traditional, conventional instrument, you get a mechanical alignment. Anatomical alignment was to achieve joint line obliquity while maintaining the neutral mechanical axis. Kinematic achieves a pre-arthritic joint line. Now, a pre-arthritic joint line, how are you going to determine in a deformed knee is a question which I have not actually been able to solve because of defects. Restricted kinematic, within 3 degrees, you have to adjust it. So ultimately, we are like this. All are confused. So many conferences I have attended. People at the end of the day, they say that I am more confused. What is kinematic? What is pre-kinematic or alignment? So I think we should, get out of it. So functional is a smart thing. So what functional means? A varus knee you keep slightly in varus, valgus knee in slight valgus. This is my principle, and that is what within limits I am doing that. So it looks very smart and sleek. So there is a difference. So I am going to this. So kinematic alignment, it was based on bony landmark. It was not taking cartilage into consideration. It doesn't take soft tissue envelope into consideration, and mainly aims for the coronal plane alignment. So there are limitations to this. Functional alignment takes into consideration mainly the ligament and the soft tissue envelope profile, because we are doing stress ROM with various robotic systems. Now there are a lot of tensioners also coming. So mainly my attention while doing it is soft tissues. Bony cuts are going to be accurate with robotics, but soft tissue envelope, if you address it, the patients are happier and patients are more functional. It considers cartilage wear because we are mapping it actually, and you don't require CT scans for that.
It's a novel philosophy. I think many of my friends in this hall, they are doing what we are doing. They're going to keep a Vargas, and I don't know how many of us are really using CPAC classification and doing that. So there are limits to this. My combined Varus is 5 degrees. Femur, tibia never more than 2 degrees. In valgus knee, I don't cross more than 2 degrees. Valgus is given in femur, tibia always neutral. Flexion of the femur, you can go up to 6-7 degrees also, because that will adjust your mid flexion laxity if at all it is there. And rotation, I've gone up to 7 degrees also. To close the lateral gap or open it, you can go from 0 degrees to 7 degrees. So some cases here. So you do all this mapping and everything. No, I'll not go for this thing. So it was a 7 degrees varus. From there, you were given 1 degrees of combined, 2 degrees of combined varus with completely, you can see a balanced knee. I was talking to some friends that in some systems, you take the tibia first, then you get this tensioner, which is a very good tool, because sometimes with a G retractor, you may not be able to apply equal force on the median and lateral type. Then this tensioner is put, which will which will give equal pressure throughout the range of movement. So I don't have to do stress. Just take the knee through range of movement. So it will map your ligament laxity on both the sides, and then you just do the adjustments. So in a varus knee, whatever is their general observation, I have not published any data on that. But generally, if you have a varus, we would give 1 degree of varus. The correction of deformity is up to 3 degrees. So if you have a 15 degrees of varus knee, then adjusting combined varus of tibia and femur without any soft tissue release, if you give 5 degrees, then you can correct up to 15 to 17 degrees of varus. That is the observation. I have not published any data. So I think we can all do a sort of a combined study based on this particular thing. So you get absolute perfect balancing. You can see the gaps are absolutely equal. And then you take this femoral cuts after doing tibia. So most of the knees which I am doing now with Willis, I am doing tibia first, put this tensor inside, tensioner, and then take your different cuts. So it's very simple thing. You don't have to do any releases generally for this. And you get absolutely equal gaps. X-ray. Another case, again a varus knee, where something similar we have done. So stress X-rays, then you take your tibia first, and then have equal balancing. So functional alignment means that you keep your varus knee into slight varus, because these are very happy patients. If you overcorrect them, they may not be happy. You can check the cuts with the sensor, and this is the final alignment. There are some literature which shows that kinematic alignment generally fails to achieve balancing in 50% of varus is this thing. And I think the reasons are the same, which I have told earlier. Secondly, the bone cutting also is very less. So I think all these alignment philosophies are a bit confusing. Very simple, this thing message is that varus knee keep in slight varus, valgus knee not more than 2 degrees varus, valgus. So that's a take home. And again, like yesterday, these are dates. Please book it. We'll be having 50th anniversary of Lokmanya Hospital, and with that, we're planning more than 25 live surgeries. Thank you very much.
Thank you, Dr. Vaidya. That was an excellent presentation that speaks of the experience and the robotics club together to achieve the functional alignment. I think when the knee replacement started, only senior people wanted to do it. Now everyone is doing. So they are actually doing more of a functional alignment. So thank you very much. So now, are there any questions from the house? Some quick question or comments? Dr. Rajput?
Want to release medial side. That's been one of the first. I don't want to touch it. So that's whatever reason that is.
I saw some people so extreme dynamics for extreme control to have done. take a scanogram.
Dr. Vaidya.
But on knee ka X-ray ले लो, वो अच्छा दिखता है एकदम.
Dr. Vaidya, can you answer this question very straight? Do you want to touch the MCL or not? That's his question.
I think it should be open.
So that's the answer, right? So there can be difference of opinion, right? Yeah. Yeah. Yeah, that's the concept of robotics. That's why I said experience and robotics.
Said no, then your dissertation was not valid. So अभी क्या होता है कि आपको MCL करना ही नहीं करना. If you do degrees of alignment, maybe it might not rotate the thing. So your flexion can also increase. Now, still if it is not balanced, then you have got a tool now. You can objectively measure it. So ask adequate. आपका adequate अलग है, मेरा adequate अलग है, कृष्णा का अलग है, राकेश का अलग है. तो ये adequate को मतलब नहीं. Now with robotic, you can measure it. If you release it slightly, measure that. Go back and see. So you have got a tool now. Objectively measure that.
I think he has answered it very well, but there can be differences of opinion. Only then we move ahead in research. So we go to the next speaker. Thank you, sir. Dr. Hariom Aggarwal. Next speaker.
So, respected chairperson, my senior fellow colleagues, friends, and dear delegates, I bring greetings from royal city of Patiala, and today I am invited with the blessing from Tikpra Malini Mata from Devi Tala Mandir, Jalandhar. So first of all, I congratulate Dr. Shubhang, Aggarwal and his team for such a wonderful conference on the knee replacement. I am going to speak on the very basics about the knee replacement. I think this is the essence that every patient wants his normal looking knee after the surgery. Patient should be able to walk pain-free and in the normal pre-arthritic position as it was before the onset of the arthritis. And at the end of that, patient as well as surgeon both feel satisfied and contented. So successful total knee replacement is based on the restoration of the knee to the normal alignment. Aim of the total knee arthroplasty is to achieve excellent alignment of the femoral, tibia and the patellar component with ultimate restoration of the patient's lower extremity to the neutral position. The proper alignment of the knee is one of the most important factors in determining the long-term outcome after knee replacement. Proper limb alignment decreases the mechanical and the shear stresses on the bearing surface and balances the forces transmitted through the soft tissue envelope. And if the components are not properly aligned, it may lead to the component loosening. And the kinematic alignment is a customized method of positioning a knee replacement with the aim of restoring the native pre-arthritic joint lines and the rotational axis of a patient's knee. The aim of the kinetic alignment is to restore the pre-arthritic alignment of the knee, joint orientation, and all three kinematic axes of the native knee. There are three alignment axes of the native knee. They are the vertical axis, mechanical axis, and the anatomical axis. Vertical axis is the line drawn from the symphysis pubis, and the mechanical axis is the line drawn from the center of the head to the center of the ankle joint, and it most of the time passes medial to the tibial spine. And the anatomical axis is the intermedullary canal of the femur and tibia. Anatomical axis of the femur and tibia, they are at angle to each other, but mechanical axis and the anatomical axis of tibia, they commonly correspond exactly with one another. The angle between the anatomical axis of the femur and tibia is called the femorotibial angle, and the normal knee joint is 3-degree varus as compared to the mechanical axis. So these are the diagrammatic representation of the anatomical and the mechanical axis. So with the mechanical alignment, we aim to position both the femoral and the tibial component perpendicular to the mechanical axis of each bone. This allowed to obtain hip, knee, ankle angle of the limb of 180 degree, considered as the neutral under the static weight bearing condition. And in addition to these three axes, there are three kinematic alignment axes. And these three functional kinematic axes, they govern the movements of the patella and the tibia with respect to the femur in kinematically aligned knee replacement. And what are these three functional kinematic axes? These are the transverse transapicondylar axis, transverse axis in the femur, and the longitudinal axis in the tibia. And transverse transapicondylar axis is the primary axis. It passes through the center of the circle, which fits to the articular surface of the femoral condyle from 10 to 160 degree, and tibia flexes and extends around this transverse transapicondylar axis. There is the second transverse axis, which is parallel to the first axis, but it is proximal and the anterior to the first axis. And the patella flexes and extends around this axis. And there is a third axis, which is known as the longitudinal axis. Tibia internally and externally rotate around this third longitudinal axis. And so our main goal of the kinematic alignment is to align the second axis, which is transverse axis of the femoral component, with the first axis, that is the primary transverse axis of the femur, around which the tibia flexes and extends. So there are various techniques which are utilized to attain this normal knee alignment. The ultimate primary goal of all alignment techniques is to achieve the neutral alignment of the knee joint. And the various techniques which are utilized to attain this goal are mid resection, gap balancing technique, computer navigation, patient-specific instrumentation, and the robotic assisted surgery. So ultimately, all these newer techniques, they help the surgeon to achieve the neutral mechanical axis of the knee joint. And this is all diagrammatic representation of the resection technique, gap balancing, which we all are doing while carrying out this procedure. These are all another diagrammatic representations of the various newer techniques. In the caliper verification, we use the manual instruments with the measurements to guide the bone cuts, and this allowed intraoperative assessment and how much bone is to cut. And in the patient-specific instrumentation, MRI and the CT of the patient's knee, they are carried out. Then the 3D image of the knee is prepared to plan for the surgery, and this technique is used with the caliper verification intraoperatively. Another one, computer-assisted surgery or the robotic assisted surgery, they have been shown to improve the accuracy and precision of the component alignment. So ultimately, all these newer techniques, they help the surgeon to achieve the neutral mechanical axis of the knee joint. While evaluating the post-operative X-ray of TKR, we should look about the overhang, about the joint line, whether they have been properly maintained or not, whether there is a medial or the lateral gap, whether they have been properly balanced, whether both femoral and the tibial components, they are perpendicular to the mechanical axis of each bone or not. So in conclusion, the primary goal of all alignments technique is to achieve the neutral alignment of the knee. Various precise surgical techniques, they are utilized to attain this goal, and the surgical total knee arthroplasty is based on the restoration of the knee to the native pre-arthritic alignment of the patient's knee, so that patient should be able to walk and carry out his all needs of the daily living with the pre-aesthetic stage. Thank you very much for your kind attention.
Thank you very much, Dr. Hariom Aggarwal, for wonderful talk. Any question?
So these are all simple basics that what is the essence of the knee replacement at the end.
Thank you.
Thank you.
Now I invite Dr. Narendra Vaidya again for complex primary total knee replacement made easy with robotics.
So I'm going to show some cases which I think without robotics would have been very, very difficult. It's not a. Sorry for that. Yeah. So I'll directly go to the cases rather than any theoretical discussion. So there are some tricky situations where I think navigation, robotics, that has got 100% value. So the first case was a femoral extraarticular malunited fracture. You can see that the fracture is united in varus as well as in extension. And in these scenarios, traditional TKR would have been really, really very tricky, and we probably would have required osteotomy, corrective osteotomy here. You can't go in the intermedullary thing also. So this was a clinical presentation. So with distorted axis is there, you have to do a lot of pre-operative planning, and then single stage intra-articular correction is for the extra-articular deformity is planned in this. So on table, the knee looked like this. There was a varus and in extension also. So we had an extra articular deformity. Range of movement was restricted because the quadriceps were adherent. I had to do a snip in quadriceps snip in this, and referencing was not possible because of distorted anatomy, and sizing also was due to deformity. It was very much difficult with the traditional instruments. This was an intraoperative picture. I had to do a snip, as I told you. Then you put your trackers to your mapping and everything. Take the center of the hip, take the range of movement, and define the axis. So robotics makes it very easy. So after mapping something, it looked like this. And once I started doing that, I'll spend some time on this side. If you see here, this is how the robotic image looked like. And it was really very difficult because the implant is actually sitting somewhere else and the bone preparation here. So sometimes you have to use your brain. The robot is not able to interpret these deformities. So initially I had to I was also worried that implant, where I am putting this implant. But ultimately where I should do the burring also. So it was a very peculiar thing. This was my first extra-articular case with the Navy or this robot. But after that, then I decided to burr whatever position that robot was showing, and then we cleared all this surface, burred it, and checked the cuts. They were all absolutely okay. Then the TBL cut was as routine. We checked the cut, and this was the final X-ray. Now final alignment, this thing where now the implant is looking absolutely in place, and you have a very good balancing also here. So extra-articular deformity, sometimes the presentation with robot can be very, very weird because it doesn't understand the deformity. When I was mapping the posterior condyle, that time it was showing anterior when mapping was going on because the femur was in extension. So robot was unable to interpret it. I don't know if I am really clear in my this thing, but yeah, femur was like this. So when you are painting here, it was looking on the robot that I am painting the anterior cortex. So it was very confusing for that time, and we really spent some time where I am going for this. But then ultimately, I proceeded with that, and then everything went on well. But the implant, while trialing, was looking somewhere else. But after doing trialing and after this thing, I could get a absolutely perfect gap, and that was a real learning. This was my preparation. I did a all burr in this case, and this was my final alignment on table.
where you can, the extension also is corrected, and there is no flexion deformity. And this was my final X-ray. So you can see that here, intra-articular correction of varus as well as extension we have done. There is slight overhang of the femur here, but the patient doesn't have any clinical problems. So very peculiar case, and these scenarios sometimes it's very difficult to interpret what robot is actually showing you on screen also. Another case, this is the extra-articular deformity in tibia. Now, when you look at it, it looks very, very simple, but the varus is in the joint also, and varus is there at the malunited tibia also. So it was a combined varus of 23 degrees in the tibia. So 16 degrees was extra-articular and rest was 9 degrees was intra-articular deformity. Now you have to correct it intra-articularly, and robot enables you to correct this. Now what you should always do is that you take this axis, and this line, if it is going out, then probably intra-articular correction is not possible. And then you have to do osteotomy if required. But till date, I think I have not encountered many situations where I have to do an extra-articular correction for an extra-articular deformity. And this was like earlier talk, this was a sagittal deformity also. 19 degrees deformity was there at the fracture site. So you have a, three-dimensional deformity. It's not a single dimensional, like you see the AP X-ray and say that is a varus knee. So you have this sagittal plane problem also, which you have to correct intra-articularly. So I think we'll skip this. So all these routine, these things were corrected. This was my pre-operative, pre-release graph. So I kept combined varus up to 5 degrees, like I told you, 2 degrees in tibia, rest in femur, and then did all this burr. And this is how we got the cuts absolutely spot on. So this was my pre-operative planning, where you can see the medial side was really tight. With 5 degrees of combined varus, I could get, without any medial release, I could get a complete balancing. And the correction was in all 3 planes. So that is the beauty of technology. And this was a final X-ray. Now we planned for 3 degree, I got 3.6 degrees. So whatever you plan, you can execute it with the robotic technology. That is very important. Another case where there is a mid-shaft deformity. So normally you would have required to remove this, and then maybe a osteotomy here, and again non-union like problems would have been there. So you keep the plate inside. Sometimes you have to remove some distal screws, but we did a CR knee in this particular case. Again, the same things, you do all this mapping and everything. So you get a absolutely well-balanced knee. So this was my final alignment post-operatively, and whatever alignment was there, we kept the plate also and the CR knee. And whatever you, plan, you get it. Another interesting case where you had an intra-articular malunited condylar fracture, severe deformity here, and a windswept deformity, valgus and varus. Bilateral we did with robotics, and whatever without much release, you can actually get absolutely perfect balancing like you see here. So I think soft tissues are being objectively released with this technology. Some intraoperative pictures, you can see the condyle, which was absolutely almost not there here. So in such cases, you may have to keep your revision implants also, because you may require augments or wages or something like that for the defects. And this was the final X-ray. Another case, I think time is running out, so I'll just skip it. Another windswept deformity. So it makes your life easy. Like somebody was mentioning earlier, the technology has actually changed the scenario in one way that any one of us doing surgery, ultimately, you can get a uniform result. So it removes the feel factor of it. Earlier, we were only doing with our feel. So now you have an objective analysis where you can get complete balancing. So I think correction of extra-articular deformities is made very easy with robotic technology. So it's a best option for all these complex cases, and it helps us to execute the plan, and especially the robotics play a lot of role in complex cases. Thank you.
Were there any questions? Yeah. Dr. Pandher has a question.
Yeah.
Okay.
Dr. Vaidya, how many times you have done the extra-articular corrections in the extra-articular deformity? Say, for example, the osteotomy study states more than 30 days. You do the osteotomy and then you Correct.
If the simple thing is that you take a long leg X-ray or a complete tibia X-ray, for example, have the axis. If the axis is going outside the articular margin, then you may require to do a extra articular osteotomy. So if you map the tibia and the deformity, the axis is going outside this thing, then intra-articular correction may be very difficult, because then your bony resection becomes too much and your ligaments will get compromised. So in those scenarios, you will have to do a extra-articular osteotomy.
And have you encountered anything that, when you are, cutting the tibia, and after that you have decided, no, the correction is not so good, you are not getting the alignment properly, you have, done the extra-articular osteotomy, then your cut will change in the proximal. Then what you do?
Actually, fortunately, I have not encountered that scenario, but it's a complex scenario. You have already committed a cut and then you have to again do it. Probably what I'll do is I'll fall back to my traditional techniques and put in a stem and correct it or something like that. But practically, I have not encountered that scenario, and pre-operative planning in such cases is very important. So you anticipate this, and then before touching the patient itself, I think one should anticipate these problems. So intraoperatively, you don't have surprises.
So very nice talk. My concern is that as in your very first case, the burring was somewhere else and the implant was somewhere else. Do you think the CT-based systems are better placed in such scenarios because they have the CT of the whole limb?
Correct. I think CT-based technology definitely theoretically can be good, but here I did not have a problem in the case. I was not doing burring somewhere else. The first picture only surprised me. Then when I used the probe and before burring, that time I was on the bone. Okay, but the picture which was showing that femur somewhere else and my bone somewhere else was the first surprise. So don't get jittered by that, or don't get panicky. Your burr will act where it is supposed to act. So you are mapped, it will come. वो implant position क्या दिखा रहा है देखो मत उसको.
Your message will be that if the implant is
I don't think there will be any difference between CT-based system, because ultimately in execution, I did not have that first image itself only surprised me, because before doing this thing, my implant was somewhere laterally because the femur was varus and in extension. But when I started burring, you put the probe, it was on the bone. So I was not having any problem, because wherever you are mapping, it is mapping actual bone. So you will not burr at a wrong position.
I understand that, but in general practice, when we get something so bizarre on the screens, we switch back to manual or cross-check the things. But
yeah, that's a message. I think
it is showing you cut somewhere else. You are showing your implant somewhere else.
Yeah.
So how good can you trust the alignment and rest of the things that
I'll trust the robot
in the planning?
See, basically,
I think we can cut short the discussion. The question is very crisp, one-line answer, that he's saying that the computer is showing that the implant is going out, half of it. And finally, you put the implant where it should be.
Correct.
But the cuts were not like that. Is it the question? So how will it fit at that place?
No, because the implant, say, especially the Cori or Navio system, you will see two types of markings when you map it. One is a bright yellow, which you have actually mapped, and second is a faint yellow, which the computer has projected. So your hip center, the computer calculates, your knee you have mapped. Now when you are burring, that will burr only the mapped area. Implant position is a hypothetical position, which actually the computer is imagining it will be there. Okay, the implant आपका burring होगा, वो जहाँ map किया है वही burring होगा. So don't worry about that image. That was a message. And when I implanted, it came on the site without doing anything.
So you don't need to revise burring.
No. Wherever you have mapped, the cut will happen only that place.
I think it's a very valid point, because what computer mapping done, and that's the difference between image and image-free system. It's not about what it plans.
I think he has answered it well.
Yeah. So the key trick here is to mark special points. Whenever you have a difficult case, just to cross-check, you can mark medial condyle, lateral condyle, anterior cortex. So if your femur, it should not go out of your special point. So for example, if I have marked in orange, because what that image projection is a algorithm generated image. But what the real image is, what the special points are there. For example, if his implant was outside the medial epicondyle or the lateral epicondyle, which has been marked as special point, then you discard that. Then that means something is.
Sir, I think it has been clarified. Any other question? Because let's have more questions.
If you use
deformity. Sometimes you see that the real key is coming out of the
Yeah,
bone.
yeah. And the special points made a role.
Yeah, yeah.
If you have to use the special points. That's the point I'm trying
Yeah,
to
that's good. Yeah, yeah. Any other question from anybody? Any question? So I have the last question. Since the literature as on today is saying there is no difference, significant difference between robotic and the traditional ones. But you know, the cases which we saw, excellent cases. It appears that the robotic is the only way to go for them. So are there any studies comparing such cases with the traditional system?
There are not studies coming up. There are many, there is one study where people are saying there is no. But there are many studies which have shown that the performance is better, the short-term results are better, accuracy is better. So I think the study is not completely out. We have to wait for 15 years.
Okay, still there is another way of doing it.
But initial results are definitely there. It has opened a new sort of option for surgery.
Yes.
For alignment philosophy. So the traditionally you can't do kinematic, functional, whatever. So I think this opened up a door where we can, our patients were not all happy. So probably with this,
Since you have a large series, I will request you to publish from India the comparison. Yeah, yeah.
We have published on
So it may change the thinking, right?
With 5 years follow, 100 cases, 5 years follow. That's the largest. And we had no demonstration first 5 years because it didn't have to happen. It happens in first year, maximum, except for infective. So you need 100% like robotic is the way for it. Because it's technically demanding surgery, and every time you get a it is absolutely reproducible, absolutely perfect. About TPR, yes, there are alignment flows. I think way forward we'll know the answer. But we have published that. Second paper we published was restoration of joint pain. I was with traditional things to proximalize the femur like millimeters. That is a published, very documented fact. With robotics, the joint pain restoration and the patellofemoral is better. So that paper also is published. So last 4 years, I think 5 papers were presented in this classes. But I'll take that in.
Thank you, sir. Thank you. I think a big applause for Dr. Vaidya. And who's our next speaker?
Sir, in fact, Dr. Narendra Vaidya is leaving. So may I request Dr. Ravi Gupta to just give the honor to Dr. Narendra Vaidya as a token of love from our side.
Dr. Dilbas Pandir, please come on the dais. Managing PCL in CRT care.
Thanks a lot, Dr. Narendra Vaidya. We can, yeah, next.
So, good morning, and first of all, congratulations, Dr. Shubhang, for organizing such a wonderful academic event. And my apologies for not being able to make it yesterday. So now we are back to basics. Managing the PCL in a CR. So managing the PCL in a CR knee. The disclosures are not relevant. The posterior cruciate ligament, the decision to retain and balance or remove and substitute is controversial, but it depends basically on the school of thought you align with. So there are 3 types of surgeons who always sacrifice, who never sacrifice, who decide in individual case scenario is a rare thing, but like I was happy to see some around. So according to the CR group, you can do a PCL retaining knee in almost every knee. You just need to balance it well, and only contraindication will be a dashboard type of motor vehicle accident injury where you have a posteriorly unstable knee. So I'll just take you quickly through the situations that we come across. Assessing the flexion kinematics is the most crucial portion of the CR knee to enhance the post-operative function and long-term performance. So the test that was described is pull out and left off test. So how to assess a well-performed knee? It is that the posterior condyle should be placed in the center of the tibial plateau at around 80 to 100 degrees of flexion. If the tibia sags posteriorly, it is lax. If the femur rolls back posteriorly on the posterior lip and lifts off the tibia anteriorly, it is loose. So these are the situations that we generally come across. This is one thing where the knee is loose in flexion, but it is like balanced in extension. This is a second situation where the knee is tight in flexion, that you have a FFD situation, but you have a good range of motion and there is no rollback. If you look at the tibia, there is no lift off or anything. This is a third situation where you flex it terminally. The insert is, or the tibia is subluxating anteriorly. Another situation where this is when you flex the knee, it is balanced in extension, but it is being lifted off anteriorly as you flex it, and you'll just see the insert pops out if you flex it further. And this is another scenario where you'll have a situation that the lateral side is balanced, but medial side is just being pushed forward. So these are some of the common situations that you'll come across when you are trying to do the CR knee, and the purpose is like how to manage these situations and still do the CR. So the lax knee, if it is lax in flexion and extension, you can increase the thickness of the knee, the thickness of the insert. If it is lax in flexion, you can change the insert from CR to lipped inserts. So you need to understand that the difference between a CR and a lipped insert. And if it is lax in extension, you can do an anterior stabilized insert that is equivalent to PS knee in the terminology of CR surgeons. So this is the spectrum that we are all aware of, the kind of inserts that we get. So these are the three inserts that I'm talking about. This is a standard posterior bearing, CR bearing. So this is having a 3-degree inbuilt slope in it. If you go for the lipped inserts, it's too bright, you can't see the insert down, but it has a 0-degree posterior slope in the insert. Sometimes the company guy will say inbuilt 3-degree has, sir. So this is what they're talking about, and this is the anterior stabilized knee. So lax knee is something which will happen, but like if you actually just try to understand it, that it is only lax in flexion, you can change the insert and put the lipped insert that will be thicker posteriorly because it has a 0-degree inbuilt slope, and it will manage your situation. So this is a very rare scenario, but you can sometimes have a knee that is actually sagging backwards, and for this you have to have this insert in the backup. But like I have not come across a knee in my 15-16 years of career where you plan something and then you have to look for such alternatives. So what we more frequently see is a tight knee. So it can be tight in flexion, it can be tight in extension, or it can be tight medially. So accordingly, we release the PCL from the femur, from the tibia, or you can do the tibial osteotomy if you want to. So this is the first situation that we are talking about, that the insert is moving out anteriorly from the medial side, though the lateral side is sitting back. So you just go in and release the tight fibers, try to put the tibia under the femur just to make the remaining PCL tight so that you can further look for those tight fibers and release them. And this is what you finally get. The knee is balanced in flexion and in extension, and you try to juggle it. There is no anterior or posterior drawer in this. I'll just have to rush through the slides because there are a lot many, and this is the case that we were just witnessing. So these are the x-rays. This is the intraoperative picture that we had a huge defect. We had to bone graft it to build it up. And finally, these are the x-rays. This is a second scenario when you see that the knee is tight in flexion, but balanced in extension. So as you're flexing it, the whole of the insert is coming forward. This can again be balanced with release of PCL from the femoral attachment. And this is what we achieve after releasing it. And this is after the insert. So there is rollback, the knee is stable, you can, there was another video after this that when we further released it, but look at the stability of the knee. In full range of motion, it's not moving forward, backward anyways. And these are generally 9 mm inserts. This is again tight in flexion. I'll just rush through the slides because we will not be permitted that much time. So all these knees, they can be balanced if you just know where and how to release the PCL. Look at your tibial cut. The moment you come across a tight knee, look at your tibial cut. If it is too thin, you can increase the thickness of the cut. If you think that it is only tight in flexion gap, you can play while putting the pins, and you can keep the pins at the same place and just tilt it a millimeter backwards. That will give you only the posterior, that will only increase your posterior slope. And if you think that it is tight both in flexion and extension or slightly more in extension, you can just increase the size of the cut and again increase the slope if you want to. So you should just be aware of all the things that you can play with in a CR knee. I'll have to rush. So this is a knee that is tight in flexion. So and it is like balanced, you can rotate it. There is no anterior lift off or anterior subluxation. So you try to release the PCL. I prefer to release the PCL from tibia when it's tight in extension. I don't know, but this is what I have learned over years, that it works well. And this is the final appearance, that it gets straight. This is another knee that is getting good flexion, well balanced, tight in extension. There is FFD. So we'll again release the PCL from tibia, and this is what we finally get. So this is another thing in your armamentarium that you can do the, just last 2 slides. So you can do the V osteotomy. This is how it actually looks, that when you push it forward, it will lift off. And this is how it looks after the insert sits in. You can still manage or balance the tight flexion gap. So even in such scenarios, you can get away, after putting all those bone grafts and everything, you can get away with a well-balanced CR knee. All these knees, they were done without robotics. And to conclude, even with full release of PCL of the tibia, excellent flexion gap or flexion balance can be attained. So this is fully released. You can, if you can appreciate, there is a fat pad beyond this PCL stem, and this is what you can achieve even after full release of PCL. It is stable in flexion, in extension. You can't see any movements. So thank you for your time.
So thank you, Dr. Pandher. It was an excellent presentation. Any questions or comments? So the debate is still on, the robotic versus.
So they are convinced, they'll do CR now.
Okay. So the next speaker.
Next speaker, managing sagittal plane deformities, FFD and hyperextension. Dr. Ji.
Good morning, chairpersons and dear friends. Once again, thanks to Shubhang and the team here for the invite. My brief is to talk on the management of sagittal plane deformities. And these are less commonly seen than your varus or valgus, the coronal plane deformities. Yeah, okay. So basically, either hyperextension, recurvatum, or fixed flexion deformities are the ones that we are talking about. So various causes for genu recurvatum, but I think what we need to keep in mind when you see hyperextension deformity is whether it's a neurological cause or it is caused by the ongoing disease process, whether it is a rheumatoid, whether it is, bony defects, post-traumatic. These are the things that we need to keep in mind. But at the back of your mind, we need to evaluate whether it is a post-polio from childhood or whether it's some progressive neurological deficit. Coming to fixed flexion, most often it is degenerative osteoarthrosis, and it is associated with mostly with varus and can also be associated with valgus. But pure fixed flexion, if you have, it's mostly in inflammatory arthritis, and often it can be due to post-traumatic conditions as well. So in all these, you have altered biomechanics. These are a challenge, both intra and even post-op management as well, and in the rehabilitation as well. So, like I said, FFD most often is associated with coronal plane deformities, and the minor deformity is correct under anesthesia. So we need to be aware of that. And it is due to the contracture of the posterior tissues like the capsule and the PCL, and in extreme cases, even the hamstrings. So we need to grade this mild, moderate, and severe. Anything beyond 60 is considered severe, 30 to 60 is moderate, and under 30 is mild. So, like in any other situation, you need to assess preoperatively what could be the cause, the severity, the associated deformities, muscle power, range of movement, and also we need to look at the X-rays. Sometimes we may even need to have a CT scan done to rule out or to assess bony deformities. We need to plan our surgery as regards the soft tissues, whether it is a mild deformity, whether it is a very severe deformity, whether there is any bony loss that we need to augment or have special implants at hand. So these are the things that we need to consider. So going for the releases, mostly it's the posterior release, depends on whether it's a mild varus or valgus also. But generally for a severe fixed flexion, it is the posterior capsules that you release. You may also have to release the gastrocnemius, peel it off from the back of the femur as it is shown there. Literature has described release of the capsule like that. I've never had the courage to sort of do that. But I think if at all you're doing that, keep away from the central area, because that's where the scary organs, not the organs, the neurovascular structures are. So some papers have even described in severe deformities hamstring tenotomy. But I think more often what we have done is to do serial casting and release, improve a severe deformity or a moderate deformity to a less severe one. But you have to be aware that these bones can be osteoporotic, and you can actually end up with fractures if you use undue force. So these are all the structures that need to be released from one particular paper that I mentioned. And sometimes you can have osteophytes and loose bodies that can actually prevent your releases. So just to say that fixed flexion post-surgery, it improves. If it's a rheumatoid, you can leave about 10 to 15 degrees of fixed flexion in a severe one, and gradually it may stretch out over a period of 6 months or so with good rehab. And similarly, the range of movement initially may not be good, but eventually at about a year or so, it improves. So you may have to take extra bone cut on the femoral side. Some papers say up to 4 to 6 millimeters, but in severe deformities, yes, I've gone up to 4, but never beyond that. And then the routine releases at the back. That's what generally gets you to get the correction. So if you have a very severe deformity, you have to have constrained implants on table, otherwise you will end up with problems. So I'll just rush through with this. I think most of you are aware of the post-op protocol. Bracing in the severe deformities. Otherwise, if you don't have optimum pain control, then recurrence of the flexion contracture is a possibility. So we need to keep that in mind. We need to motivate these patients. Many of them have been bedbound for a long time, not been walking. So we need to be aware of that. So the complications, instability, and what I've not mentioned here is iatrogenic fractures that we can have in the severe deformities, severely osteoporotic patients. Okay, so just one, I think that's one very stiff knee this was, and it was not a very tight, in the sense of degree of flexion, but it was a very tight knee, and that needed correction. Here's a rheumatoid who was not walking for about 2 years, 60 degrees or so of deformity, and we needed to go higher. I unfortunately don't have the opposite side where I actually fractured the epicondyle. So I had to fix that. So we need to have your trauma implants also ready in such cases. So rushing to recurvatum, it's unusual in an isolated situation. You can get it because of the varus thrust that they have. You can end up with bony erosions at the back, and then you can have these sort of deformities. And more often it is associated with valgus in a rheumatoid knee. Okay, so there is sometimes recurrence of this deformity post-operatively. There's a paper from Bangalore, I think, who they said that it is so. So essentially, the posterior tissues are stretched, the posterior capsule is stretched, and the cruciates are attenuated. So again, pre-op evaluation is absolutely essential, whether it was during childhood, whether any neurological condition is there. The power is very crucial, range of movement, of course, and gait analysis, not really. Okay, we have to rule out the cause of deformity. Coming to the releases, avoid touching the posterior part of the knee. Minimal bone resection, avoid posterior release, and then I'll just rush through just a few tips. Under resection of the bone is generally what is done, and you use a relatively thicker femoral and tibial components. So Krakow has described posterior capsule constriction or repair, but I don't know really if it is done. I've never had the chance to see anybody do or hear about it, but that's been mentioned in the literature. So if there is any laxity of the collaterals, you may need to do epicondylar osteotomy and tighten it up. Okay, so that's one thing. So like I said, very minimal bone resection and hardly any soft tissue release at the back. So you just stick on to your basic structures. Go in a titrated manner so you don't overcorrect that. So, right, okay. So I think just one case I might show there. Yeah, just finish with this. A very severe deformity and it was grossly hyperextending there. Massive bone deformities there, bone loss there. And I had to reconstruct that. Then that's the thing. Okay. Another example, this was a pure bone loss at the back that was called leading to hyperextension that corrected. Here's one extreme case, and here you should not touch it without having constrained implants at hand. So, but however, we got away with the standard implant there, stemmed it on the tibial side. This was something like a sponk, I think. This was not a a fracture. It was a sponk situation with hyperextension there, and that was how it was sorted out. Just to show that sometimes we end up with the knee in a little bit of hyperextension. We worry whether they stretch out over a period of time. Generally, it does not happen. So coming to the conclusion, meticulous evaluation of both these sagittal plane deformities, pre-op planning is essential. Stepwise surgical correction, have constrained implants at hand, and do it well. I request all the younger surgeons to join Indian Arthroplasty Association. Please do become members of the Indian Arthroplasty Association. And in the end, with the permission of the chair, I welcome you all to Bangalore for IOCON 2024. Thank you very much.
Jeet, it's a actually difficult topic. You made so easy. Any questions or comments? Just a small question, like in flexion deformity, sometimes we tend to increase the posterior slope.
Yes.
So is it true the reverse in the extension deformity also? You reverse the slope?
Not standard, not done it, but like it was shown in the previous one where he was trying to balance the PCL. If everything else you have done and the posterior capsule is very, very lax, then that's an option that you can undertake.
Yeah. Thank you. Any other questions? So we move on to the, Dr. Rajput.
Yeah.
See that he's got about 90-degree flexion bilateral.
Yeah, I mean, first and foremost, I think is to see whether on table, at least, whether the anesthesia will relax him to some extent. If it is a rigid sort of thing, then I think it is said that you do it in 2 stages. You do hamstring release, posterior capsule release, and then do on to the total knee. But I have not done that. I've had only 2 cases with such extreme deformities, and I've just taken extra bone cuts on the femur and released posteriorly and got away with One patient I had about 20-degree residual varus. I think the other one stretched out much more on table. So got away with that.
Any experience putting Elizero on these ones?
No.
Does anybody have?
So I think there are options like this, but I must say, at the end of the procedure, before the patient goes out, you must check the vascularity.
Yeah, absolutely.
If you are correcting the moderate
Mandatory.
severe deformities.
Mandatory.
Yeah. So thank you very much, Dr. Ajit. And we move on to our next speaker.
Next talk is demystifying alignment, Dr. Krishna. Next speaker will be Dr. Vaibhav Bagaria. Next.
So this is a little bit complicated topic, and it has been promoted more because of robotics, I suspect. So we will look at the different alignment philosophies currently existing in TKR. I don't have any preference for one or another. If we look at well-performing athletes, these are at the peak of their performance. The knee alignment is definitely not neutral in all of them. So all of them have different alignment. So there is a movement in the Arthroplasty Society towards what we call as personalized knee alignment based on the individual patient's alignment and the collateral ligament laxity. And if you look at the normal knee kinematics, because of the function of ACL and PCL and the asymmetric nature of the medial and lateral condyles, there is a lateral rollback of the lateral femoral condyle, and there is external rotation of the femur in flexion. And in extension, there is screw home mechanism. So this happens. And you have the medial meniscus, which is relatively conforming, and the lateral meniscus, which is mobile, which slides off, if you can see on that MRI film there. And it takes on the lateral femoral condyle as a separate articulation in deep flexion. And this ACL is interfered with in knee replacement. So most of our knee arthroplasties are a compromise. They don't ever replicate the normal function because the menisci and ACL is not there. Now this search for this alignment began with this particular paper, which showed that almost 32% of normal men and 17% of women have got mechanical axis alignment, which is more than 3 degrees of varus. So this is what is called as constitutional varus alignment. And we also have this at the background that around 20% of patients with total knee arthroplasty are not satisfied. And we really don't know what we could do better. And is alignment one of the options to make them happier? If you look at all alignment options, you have the patient-specific alignment techniques or the pre-arthritic alignment strategies like unicompartmental knee arthroplasty and kinematic alignment, which tend to restore the patient to what they had before the arthritis set in. That is pre-arthritic alignment. You have hybrid techniques like restricted kinematic alignment and adjusted mechanical alignment, and some of the functional alignment techniques which tend to play around with the femoral and tibial component positionings within certain acceptable boundaries, which can be narrow or wide based on the individual philosophies, so that you don't need to do too much of soft tissue releases, but in certain cases you will do soft tissue release as well. And you have the conventional technique like mechanical alignment and anatomic alignment, where you are trying to restore a neutral mechanical axis, hip, knee and ankle in the same line. So in kinematic alignment, you essentially restore the pre-arthritic alignment. So you ignore whatever is the varus valgus, the tibia, femur, you do what is native to that patient. So you remove the bone equivalent to the amount of metal you are replacing, and you assume that the native collateral ligament laxity and alignment are restored. In restricted kinematic alignment, you impose certain boundaries. In inverse kinematic alignment, you do an anatomic tibial cut, use gap balancers as was shown in one of the technique, and then adjust everything on the femur, so that now you have a well-balanced knee throughout range of motion. And of course, functional alignment is a balance-driven strategy. Now, why should we have boundaries on kinematic alignment? It has been shown that it may not be desirable to recreate pathological anatomies, especially in the outlier situations, because this has contributed to the wear in the first place. So it may not be prudent to create a pathologic anatomy because you expect that sort of an anatomy will cause wear out of the implant as well. And we also have challenges with the current available implant fixation and polyethylene tolerance challenges, limits, and this cannot be exceeded by recreating pathological anatomies. However, the long-term data in the registry and with respect to the survivorship and failure have shown that kinematic and mechanical both function equally well. Now, the CPAC classification, Dr. Narendra Vaidya went on this, depends upon the joint line obliquity and the anatomic hip-knee angle, which is important. And it doesn't take into account the sagittal and rotational plane alignment of the knee. However, two fundamental principles which we need to understand here. We must calibrate what is known as the anatomic hip-knee angle, which is the difference between the medial proximal tibial angle and the lateral distal femoral angle. And you also look at what is the direction of obliquity of the joint. So there are three patterns which are available. So if you have joint line obliquity less than 177, it is called as an apex distal joint line. If it is between 180 and plus or minus 3, it is called as an apex neutral joint line. And if it is 180 more than 183, it's an apex proximal joint line. So this is about the joint line obliquity. And if your overall alignment is plus or minus 2 degrees of 180, then it is considered to be a neutral alignment. If it is more than 2 degrees of varus on one side, it is a varus alignment. And if it is more than plus 2, then it is considered to be a valgus alignment. So based on this, the 9 grids are drawn. So you could have a apex distal joint line which could have an overall AHK of varus, neutral or valgus. You can have an apex neutral joint line which could again be a varus, neutral or a valgus, and an apex proximal joint line which would again be a varus, neutral or a valgus. So each varus need not be the same. So a varus could have a different joint line obliquity. It could be a completely different beast to deal with. So this needs to be understood. Now, the alignment philosophies are based on 3 basic fundamental issues which we need to evaluate. What is the morphology of the femur with respect to the sagittal, coronal and axial rotational positioning of the native femur itself? What is the status of the soft tissues with respect to the collateral ligament laxity? We all know that in extension it is more or less balanced, but in flexion the lateral side tends to be lax. So whenever you're looking at a kinematic pattern of restoration, you're looking at some laxity on the lateral compartment in flexion, but more balanced in extension. And finally, you're looking at alignment. Are you looking for a 0 plus or minus 3 alignment, or you're happy to extend your boundaries a little bit to about 6 degrees of varus to 4 degrees of valgus so that you minimize the soft tissue releases. The fundamental problem, however, is that the meniscal and ACL function still needs to be restored, and this cannot be done. So these are the 4 alignment spectrums which have been described: the mechanical by John Insall, restricted kinematic by Venditoli, functional alignment by Faris Haddad, and kinematic alignment by Stephen Howell. So what do we do here? For in any alignment strategy, we have to look at boundaries, the laxity pattern, adjustments, and the overall HKA. So in kinematic alignment, the boundaries are unrestricted because they are based on what the patient has. The laxity pattern is restoring the native laxity. Femur is relatively constant in all kinematic philosophies. You don't give any rotation, you restore the joint line. All adjustments are made on the tibia. The HKA is variable, and in restricted kinematic alignment, you're looking at plus or minus 3 degrees. In functional alignment philosophies, the boundaries are again restricted, but the laxity is not accepted. You balance the knee, and then you make adjustments on tibia as well as femur to get the balance right. So this is what Dr. Narendra Vaidya was talking about, this functional alignment, and your boundaries can be narrow or wide. The most commonly accepted boundaries are 6 degrees of varus to 3 degrees of valgus overall alignment. So typically you need a robotic assistance, and something like that pops up, and hopefully when I do the live surgery, I will show you all the philosophies on the screen. And these are the differences between kinematic and restricted kinematic and functional alignment. Alignment is non-negotiable in kinematic and restricted kinematic, with the resultant balance and laxity being accepted. But in functional alignment, it is a balance-driven strategy where the resultant alignment is made acceptable. Why would you need all this? You need this because of this particular paper which showed that the forgotten joint scores for functionally aligned knees are superior to any other strategy. So there was almost a 22-point difference between a functionally aligned knee versus a non-functional aligned or a mechanically aligned knee, and this changed the paradigm. And to take home message is that a functional alignment is a balance-driven strategy with emphasis on recreating joint line obliquity and a HKA which is acceptable from 6-degree varus to 3-degree valgus. You can have a mechanical functional alignment starting point or a kinematic starting point based on how you're balancing that particular knee. And this has been shown to give better patient-reported outcome measures and better forgotten joint scores. So you should know your start point, need to know your implant boundaries and the laxity endpoints and the overall alignment targets that you're going to have if you want to do any of these alternative alignment philosophies. Thank you.
Thank you, Dr. Kiran. It's a very difficult topic. You tried to make it simple. I would say still it was difficult for the audience because it's a new concept.
It is.
So I would say, request you to develop a team and teach our youngsters so that it becomes easy for all of them. The people like me, maybe, they are the outliers now. Right. So thank you very much. Any questions? So thank you. Thanks a lot.
The next talk is managing deformity with the robotic. There is Dr. Vaibhav.
Next, Dr. Parmar.
So thank you, Chairperson. And this talk is for both outliers and inliers. Yeah, because I'll talk about some very basic things about the varus knee. And I'll also talk how robotic is changing the way we look at all the varus deformities. Yeah. So thank you, first of all, for inviting me. I'm from Mumbai. I work at the Sir H.N. Reliance Foundation Hospital. So, as I said, it will be about basics as well as what robotic does. So let's look at what's the anatomy, how do you classify, what's the soft tissue management, what's bone management, and how we change the way we look when we do robotics. We all know what varus is, previous talks have spoken about it. Now, when I look at varus, we must understand one thing. People, and I was just discussing that we are dogmatic whether we should do soft tissue releases, whether we should not do it, whether we should do CR, whether you should do PS. I think when we look at any deformity, it is clear that it is combination of both bone and soft tissue. And the right way I believe why we have unhappy patients is that we tend to be dogmatic that, only the bone should be dealt with or only the soft tissue has to be dealt with. So going to basic, I think it's important to know what exists on medial side. This is all the structure that exists on this side. And we must also know this very important structure on the medial side, which is SMCL. And you'll be surprised to know that majority of people will not know the anatomy, how far it is on the femur and how far it is on the tibia. So it's very important. This is a sacrosanct structure. And why do I say that? Because joint means different to different people. When I'm talking about varus knee, this is the structure which defines joint for me. The area between the origin and insertion of SMCL. For a deformity correction surgeon, it's a line. So all that debate we had on extra-articular deformity was about line. But as a joint replacement surgeon, we are thinking about a box. For an arthrosurgery surgeon, we are talking about a capsule, the area between capsules. So this is when we talk about the varus knee. And also how the structures are from the top to bottom. So the top layer is osteophyte, DMCL, PES, semimembranous SMCL. So this is very important to know the structure on the medial side. And you know that deformities are not same. All the varus are not same. It can be reverse joint line. We have CPAC classification. We have got all different kind of varus. So it's very important to look at X-rays because that will tell you how you are going to approach the knee. And of course, you'll have extra-articular. We went deeper into varus deformities when we wrote this article in JBGS, and we defined what exactly does varus mean when we look at the bony deformities. We talked about soft tissue, and we'll see that these are the different features of the varus that are there. It starts from the femoral osteophyte, joint space narrowing, tibial osteophyte, goes to the flattening, the tibial defects, then to subluxation, then the stress fractures. So look at the X-rays to find what contributes to the bony part of the varus and what contributes to the soft tissue part of the varus. So all this can be seen. When you look at the X-ray, you'll see the varus is not the same. And also notice where the deformity is coming from. Is it femur? Is it purely at the joint? Is it tibia? Or it's extra-articular? What's extra-articular again is the area which is outside the insertion of SMCL, which is 7 centimeter from joint line. How do you do that? You draw a epiphyseal line, joint line, and drop a perpendicular and draw a tibial axis. If outside 6 centimeter and you have got a severe deformity, these are the deformity that you need to tackle in 2 stage or 1 stage, but at 2 sites. So, as I said, we think in terms of anatomy and classify, decide in terms of soft tissue and bone deformity, and execute with our special techniques. The goal is that the medial structure reach a length equalizing that of lateral structure almost. And why I say almost is because we'll talk about this. And when I look at knee, when I look at any varus knee or a valgus knee or any kind of deformity, I look at it as a 3-step process. One is basic soft tissue release. When I look at the knee, I feel how tight is it? Is it giving away? Is it flexible deformity? Is it correctable or not correctable? So I plan my basic soft tissue release. Then the second is where the robot comes in. I juggle the bone cuts with the robotic planning screen. And then if there is at all any residual release, I fine tune it with minor releases that remains after the juggling. As I said, for me, TKR is still both bony and a soft tissue surgery and not either or. We all know that how to create a medial release. And this is one thing that I feel, and when I teach, is that you look at the clock concept. You look from the 6 o'clock and you go up to 12 o'clock, and all these structures contribute to varus. So when I've started doing robotics, I stop at 3 o'clock. I do not go and create any more releases beyond 3 o'clock. From 6 o'clock to 3 o'clock, the releases will happen for any varus which is more than 5 degrees. And beyond that, it will be a sequential release depending on why I say that. And similarly, like a triangle, it will be top to bottom releases. So this is the first step, irrespective of whether I'm doing robotic or non-robotic. Then comes this planning screen, and this is probably the crux of my talk. This is how the planning screen looks. And what robots does is that if you have done a certain number of cases, you can very well gauge how your medial and lateral gaps are by giving a same amount of tension. So after you have done 50, 100, you are pretty reasonably consistent in capturing the gaps. Nowadays, there are tensionometers available which will do it this, but if you are doing a certain number of cases, you will know how it looks like. And then once you have gauged, then what the screen we saw, and when I'll show in live surgery, is that you have got 4 boxes: medial lateral in extension, medial lateral in flexion. And then what you can do is you can juggle your bony cuts by setting your negotiable and non-negotiable. And that's what we heard from the morning. All the alignment philosophy is about knowing your boundaries, knowing what you can do, and exploiting the 6 degree of freedom of component positioning and 6 degree of femoral translation, and use the technology to hit the moving target. So what we all know, what are the 6 degrees of freedom? We can dial in varus, valgus. We can rotate component internally or externally. We can flex or extend. So this can happen on femur and tibia. Similarly, we can move a component towards the joint, away from the joint. We can shift it anteriorly, posteriorly, translate it medially, or translate laterally. This is what is knee replacement. This is what is experience. This is what, when the robotics come in, can be done objectively. So if you look at the total permutation combination of this 6 in femur tibia, it's 824. Ability to achieve the top 10 determines the happiness of the patient and the success of the surgeon. Remember, there is only one goal in knee replacement of a happy patient: balance force all across the joint. Medial compartment, lateral compartment, and patellofemoral. If you balance the forces, patient will be happy, it will last. Do not stray away too far away from biomechanics, because then you are compromising survivorship. So look, there are only 2 goals in knee: survivorship and forgotten joints. You do that, and if you do it intelligently, you will achieve that. So how do I do it? So these are my non-negotiable: alignment philosophy, 5 varus, 2 valgus, balance 2 millimeter flexional extension, gap equal or slightly loose in extension for TKR, slightly loose in flexion for UKR, no notching, no overhang, joint line preservation. But then I've got certain things that I can play around. And as I said, if I play around, I'll reach what I can do that. So you will see in this short videos, what I'm doing is, if you look here, it's capturing, this is the warm-up screen, and then I'll be capturing the gaps. This is non-stress. Then once you give stress, then the graphs will change. And you'll see, although I'm giving a valgus stress, still because it's distraction, the lateral side is opening. And finally, the lateral side will open much more, showing that the lateral gaps are more. And this is the kind of graph that you will see. you'll see that the inflection, the lateral side has got too much of opening, and extension it is less. But within a few seconds of having this objectively, by dialing in certain varas, by shifting my tibia, by changing the rotation, by changing the poly size, I'm able to achieve almost near thing. And the key is to, when you are talking about varas, remember lateral side is good. So when you balance, you ensure that the lateral side is restored to its normalcy. And once you do that, your game is up. So just a few seconds more, and this slide you will see that it is nearly almost completely balanced when you end this. So for me, the medial side, that 5.3 and 3.1 is not very important, because that's the pathological tightness. You achieve the normalcy, and that's it, you are set. So as I said, we have moved to the era where we call it an intelligent alignment to hit a moving target. This is my happiness. I'm very happy if I'm in the first compartment, very unhappy in the last compartment. Thank you.
So thank you, Dr. Bagaria. It was, I would say the middle path, as Dr. Tuli used to say, and we used to listen from our teachers, the science and art orthopedics is. So it's an art to, move your components by learning it or with the help of the robotics. So excellent presentation. So any questions from the house? Or comments? Dr. Shubhang wants to say something? Okay.
No, I think what we all discuss is we are probably saying the same thing, and robotic allows us to do it objectively. And what I've done is put it objectively, what you can deviate and what you can't deviate.
In fact, by learning this, sometimes someone commented that the computer will do whole of the surgery. So human is still required. So thank you very much. We move on to the next lecture.
I think that Harpreet from Jalandhar is not there. So next and last talk is managed faulty with the robotics Belgas, Dr. Narendra.
First of all, thank you, Dr. Shubhang Aggarwal, for giving me the opportunity to present my presentation at here. And after yesterday's very good talk of Dr. Manoj Wadhwa, how to manage the valgus knee without robotics. Now how to manage the valgus knee with the help of robots. This is my talk. Difficulty, ligament balancing changes in bone anatomy is more difficult to correct in valgus compared to the varus deformity. Valgus knee is less frequent. It is approximately 8 to 10%, and 10% cases. Typical findings what are? Hypoplastic lateral femoral condyle, external rotation deformity of the tibia, internal rotation of the femur, tight IT bend, and posterolateral tight structures are there. If we classify the valgus knee according to Ranawat classification, grade 1 less than 10 degree, grade 2 between 10 to 20, and grade 3 is more than 20 degrees. General principle is the surgical technique. Prefer whatever the incision you are comfortable, parapatellar, subvastus, midvastus, whatever. Depend on ligament balance. Component selection, whether CR or PS knee is your choice, and component position according to your plan. Main principle in valgus: restore alignment on all the three planes, restore the joint line, restore the joint stability, restore the range of movement, and most important thing is the patellofemoral kinematics in valgus knee. Use appropriate fixation technique. Whenever you need some rod or a revision implant, use semi-constant implant. When is needed, you should use it. In valgus knee is always type 2, there is less bone cut, always less bone cut, preferably. And why robotic in valgus knee? So, some basics. Previously implanted joint sometime, or more like this. Reproducible result, as Dr. Narendra Vaidya say, same X-ray repeatedly, you just see the X-ray, you forgot the patient name many times. Reduce recovery time and all those things. Customized knee replacement just for patient. This is something basic regarding evolution of robotic technology, early bell. I will not go regarding more detail in conventional and all those things. Yeah. how robotic knee replacement works. It is image free and the real time technology. So you can move your skin here and there and change your plan according to your tightness, varus or valgus. Is image free technology. I will demonstrate few cases. This is the first case, 65-year male patients, valgus knee on the one side and both the side. Around 22 degree to 25 degree valgus is there. And perform the robotic TK. Implant is Entham on left side. This landmark registration is there. Everything is after registration and all things. This femur axis refinement after range of movement detection. Now gap assessment. See here, there is huge opening on the medial side and lateral side. There is little bit opening and flexions is there. After tibia free point collection, see the graph on the left side. Yellow or saffron is the medial, and blue is the lateral one. Medial, there is huge opening line above the graph, above that horizontal line. It is huge opening. Now, without releasing the soft tissue too much, how you can adjust your varus or valgus knee? That is the sometime robotic here help you more better way. Here I accepted after the balancing and right side graph, I accepted internal rotation of the femur up to 7 degree. Move. See on the second box and see how I had balanced without too much soft tissue release, all those things. See the tibia cut after that. And this is the post-op graph after implant position. So pre-op valgus is around 22 to 25 degree. We have plan alignment 3 degrees and achieve approximately 3 degrees. That is possible with only with robotics, with minimum soft tissue release. We are moving the component little bit. This is the post-op X-ray of that patient. Second case, 71-year female, 8 degree valgus, right side. Same thing is, look at the graph. Tightness over lateral side in extension and opening over the medial side. As Dr. Vaibhav Bagaria said, many times you just adjust the graph on one side. You just medial side, we have balanced it. Lateral side, we left it. So that much we can correct sometimes with little bit of soft tissue release and all those things. Many times both the side you can't adjust lateral and medially graph equally. See here, preoperative valgus alignment is 8 degree. Plan alignment is almost 0 and achieve is almost 0. The 68-year male patient, post HTO case, 2 degree valgus. Yeah. Same, it is lateral side is too much, medial side is too much opening, lateral side is tightness is there. We adjusted the graph both in extension and flexion. Medially we adjust it completely, laterally little bit tightness is still there. Pre-op valgus alignment is almost 2 degree, plan 0 and achieve alignment is also 0. So whatever you plan that you should achieve with the help of the robot, little bit soft tissue release. So in valgus knee, many times the robotic technology will help better. You need minimum soft tissue release, but can't always rely on the robotic technology, as Dr. Manoj Wadhwa is yesterday. So very good technique of soft tissue release and all those things in valgus knee. Keep always revision implant ready in valgus type of knee. Keep rods and all things are ready. Okay, thank you.
Sir, any questions from the house or comments? It was a wonderful presentation.
Thank you.
Thank you very much.
Thanks a lot, Dr. Pramar. We have this session complete with this presentation. So may I request all the speakers of this session and kindly stay here, sir, moderators also. Can I request all the speakers of this session to be on the dais, please? And may I request Dr. Goyal to come on the dais and have the honor of facilitating the speakers of this session. Dr. Hariom Aggarwal, Dr. Dalwans Pandhe, Dr. Jeet Kumar, Dr. Vaibhav Bagaria, Dr. Narendra Parmar, Dr. Krishna Kiran. क्लास सब पंजाबी वाले हो जाने चाहिए यार पीछे येलो जोन आई नहीं तालियां I request Dr. Goyal to honor the moderators also. Nice click, sir. Thank you, sir. May I request Dr. Ajit, Dr. Krishna Kiran, Dr. Vaibhav Bagaria, Dr. Hariom Aggarwal to stay on the dais, please. Please stay on the dais, sir. Okay, fine, sir, fine. May I request Dr. Rajput, Rakesh Rajput to join on the dais, sir. We are going to have an inaugural ceremony for this regional meets. Dr. Hariom Aggarwal, please come in the center of this sir. May I request Dr. Sandeep Goyal, Director of NHS Neurosciences, and Dr. Shubhang Aggarwal to also come on the dais, please. Dr. Ramesh Sen also please come on the dais, sir. May I request Dr. Kabal Singh Ghai also to come on the dais, please. He is Secretary of Punjab Orthopaedic Association. So we have the session 5 for the next on the agenda. So may I request the chairpersons of this session, Dr. Sumit Mahajan, Dr. Hariom Aggarwal, Dr. Ambo Sood in case he is present here, Dr. Hemraj, Dr. Piyush Sharma if they are present, and Dr. May I request Dr. H.S. Gill to be on the dais, sir, as the chairperson.
So moving ahead with the next session, I think the Kali by talking by Dr. Mason, the first take. So I invite respected Dr. Mason sir to speak on stiff knee takedown. It is just for all the delegates that Dr. Mason is our past president of the Indian Orthopaedic Association.
Thank you, Dr. Hariom. Thank you, chairpersons. So my assignment is to talk about a stiff knee. We appreciate that when we get a patient like this, who has got a stiff knee can vary a lot. It is actually defined as when the range of movement in the joint is decreased to less than 50 degrees. Now this could be in a different position. It could be a fibrosis or it could be ankylosis. In the fibrosis, there is a beautiful classification laid out by our Dr. Miral, and they have published a beautiful classification depending on the amount of flexion deformity it is less than 30 degree, or it is more than, it is 30 to 60 degree or 60 to 90 degree, depending upon whether this is in extension stiffness or stiffness is in flexion. Or then the third variety they had given it is that it is a ankylosis. Again, the ankylosis could vary whether it is less than 30 degree or it is more than 30 degree. So all these things have an implication. Now, when we look at the stiffness as a factor, we understand that the muscles in this stiff knee are likely to be affected. There will be contractures on the flexion side. There will be a stretching on the extensor side, and they may be non-functional on that part of it. And accordingly, there is a lot of stretch which will be happening over the skin, underlying tissue. And then when we look inside the joint, we can have another issue. Now here he is a patient who was with me in about 15 years back with the totally fused hip, with the totally ankylosed knees also. Now this is a situation when the things are totally ankylosed, your options are relatively difficult to determine what the best way is, because along with this thing, there will be a problem at every level. When you are going at a skin level, as I said, skin is likely to be stretched out, and in this kind of a skin, your healing could be an issue. So you'll have to be very careful about how to take it down at that level. Then when you look at this thing, your midline is supposed to be the standard here also, a standard approach for the patella. The problem is here, everything being stretched, you have a difficulty even in subluxating of the patella, and there could be an issue that even the patella is also fused anteriorly to the femur. So in the ankylosed kind of a situations, all these things are likely to be very difficult in that context to let them displace out. And in this kind of a situation, when you are doing this release, you have to be very careful whether you will be able to really have an adequate access to the underlying bones or not. And in that scenario, you might have to go to those osteotomies of the tibial tuberosity area with a proper protocol. And that could become another understanding of this area to get an appropriate exposure. So by going this way, when you are going inside it, you are likely to create a joint space. Now here this was a case was because it was totally ankylosis, so you have to break that ankylosis. But to break that also, you have to reach inside it. So for that reaching inside it, you will have to clear the the area around. The medial gutter needs to be cleared up so that you can have a reasonable amount of deflection on that side. Along with the gutters, you have to release the underside, the attachment over the tibia also. So you need enough space which could be affected in this kind of a situation. So after that is done, thereafter you will go to the TK. You can go down there to see those osteotome which I am using to do the osteotomy of that ankylosed bone over that area. And once I have been able to do, I start going for the, after the definition, after whatever retraction I could do, with the release, I am going for the cuts over there. Now, we have always to appreciate in this kind of a situation, there are no good markers available also due to this situation. So you have to be very careful about defining every part of it. So once we have been able to define it out, we put this thing. As far as the implants are concerned, again, if it is ankylosed position, if you go to the text, what Mrinal has written, that all of them will need a hinged knee because their collateral ligaments may not really be appropriate enough to sustain the knee abilities to flex and extend. So you might have to go in for that. But 15 years ago, whatever the understanding we had, we went with the standard kind of a knee over there at that stage of time. This is the patient on the 6th day when we started having this movement. And this was after 3 months. He had a problem, as I told, a patient of rheumatoid arthritis, because this is the most common etiology in these cases, various kind of a, so his shoulders were affected, his elbows were affected, his hips were affected, his ankle had a equinus deformity. But in that kind of a situation, he needed a support to get up, but subsequently he was able to make himself walking around in this kind of a situation. And this is him after 2 years. You can see the joint is doing that way. His hips were both replaced, and this was okay. And this is at 2 years. When before that time. This is another case. Again, same kind of a situation. Here, the deformity is significantly valgus also. A same kind of a fused knee where there was an ankylosis within the knee joint, and you can have the same kind of a situation. So we understand that apart from the arthritic conditions, the ankylosis could happen to other conditions also. It could be a post-traumatic knee, which I'll come subsequently, or other kind of a situation which can also have same kind of a situation. And there could be a subluxation pattern, and all these things are likely to give us a problem while we are creating the space between the patella and the femoral condyle. So all these things needs reasonable amount of a care while we are separating them out, and then to create a space. Once we have created a space, you can see another problem could be the loss of the bone also. While you are creating that space, you might have a loss of bone also. So you have to compensate for that bone loss also. Create a kind of adequate space for putting up this thing. And after that space is created, thereafter you can have to use the jigs also to have the specific cuts to be described, taking care of that patellar, this thing, because patellar ligament is very likely to get avulsed. Patella is like to fracture due to the excessive stress put onto that side. And this is after maintaining the stability, we could get reasonable amount of the stability. This is what we had been able to get it. And this is his follow-up at 4 months, where he is able to walk. And then this is after 1 year. And this is after, he came after 10 years. He came for the hip. His hip had one revision. So this is what he's walking after 10 years of this surgery done. His knees are reasonably doing well after 10 years also. This is another case, a young boy who again had rheumatoid arthritis. His both hips were involved. His knee, now right knee was taken up as a septic case, and it landed in a stiff kind of a knee, but not an ankylosed knee. Again, we went on this, creating that space over there, getting the collaterals over there, and subsequently the left side I could mobilize it. You can see it, and we mobilize it otherwise also under GA because it was just a stiffness of the tissues. But then he was okay at 1 year of the follow-up after this thing. And then the follow-up of 2 years, he could have a definitely reasonable amount of a ambulation active, and he is able to manage. So to conclude, when we have got a ankylosed knee or a very stiff knee, we have to be very careful about multiple situations, right from the stiff patella, stiff, everything is stiff. So we need to create spaces at every level, proper releases and proper creation of gutters. And thereafter the mobility, we might have to think of what the implant is likely to fit. We might have to think of what are the kind of the these bone losses are there, and definitely the osteotomy, whether the plain surgical approach can help or we need a separate ones. Thank you.
Any question, please? from the audience? Sir, I have got one question.
Please.
Sir, the valgus knee which you have shown is there is lot of bone loss. Why you have not used the primary knee? Why you have used the primary? You have not taken care of this constrained knee with the organs and you still see that the X-rays, it is still in the valgus.
No, if you remember this, there are a few more problems with the valgus because of 7. I didn't want to talk about it. That you correct to the level at which you could put up the bone. I told you these are 15 years old surgeries. At that time, what was available to you, all these, nothing was available to you. At that stage, you build up at that level of a resection so that you could have a stability. Whatever stability you got in this kind of a patient, we accepted that. So that was the situation.
And how many times you use snips for this? For stiff knee?
Snip knee. Snip is one thing which I could have told you that it is required whenever you have got a problem in getting the total exposure. Snip is a very appropriate procedure. Likewise, Tibial is another procedure where you can get a little more access to that area. Another problem which I want to say with the valgus is the peroneal nerve involvement is a very common problem which we had in this case. It eventually improved and so he was okay.
And how many times you go for the snip and how many times you prefer tibial tuberosity osteotomy?
Snip has been much more a procedure rather than the osteotomy. Osteotomy, I think I have not done 2 times, but snip I have done reasonably well.
Excellent presentation, sir.
Thank you.
I think these type of cases should be handled only by the experienced surgeon because everything is tight. Skin, muscle, ligament, tendons, everything is tight. So the beginner, they should not opt for these type of cases. Now the next talk is by Dr. Rakesh Rajput. Because he had to go for surgery, that's why his talk is being preponed. And he is going to speak on how to choose the right patient for the unicondylar knee.
UKR. So can I just have a raise of hands? How many of you do UKR? Vaibhav? 2, 3, and 1 slowly, 1 more, 4. So you can understand like it's not something people like doing or don't want to do, or perhaps have not had an opportunity to do it. So even the ones who do, sometimes, we do cut corners. We don't pick up our patients very well. And when I was also a young surgeon about 25 years ago, I also burned my fingers because I wanted to do them and I overdid them without picking the patients well. So gradually I have learned how to pick these patients very well, particularly in our country, because we see a lot of borderline inflammatory arthritis which we miss. So if you want to pick this, we want to be sure that are we picking the right thing? So is this surgery good? That's the first thing we need to answer. And I think from yesterday's talk and today's talk and the literature, UKR is now almost as good as a TKR regarding the longevity. That is all we were worried about the UKR. Question is, function-wise, is it as good as a TKR? And the answer is definitely yes. Function-wise, it's probably even superior to a TKR. So it's a surgery I think we should learn. And are these any good? So if you look at the good results and the excellent ones, you will always see more in UKR than you will see in TKR. The only trouble is, if you're going to have a bad result in UKR, you're almost going to get it very immediately, within a year or something. So the bad results of UKR are very prominent right after the surgery. So that is what people are afraid of. Whereas if you do a badly done TKR, that will still last 8 years, 9 years, 10 years. So you've covered your base for quite some time. That is not the so case with the UKR. So you get it right, it has to be right from the day one. Okay. The other thing is, choose the surgeon also. The surgeon doesn't choose the operation also. You got to also choose the surgeon as a patient. And if you see from the graph, if you're doing less than 10 in a year, your results are not very good. To break even, giving the same results of success, or longevity, you need to come to close to 20 operations in a year. And if you're reaching 30, it's almost like as good as a TKR surgeon. So you need to reach that number. To reach that number, you should be choosing your patient in such a way that every patient who walks into a medial compartment arthritis in your knee is a UKR patient unless proven otherwise. If you don't have this philosophy in your life, you will not be able to reach that numbers, most of us anyway. Okay, so we know this is how it is. The question is, one thing which turns patients away from doing a UKR is anterior knee pain. Oh, anterior knee pain, patellofemoral problems, don't do a UKR. Now I'll just give you an evidence for it. And we did this in Bristol also, where I used to train. We did a relationship between anterior knee pain and patellofemoral arthritis, absolutely none. So anterior knee pain does not correlate. Even sometimes medial compartment arthritis will present as an anterior knee pain. So ignore that, please. Okay. Next is age. We know that we say, okay, fine. For UKR, you should be a bit older, above something this age. Or some people say you should be slightly younger. So elderly are not contraindicated. I'll just give you examples. Even the young are not contraindicated. There was a question, I think somebody asked, what is your youngest patient, right? Somebody asked for UKR. I'll give you how younger patients are. So case study, 70-year-old retired army person, very active. His complaints is after 1 kilometer, right? He plays golf. He needs to bend down. Now he's been around somewhere asking people for operation, but everybody gave him TKR. He wouldn't get it done because he asked, can I play golf kneeling down and looking at my hole? He said, no. So he comes to us. That's exactly we do varus valgus stress waves. He gets bilateral UKR and look at him. So that's his function just within 2 months of his operation. You cannot replicate these sort of functions with a TKR. And if you can't, he won't get your surgery done. So it's not just that, we actually believe in surgery. 41-year-old. Okay, so you were asking about how young you can go. 41-year-old, not now. That is why I have not taken his name off and also the date of operation. So this is 2009 when he was 41. So he came to us at that time, even I wasn't sure I'll give him such a good operation. So I told him maybe it will last 10 years. He said, well, ठीक है sir, 10 years के लिए भी कर दो, मुझे TKR नहीं चाहिए. So he got his stress views done, had his operation done. Look at him, he's come after 10 years because I had told him after 10 years you will need a revision. So he said, sir, मैं आ गया हूँ revision करने के लिए. I said, तुमको problem क्या है? Sir, कोई problem नहीं है. So that's the faith he had in you. So we got him running on the treadmill for us just to show off. So he is now 14 years down the line and still running strong. Now, the other extreme. So you've seen a young, you've seen a middle-aged or slightly older. Now I'll show you one. This is the beauty of this operation, that even for elderly patients who are contraindications for a normal TKR will become an indication for UKR, where you have, let's say, 3 strokes, you've had 2 MIs, and the cardiologist says, sorry, he can't take a TKR, but he can definitely take a UKR. Let me tell you this. Even if you have tricompartmental arthritis, you can do a UKR, you will take away 80% of his symptoms. And we've done fair and fair number of cases. So 85-year-old, that's his X-ray. So he wasn't a very bad X-ray to start with. Okay, but he was fairly symptomatic and a very strong guy actually. So that's him. That's his operation immediately. That's about 6 months. That's few years down the line. And that is 8 years down the line. So still nothing has changed in him. And that's his, look at his function. Now he's past 90s. Right, so the conclusion is that this is an operation even for geriatric patient, probably the operation of choice for a geriatric patient, and you have evidence in literature if you could look for it, right? High level activity, again, people say, oh fine, they should have high tibial osteotomies and not UKR. I would say that if you have bone-on-bone contact, even for high level of activity, UKR is the operation of choice. These are the scoring, what we do is a Tegner score for all these high level activities. And you see that the Tegner score actually is same for this. Next question comes about obesity. So people say again, for obese patients, maybe TKR is a better contraindication. And if you look at the original contraindications by Kozin and Scott, obesity was the #1 contraindication. Now, if you look at the actual results down there, the more obese you are, the better you're going to perform with a UKR rather than a TKR. So again, an operation of choice for obese patients, okay? Chondrocalcinosis, again, people say, oh fine, the lateral compartment is involved, don't do it. Look at that. There is chondrocalcinosis, not a contraindication, okay? You will see many of these, and sometimes these are due to injections, steroid injections, and some of them are actually truly chondrocalcinosis. No, you don't need to have contraindication. Lateral side, okay, fine. When you look inside, you will always be ready for a TKR if anything goes wrong. You see this fissuring, and this fissuring is because of the tibial spine which articulates because of slight subluxation, not a contraindication for TKR, okay? So if you see this fissuring, not a contraindication. So don't change per-op if you see this. Only if you see a very full thickness gutter that you need to think about. So if you see this big hole on the lateral side, we haven't got enough evidence that this is a contraindication. But still, I would say at this stage, don't do it. Okay. If you're still in doubt, feed all these parameters and the Oxford scale will tell you whether you should go ahead with the UKR or not. We don't reply that. Good thing is to do a good X-ray quality. Okay. So do a good X-ray and then look at actually what you're going to look at. Only in the bottom case where you see that you haven't been able to demonstrate bone-on-bone contact, And on vulgar stress, it's not opening up quite. So both of them generally are contraindications. For these ones, I've actually started doing the fixed bearing UKS. I don't do mobile bearing UKS for these ones. So even though it isn't a contraindication according to classic textbooks, we overcome even that. Again, you can look at a lateral X-ray and make out. So the ACL, how we detect in for a UKR indication is not through MRIs, not through clinical testing, not through arthroscopy. We look at the lateral X-ray and you see the sclerotic line from anterior to posterior, which means that the weight bearing was happening and the bone has responded to it. So that goes all the way back only in this one that you need to start having a contraindication, the last two ones. Okay, otherwise they're not. Clinical, when you look at the ACL, they may look frayed, they may look a bit torn. Don't worry, as long as they're functionally intact. So functional integrity is more important. So use a probe or one of the artery forceps and try and do that. Okay. Full thickness cartilage or lateral side will be a contraindication. Okay. Nothing else. So MCL should open up, as we said. Patellofemoral joint only on the lateral side. If you have full bone on bone contact, maybe a contraindication. Otherwise, nothing is a contraindication. Okay. So virtually don't follow these contraindications. I think Cosin and Scott somehow sat over a drink and decided these are our contraindications. No evidence behind whatever they actually gave us. So if you follow them, you'll hardly have any case for UKR. If you follow the ones which I just said, you will have 10-year survivals, huge amount. So indications, all these are indications, contraindications. You know, you have to really find a contraindication apart from the ones I just mentioned. Thank you very much.
Any questions, please, from the audience? Sir, again, I have one question.
Yes.
Where you do for the fixed bearing implant in UK, and where you do go for the mobile bearing implant, because the companies like Smith and Nephew come to the fixed bearing implant only, and so is Johnson and Johnson.
So I was to start off with a fixed bearing guy, and then completely converted into a mobile bearing. And then once the robot came in, we started moving again into fixed bearing. I'm equally comfortable with both, and I think both of them work very well. So if you want to do fixed bearing, I think robotic might help you. For mobile bearing, I think you don't need robots for that. So do both, I think, because not everybody is going to come and ask you that I want to do robotic. So those ones for me are mobile bearing.
Thanks a lot, Dr. Rakesh Rajput. In fact, we'll be just going for the live feed from live surgery. That patient is ready. So may I request the chairperson of this event to please pause for a while. And may I request Dr. Deepak Joshi, Dr. Rakesh Rajput, please be on the dais again, sir. Dr. B.S. Hunjan and Dr. Ramesh San to be on the dais as the moderators for the coming session.
Okay.
We'll be again having the rest part of the session after the live surgery.
Dr. Krishna, can you hear us in the OT?
Yeah, I can hear you.
Okay.
Can you hear me?
You can start, I think.
Right. So you can focus on the X-ray. So it's the patient who is 63-year-old lady with bilateral tricompartmental arthritis.
I think volume needs to be up.
Can you hear me now?
Yeah, it is still not that.
आवाज ठीक नहीं है.
No.
देखो ना. Now?
No, the volume is voice is very low.
Voice is low, it seems. देखो.
Yeah.
ये mic का issue.
एक बार देख लो माइक का क्या है. अभी ठीक है?
Yeah, that's quite good. Quite good.
Yeah. So this is a scanogram you can see, and also the short leg films. It looks like a varus knee, but it's got tricompartmental involvement. It looks like that. So we'll be doing a minimum-adjusted approach, and I'll show you the different alignment philosophies. So the talk was a little complicated, but I'll hopefully make it easier with the robot. So when we do the planning in there, I will show you. So we have transitioned to this minimum-adjusted approach after doing subversus approach for a long time. And we have found that the immediate recovery is a little bit better with this particular approach. Only you can still do a medial parapetal or whatever you like. So the incision inferiorly is similar to that of a medial parapatellar, and you go into the tendon at an angle of 120 degrees after taking a 5 millimeter apex here, so that it doesn't cause the tendon to, split without any control. And it makes the repair easier like that. And initially, we will not do any soft tissue releases, and we will see if required with our bony adjustments, we are not able to balance the knee, then we will do whatever is required at that point in time. From our experience, 80% of the knees don't need any soft tissue adjustment. No, this is a, इसको adjust करना पड़ेगा. हाँ. This is an apex distal joint line. If you look at the pre-op X-ray, can you, this film you can just put the X-ray on. There is no need for that. उसमें X-ray लगा दो. So this is an apex distal joint line. The LDFA looks to be around 3 degrees of valgus, and the NPTL looks to be about 3 degrees of varus. So doesn't require any adjustments. This can be fully kinematically aligned. So this patient, we don't need to do restrictions in align this knee kinematically. The initial soft tissue release is only to the level of the tibial tubercle anteriorly, and this is just an exposure of the joint capsule from the tibia and part of the deep MCL till the mid-coronal point. So will not be any. So it's like a UKR. So there's no soft tissue release initially. Right. Take one Langenbach here at the junction. Okay. So this actually looks more of medial compartment. Dr. Rakesh was talking about uni. It's an option, osteotomy hammer. So we will have to remove the tenting osteophytes, and they will make the mapping and assessment more accurate. Right. I'm just making sure that the exposure is adequate. The cautery थोड़ा बड़ा सकता. Removing the anterior horn of the lateral meniscus now to make the tibial exposure more adequate. We have removed the osteophytes from the femur, and whatever I could see anteriorly from the tibia I removed. Now I'm excising the ACL. There seems to be mucoid degeneration in this ACL, so it looks very bulky. Right. So now we are ready for the pins. So you can see it's a deformity which is correcting. We will also, in robotic cases, make a little bit of dent here so that our anterior cortex mapping is accurate. Right. Pin. The first pin goes in the wound, so we position the tibial pin. Tibia ka de do pehle. Shubhang's workflow is different. So the first pin goes into the metaphysis, and it is between the anterior and posterior cortices, so that there is no stress riser. Abhi ye de do. So this is very important because we don't want any additional complications. So this is the anterior cortex, this is the posterior cortex. The pin goes in the center of that particular area, so that there is no stress riser. वो दे दो, उसको लगा दो इधर. And it should not be a bicortical pin, it can touch the opposite cortex. That's it. And this pin has to be stable. For the junior surgeons, the robotics or navigation are only as good as the integrity of the trackers and the quality of information we are giving. If you give garbage inside, it will be garbage outside. So the output will be garbage. So you cannot trust it unless the information is correct. And this needs to be seen on the. इसको adjust कर लो कैमरा को. Yeah, थोड़ा इधर कर लो. सेंटर में लेके आओ. Yeah, नहीं उधर हाँ नीचे करो उसको. Bus, that's it. So this tracker needs to be visible. If you see on your top right hand side screen, and it should be stable. If it moves, then there is no point. Take a line and back little. एक और line and back दो.
Krishna, can we have one screen showing actually the screen which you are looking at? That's not coming up on this.
You're not able to see that?
Not yet.
Just give me a second. I'll ask them to.
We need to adjust that.
Yeah.
Please standing in between, I think.
Are you able to see now? No? We are able to see very clearly here. What screen is not visible? Just in it. So the femoral pin is in the direction of the epicondyles medial to lateral, and the proximal pin ends below the flange of the implant, so that there is no stress riser there. So that is what we do in our unit. In the yes. Little bit more. That's good. And for patients with these sort of medial approaches, it's also advantageous because it will act like a retractor as well. And typically, these have to fan out away from each other so that they are visible. So whatever is this is suitable for the surgeon, they will figure out a method which suits them. I'm just making sure that this is tight so that it doesn't change during the surgery. Right. Let's move on. This looks a little bit. Right. So both the femur and tibia are now visible. If you can see, are you able to see that screen?
Yeah, it's coming now.
Yeah, okay. Can you give me that thing? Yeah. So we'll need to get familiar with the foot pedal. So I'm defining the checkpoint. So Devans was asking whether this checkpoint is reliable. It's very reliable. If the pin moves, the distance between these two will move. and it will show up. What we noticed with the other bony checkpoints was that the checkpoint was moving more often than the pin. So this is the medial and lateral malleolus, and this is the center of the tibia which we calibrated on the long leg film, and this is the center of the femur. Now we will register the hip center. We will just go. इसको थोड़ा लूज करना पड़ेगा. एक सेकेंड रुक जाओ, देखेंगे. लूज कर दो. Loose kar do. So this side support sometimes needs to be loosened, otherwise the error will be more. No better. Right. So wherever it is in green, you can accept. And this is the neutral position for the limb. And I'm doing the kinematic registration. And now we're ready to do the femoral free collection. It was tight kar do wapas.
What is the time when you feel that there is garbage in when you are taking the registration point?
Yeah, I will show you that. So it's important to map this accurately, although this system allows us to overrule it by quite a bit. But I rely quite a bit on the three-dimensional planning, and I'll show you how we do that. So the most important advantage for this system, except for severe deformities or extra-articular deformities where the model is not very reliable, other situations is extremely reliable. So I'm taking extra care to map the whole thing. So I'm mapping the epicondyles and I'm mapping the anterior cortex. Now this is done, this pink thing will allow us to see if we have mapped it accurately or not. So now if you can see, I'm mapping on the apex of the intercondylar notch and it is matching there. Okay, so this is not garbage in, this is exactly, the model is very accurate. Now I'm on the medial epicondyle and you can see that the medial epicondyle is matching. So this is not any model. This is a very accurate model which is almost as accurate as a 3D CT. So it's a way to verify. And now what we do is we look at the anatomic epicondylar axis, that is the angle between the lateral and medial epicondyle and the posterior condylar thing. This is around 4 or 5 degrees. And we know that the surgical epicondylar axis will be 2 degrees internally rotated to the anatomic epicondylars. And this is the posterior condylar axis which I am manually defining. So the first boundary which we do with our restricted kinematic is the rotational boundary. So we will play between 0 and 3 degrees in this particular case. And that is case to case, it is variable. So you calibrate the posterior condylar axis to the anatomic epicondylar axis, and then you recalibrate the surgical epicondylar axis by subtracting 2 from it. You get that? So that's the rotational boundary now I have set. So based on how the soft tissue behaves, then I will use that particular boundary for my surgery, 0 to 3 in this case. So I tend to subluxate the tibia at this stage. It's difficult. It's okay. So give me that. So as Shubhang was saying, we don't need to do the whole anterior subluxation of the tibia. We can just do the anterior third and it does calibrate, but we are not depending upon that for the complete sizing. Anyhow, we'll do manual sizing. So you can see here I'm going back with my thing and I'm able to calibrate the whole tibia even without subluxation. Right. And here also you can do the special point calibration to make sure that it is the tibial spine. So this is a good way of looking at it. So this is the tibial spine and you can see this is the medial spine and this is the lateral spine. So this model is pretty accurate. So now we can go on. we'll just spend a moment on this. इसको बड़ा कर दो, the screen बड़ा कर दो, उसको छोटा कर दो. So you have three options here. You're looking here at the implant planning window. You can look at the bone planning window, and you can look at the axial cut. So these three options are available. It is suggesting that the femur is 5 narrow size. उसको कैसे दिखाओगे? वो कट रहा है, उसको कटना नहीं चाहिए. I'll come back to that as we go on. Just okay. Now you can see. So the size is 5 narrow. Tibia is showing 5. Maybe we'll have to recalibrate that. Implant thickness 9. Flexion deformity 5. Range of motion up to 136. 9 degree of varus preoperative alignment, and it is planning a postoperative default to 0 degrees. So this is clear this time. Okay. So now we go to the next step. And we now look at the deformity dynamically. So this is around 10 degrees of varus deformity, and as the knee is flexing, the deformity is reducing. You can see that in around 15 degrees it becomes 7, 30 degrees 7, then it is increasing a little bit, and then it's remaining constant. So it will give us which part of the MCL is contracted. Now we are looking at the correctability of this deformity. So I'm putting this spreader in, and it is coming to 3 degrees of overall alignment. So it's probably a 3 degree preoperative alignment to start with. And here I'm collecting the soft tissue laxity across the range of motion. All of you got this? So this blue one is the starting point for the knee. So the knee is around 5 degrees of flexion. This is full extension, and as you flex, the knee is becoming more and more tighter. So now, so this is a mechanical plan for this patient, which is showing that the medial tightness is 3.5, and laterally it is 0.9 lax in extension and 0 in flexion. So this is a mechanical plan. So suppose you say we'll do 3 degrees of external rotation. So this is what it is showing, the situation. So now what I'm doing on this is, I will go to the axial cutting window, and then I will make adjustments. Suppose I was doing this is how it is going to look. The fine arrow is going to look like this, and there is a little bit of extra anterior bone which will take out 3 degrees of femoral component flexion, 3 degrees slope. So what we do first is we make adjustment in the slope. So I normally tend to go for about 5 degrees of slope. You can see just by making that, we are making some changes to how the flexion gap is. The tightness has not disappeared. Could you see that? Next, what we do is, so this is a joint line on the tibia, that is a joint line on the femur, but this is not the native inclination. So I'm going to give 3 degrees of varus to the tibia. And once you do that, automatically the gaps have further changed. You saw that we didn't do anything yet. Now I want to do about 1 degree of valgus so that my overall alignment is 2 degrees of varus. And because it is a little bit lax here, I'm going to reduce the tibial cut. And you can see here that the extension gap is more or less balanced. We have noticed that if we pre-balance it to 0, 0, then you're putting a thicker polyethylene insert in some of the situations. We don't want to do that. So we know that the 9 mm lateral side is not affected that much. There is about a millimeter or 2 of weight on the medial side. So the femur is almost native. And the tibia, we are changing from 6, 7 degrees of varus to 3 degrees. So that is the adjustments we are making. So that the overall alignment is like this. Now I will antagonize this femoral component to make sure that my flexion gap is balanced. Got it? So this is matching, and I will reduce the slope so that it is sitting flush with the anterior cortex. So these sort of adjustments you can never make with manual surgery. So we converted something which was a 7 millimeter tightness on the medial side to just a 2 millimeter tightness without doing anything, by just adjusting the implant in 3 dimensions in 14 degrees of freedom, that is varus valgus, flexion, extension, and rotation. So our combined sagittal angle, that is the angle of the femoral component flexion to the posterior slope, is manipulated between 0 and 10 degrees. The combined rotational angle 0 to 3 as we planned before the surgery based on individual patient, and combined coronal angle should be plus or minus 3 degrees or 4 degree varus to 3 degree valgus with which you can play. So now your surgery is already done. You just have to execute this plan. So now we're doing, yeah.
Just one point, just go back to the screen.
Okay, okay. Right.
So here, like the posterior condyles from medial side, you're taking out 12.5 and from lateral 10.
Yes.
So what is your upper limit? How much bones you will take out before you move on to the sides?
So up to 3 millimeters is okay for me. Because each degree of rotation will take about 1 millimeter of bone. So this is not strictly kinematic with respect to the this thing, but I can go back and do 0 degree rotation here, and maybe take the implant a little bit back. And this will also work. So you don't need to do it where I am creating a little bit more laxity in the lateral compartment. I'll reduce a little bit more tibial cut, and I will balance this thing. So this is also okay. Anything which is 4 millimeter or less of tightness can be balanced. Are you with me?
Good.
Yeah, so this is okay. So we'll go with this one. So now you can verify here whether the cutting block is sitting properly in the center or not. And then you go on and go to the verification of the checkpoints. No. I'll show something else. I'm not doing the pin peg, but I'll show you something else, what I normally do. So this is the checkpoint, and this is the tibial checkpoint, and now we are ready. Okay. Bar initial cutter, है ना? ठीक है. So now this part of the operation can be done by anybody. You can ask your assistant to do it. So I'm just checking with the burr if it is sitting exactly on where the model has been generated. This looks pretty okay. So I will take out the. So this is pretty fast. Vaibhav, I think, is showing the burr all technique, which is also pretty okay with this particular implant. It is with this system, you can do the burr all. So we call this as extended restricted kinematic alignment because we are using coronal plane boundaries, we are using sagittal plane boundaries, and we have also described the rotational plane boundaries. And we have sent it for publication. I don't know whether they will accept what we are saying. But I thought it's a very scientific way of doing surgery. And we looked at our alignment and gap tightness with bony adjustments. And we found that majority of the patients with mechanical alignment, more than 60-70% had significant gap tightness on the medial side, which requires soft tissue releases. But if you do subtle adjustments within the acceptability of even plus or minus 3 degrees, your soft tissue releases come down to around 20% of cases, from 50 to 60%. So this becomes a much more calibrated way of doing the surgery. And I suspect the sagittal positioning of the femur and tibia is a problem with manual surgery, which we can never overcome because the tibial slope and the femoral flexion are very subjective.
But that are you able to have their assessment scores by forget means or whatever the score you're using it to have that advantage right now?
Sorry?
Are you able to evaluate them clinically also subsequently in the follow-up whether this is being benefited or not?
The patients, yes, sir, we have looked at we have looked at 400 consecutive patients. With 200 we have done with this restricted kinematic philosophy, and 200 we have done with mechanical. And definitely in the first 6 months, the restricted kinematic are much better. The scores are better. After 6 months, they tend to equalize. So now we've made the very initial surgeons will have difficulty with the positioning of the lug hole sometimes. We don't need that. थोड़ा इधर का मैलेट दे दो इसको मैलेट देना इसको इम्पैक्टर होता है ना टिबियल इम्पैक्टर So generally, we have seen that there is no need to cross-check any of this because it is very accurate. We are just being suspicious because of our inherent suspicious nature. The system is very accurate. ये सीधा हो सकता है? नहीं, ये थोड़ा टेढ़ा है ना, उसको सीधा. ठीक है, no problem. Just इधर लेना. So you can see that we have actually made the component 0 degrees, but we have not notched it. So there is no flexion. So that is the accuracy of the system. You can recreate anterior and posterior offsets. Retractor very safely. लगा देना. बस. Now you can drill and then fine tune the whole thing to see if there is any error with the saw blade. So you can go to the barrel and check if everything is fine. So generally, if you're careful, and if there is some bone left, you can still, make it fine tune that thing. So this looks pretty okay. You can just fine tune the whole thing. So beauty is you can use it as a hybrid system. You can use it as a burr. You can use it part burr and part saw to make the workflow more optimal for the individual surgeon, whatever is your preference. सीधा वाला दे दो ना स्ट्रेट वाला दे दो हटा दो ये हटा right. So now we have taken out the femur, done the femur. So now we'll do the tibia. Starter. So what we do with the tibia is, give me the tibia cutting group है अपने पास रखते नहीं हो तुम लोग नॉर्मल वाला नहीं नॉर्मल कटिंग ग्रुप लगाते थे. So now we'll put this on visualize cut and use this as a navigation tool to make the. You can blur all the blur the whole thing out. लगा इसको लगा दिया बस ठीक है दे दो जीरो कर देना. So you use this tibial cutting block as a template for the thing, and you use a cut check here. And you can see that okay, you are able to position the jig exactly where you want. Within about a millimeter or so. So people who have used navigation, it is very simple for them. It's a 1 minute process. And then you can always go back and fine tune it with the burr. I find that the burr is a little bit more messy for this particular step. So this is much more convenient in my hands. But somebody wants to do burr, they can do burr also. So you can see that the medial side is a little bit tighter. So maybe we'll have to do a little bit of soft tissue release at some point in time. That's okay. Simple little.
Basically picking up the right thing from the robot and then doing whatever else can be done.
Correct, correct. So the robot is an intelligent assistant. It is not your replacement. So you are the boss here, Nibler.
There are no haptics to stop the saw.
So your hand is a haptic. 20 years of experience is a haptic. So you do if you need haptics to if the robot is operating, it requires haptics. Surgeons don't need haptics. But you can choose to do whatever way you want. It will empower you. It will not make you a slave. That is the idea. So you should not become a slave of technology. You should use it as a slave. You should not become the slave of the technology. So we know what is right, what is wrong, based on so many years of experience. We are trying to calibrate what we are doing and fine tune how good a surgeon you are. So you'll become better and better as you keep on doing this thing. So I have realized that the manual surgery also becomes more accurate and more superior with this sort of a. So now I'm fine tuning this thing. You can see that my solid was also pretty accurate. So we don't need to do any more cut. You can see that the cut was pretty accurate.
If we are doing with the robot, we should have everything.
Yeah. Then lift curve, disc lift, femur lift curve. So now we will fine tune the knee and see the trial reduction. Wait. 3 देना मेरे को कर्व्ड ऑस्टियोटम दे दो और हैमर I'm taking out the posteromedial osteophyte. So it has been shown that up to 3 to 4 millimeters of laxity tightness can be adjusted. So if you notice, this we cannot calibrate on the before you do the osteophyte removal. So up to 3 millimeters, 4 millimeters of medial tightness we must leave. We must not try and pre-balance the knee to 0, 0. So initially when you buy the robot, there will be a tendency to go overboard with the numbers and try and pre-balance it. दूसरा दो ना ये काम नहीं कर रहा पकड़ रहा नहीं ये पकड़ कुछ और सब दूसरा I'm just removing the posterior horn of the medial meniscus. So what we have noticed is instead of pre-balancing the knee completely, we will balance the unaffected side, that is the lateral compartment in varus knees and medial compartment in the valgus knees. And we found that up to 4 millimeters of laxity, you'll be able to manage tightness on the medial side. Affected side can be managed with excision of the scar and the osteophyte removal.
That you take as a physiological limit of it.
That is based on our own experience. It is 3 to 4 millimeters of tightness. You don't need to worry about it and resect extra bone. So initially we will just accept that 3 to 4 millimeters. But what we were doing is we were trying to make the tightness equal in extension and flexion. So that if you want to do a soft tissue release, 3-9 trial, then it becomes easier for you to do the soft tissue release because नहीं मेरे को trial दे 3-9 दे दो यार 9 only दे.
So what robot and this technology tells you is this osteophytes and soft tissue release, how much to do, that is not going to take, right?
So it cannot make anybody into a surgeon. Robot will not make anybody a surgeon. If you are a good surgeon, it will be an additional technology for you. So just because you buy a Tesla car, you will not become an expert driver. You will not become Michael Schumacher. You have to still do the job. So if you see, our flexion gap is slightly trapezoidal as I had planned. I wanted the lateral side to be a little bit tighter. We're creating a unstable.
Krishna, if you happen to see bigger osteophytes in that area posteriorly, so will you be taking it more compromise on that level of 4 or stiffness level?
Yeah, you can go up to 4 millimeters, sir. Beyond 4 millimeters, it becomes into the territory. Now, if you can see here, you can see that this is nicely externally rotating. The rollback is happening here. Medial side is nicely located and the lateral side is rolling back a little bit because we have created that sort of a laxity in the flexion gap where the lateral is slightly open as compared to the medial side. The medial side is well balanced. So this will function like a medial pivot in flexion. And you can see that I'm getting full extension. And there is no laxity in extension. This is 2 degrees of varus, which we had planned, 2 degrees of flexion. And it is internally rotating to 5 degrees, which is a screw home mechanism. You can see the internal rotation of the femur there is 5. And when we flex the knee, the overall element still remains in 1 or 2 degrees of varus. And this is the laxity pattern across the joint, where the lateral is about a millimeter or 2 lax as compared to the medial side. But it's about well balanced and the alignment looks okay. When you look at, I'm not giving any rotation, but the patella is tracking very well.
How much laxity will you accept laterally? 2 millimeters, 3 millimeters?
So in flexion, up to 2 millimeter, extension 1 to 2 millimeters, okay. But you also always have a choice of releasing a little bit when putting a level poly. In a valgus knee, you cannot accept laxity on the medial side because medial side is inherently tight and lateral is inherently lax. Injection do. Two pins, Nicole. So now we are ready to take out the pins and then we will prepare and cement it. So if you want to proceed with the program, you can, or you want to see me do it, I will do it, no problem.
Shubhang, in the absence of Dr. Shubhang, we can carry on.
Yeah, I think you can carry on. That's the thing. So the major part is all done.
No, you carry on. We are watching.
Aja, you're watching. Okay, fair enough. Yeah. Nicole. So there is also a slight tibial osteophyte here. So once you remove that, the 1 to mm tightness on the medial side, which is causing the lateral laxity, will reduce. So we don't need to increase the thickness of poly. It will be 9 mm only.
How often it has happened that at this moment you might have found something more than what was there and you needed some more correction?
It has never happened in so far. So it is it's extremely rare for me to put in. I don't remember putting in a 9 millimeter poly. Straight like this. Straight wala straight. Right. We can see here a little bit of osteophyte is there, and I'm not released any sleeve. It's almost like a UKR. So some of our patients, we looked at our patients, the pain scores are similar to that of UKR. Because there is not much soft tissue release we are doing anyway. I'm just fine tuning that medial tibial osteophyte. Okay. One thing this robot doesn't tell us is the rotation, but that is taken care by the implant because this is an asymmetric implant. What we are looking at is a line from the center of the PCL to the middle third junction of the tibial tubercle, anteroposterior dimension of the lateral tibial condyle, and we are also looking at the matching of the tibia to the anteromedial body of the normal tibia here. So these 3 landmarks you are using. वो लोग एक ही लगाते हैं. Tibial preparation दे दो यार. Cement mix कर लो. नहीं है. So 3 landmarks: AP dimension of the lateral condyle, center point of PCL to the middle third junction of the tibia, and anteromedial border of the tibia. And you must do this in reverse. This thing, otherwise it will remove the bone. Also, कर लो. Cement mix. Implant open. Sometimes these pins fall into the tibial holes. You need to be cautious. Also कर लो. Mix कर लो cement यहाँ. Yeah, please mix. Injection दे दो मुझे. Yes, 1 second. Give an injection.
How often do you use flexing the femoral implant as a tool to correct the flexion extension gap?
Yeah. So just like in this case, we have extended the component and made it 0. Sometimes we go up to 5 degrees of flexion to make sure that there is no notching. Whenever I want to optimize the femoral size. So this implant allows us to lift करो. Injection दे दो. Allows us to use a narrow femoral component. So we don't compromise on both anterior as well as posterior offsets. And you see, I have not touched the PCL. I have not recessed the PCL. So 99% of my patients, we don't touch the PCL, irrespective of the deformity. Last 400-500 cases, we have recessed 3 PCLs, if I remember rightly. And it's an evolution for us also. Sometimes you think, अरे stiff knee है इसमें, अरे injection दो यार. देना है, cocktail नहीं दिया. So मेरे को हाथ पे दे दो, वो सब जरूरत नहीं. Just on hand. I don't need all this. जो है वो दे दो यार. उसका जरूरत नहीं है. एंटी वो दे दो ना. Xylocaine. बोलो. तुम लोग नहीं देते normally. Okay, we'll do it later. Okay. So the injection is not ready.
Cocktail is not ready.
Cocktail is not ready. I don't know why.
I think they had all of it last time.
When you were operating before surgery only, it was ready. I think when Shubhang was operating.
No, sorry, don't create bias.
They will always be biased. Sir. They are not afraid of me. They are afraid of you.
Amit.
But the thing is, it is exactly as it is back home. Even they are not afraid of me. So you can, it is an important step to inject the cocktail into the posteromedial corner. And also underneath that vastus medialis, it will work like an adductor block. I think Vaibhav has published it from his unit, where they give an intraoperative adductor canal block. Very interesting. 2.5 drill लगा लो.
Yes, and we are doing that also, Dr. Kiran.
Yeah. I saw that you are giving before the incision. I think it's a very good idea because the pain will be lesser.
No, there are 2. So we do one in the posteromedial.
Yeah.
There are 2 different cocktails. One is pre-incision.
Yeah.
The second cocktail is given at this time in the posteromedial corner.
Okay.
And then we do the adductor canal block.
Okay.
Surgeon administered adductor canal block. We copied from Dr. Vaibhav's study.
Yeah.
And it's doing quite okay so far.
It's excellent. Actually, Vaibhav's idea is very good because I think Dr. Nilisha is doing subvagus approach, so they're already doing the adductor canal exposure.
What exactly was used in cocktail?
In our unit, we use ropivacaine with clonidine and ketorolac.
Okay.
We give a continuous adductor canal block post surgery, and the block is with the patient. It's on their. It's a continuous block, like a
indwelling catheter.
That's right. So some of the patients who are more sensitive, we send them home with it.
Okay, so we don't do any indwelling catheters. So we are giving these patients, the study is between what the anesthetist is giving and plus what we are giving. Okay. Medial will go to everyone anyway.
Yeah. I'm sure it will be efficacious. Vaibhav has shown that, so it should not be different in your case. But it's a useful thing.
Yes, and our use of opioid has drastically gone down.
Oh, okay. Yeah. So we don't use opioids in our unit. Also, impact ले लो. So this is a sort of a personalized knee arthroplasty. So the values are not fixed. They're based on what we calibrate before the surgery, and also the gap patterns and the bone resection patterns on the screens. But it is perfectly okay to do mechanical alignment. It will still allow us to calibrate the soft tissue releases precisely, whether it is needed in extension or whether it's needed in flexion, and it will avoid unnecessary soft tissue releases. I believe that we should do the implant with the least possible constraint for the patient, but that is my personal belief. We do not have evidence to say that doing that is superior to one is superior to another. No, impact together. One status. Will hammer. Okay. ये हटा दो, ये हटा. Right. So you can see that the surface area of marine is actually better than that of a saw. Narendra, the Vaidya is talking in the morning. It's actually better. In sclerotic bone, it is much better. Again, we use cement both on the femur and both on the tibia, so that the penetration is better. So Dr. Vaidya can afford to fly his whole team. I cannot. So I prefer to operate with different challenges.
Let's wait for a few more years, then you'll also. No, I think you just have to ask. You have the privilege, you should have just said it. We have very.
So he's with Dr. Sen for such a long time. So he helped me with my case yesterday. I reject him today. So we should operate in different circumstances. That will give us an idea as to how good we are. We should challenge ourselves. So he's talking in Marathi also. So that is not great. I would prefer to learn Punjabi. Extended.
I have a question for robotic surgeons. Not only about in preventing the complications of embolism.
So the incidence of embolic complications is very low. If your surgeon is into bilateral replacements, there is evidence that we should not use a tourniquet and we should use some sort of technology which allows us not to violate the medullary canals. So both slow and good. So we open the medullary canal when four canals are opening both tibia, both femur. Using a tourniquet also, then it is not a good thing. Like that, and we remove the residual cement and then we down.
Thank you.
Thank you very much.
It's wonderful. I think you can listen to the clapping around. It is wonderful.
Thank you very much. Thank you very much.
So now.
Good. ठीक है ना you can do it. We are doing the pin which is close to the heel.
We're just
So
realigning the things, just saving time because he's going for the surgery after that. So he would require a little bit time to get ready. So we are just jumping onto this.
So thank you, Chairperson, once again, and I'm glad that the discussion has already been initiated for this. So my brief today is to talk about the surgeon administered direct adductor canal block. So we all know that this pain management has evolved, and we discussed about. Sorry. So the pain management is something I think that I've learned is one that makes or breaks you as a surgeon. The patient is having too much pain after the surgery, it certainly disreputes you. And as someone told me that whether your surgery has been successful or not successful is determined on day one, and that is when the phone calls are maximally received by the patient in the evening by their relatives. If the patient is in pain, your surgery has not gone well, irrespective of what alignment philosophy you have used. So today I'm talking about a specific technique called as direct adductor canal block. We know that the pain management has evolved over time. And in this talk, I'll talk about the rationale of why and how surgeon administered direct adductor canal block work. We'll touch upon the anatomy of the adductor canal, the technique, the content, our experience, and the advantages and limitations. So of course, we know that adductor canal blocks work, and that's been proven beyond doubt in numerous studies. And we have moved from an era of femoral canal block to a more motor sparing adductor canal blocks. Before I move on to the actual subject, I just want to touch on the anatomy. And around the knee, there are 10 nerves, and it is supplied by femoral, sciatic, as well as obturator. So there are branches of all three major nerves that supplies the knee. And this is roughly how the knee innervation looks like. Now, the rationale for use of DACB, as we discussed, is that we are just there in that area. As a surgeon, we know that the place of interest is this, which is the lower half of the adductor canal. So this is where we are, and that's the topmost part of our implant prosthesis. And this is how it looks like. We know that there are nerves here, and they are very close to our operative site. So how do we prove that it is feasible to do it? We did a CT scan study, we followed it up with a cadaver study, and we did a randomized control trial. Something that any new technique has to be done in these three things. So just how the traditional adductor canal blocks work is this. This is the femoral artery, femoral vein, and that's the saphenous nerve here, which we are targeting. But we need to be mindful of the fact, or it's an advantage, that the block is not targeting just one nerve, but it works on the phenomena of infiltration or of volume infiltration. So a large surface area which is being infiltrated by a good amount of volume of the anesthetic agent. And that's how it works, unlike the other blocks which we gave, which is more targeted toward a specific point or an area. It's a large area when we look at the adductor canal blocks. So previous studies have described how the adductor canal look. And in our studies, we did this. We actually did 100 CT scans and found out how is the entry point. So if we made an entry point, which we hypothetically assume 2 finger breadth above the anterior flange, this is how it looks. So in this, you will see that this whole area is the area which is amenable to be infiltrated by the high volume anesthetic. So this is the entry point. This is the starting point of the adductor hiatus, and this is the target region. And you'll see that a normal needle, even a small gelco, is able to reach anywhere from this point to this point. And this was the hypothesis that we had. And then we did our cadaver studies. We had the feasibility, whether it is possible in cadavers or not. We first did this our own measurements on the CT, and then followed it up with a cadaver study where we, as a part of the Bombay Orthopaedic Society workshop, we had these cadaver dissections. So we injected methylene blue by using this and seeing if the stain actually happened when we are injecting in cadaver. So you'll see this is me injecting it here, and the technique of doing it on cadaver. So you have this needle, we have got methylene blue here, and you'll see the 2 finger breadth above the flange. We make the entry point, and approximately 10 to 30 degree. And as I said, approximately, because there is no need to be very accurate on the trajectory, that if you put that high volume, the whole adductor canal gets stained, and this is proven on the dissection there. So this is what we did. We injected, aspirated it, and then injected it. So this is how the cadaver study was done. And then later, as I said, this is the diagram that we use in the paper that we published. That this is how our entry point should be, and this is the direction of the needle when you are giving this block. Of course, it has to be supplemented with periarticular injections, and these are the different zones which has been shown to have maximal impact of pain relief. If we give in all these 8 zones, it will be good. And I call the DACB the zone 9 and 10. This is how it looks intraoperatively. This is the femoral flange, just 2 finger breadth above. You give it, and I'll show it on video. You see, we are just injecting. You will feel a give way, aspirate it, and then slowly inject it, and gradually withdrawing your syringe so that the whole area of the infiltration happens. And you will see that there's nothing too technical about it, because you are not targeting a single point here. So this is the technique of direct adductor canal block. We published it and we compared it with our colleagues. Dr. Nilensha always puts a continuous block, and we did not. So we had a comparative group between the 2 groups, and we found that it works as good as ultrasound guided block. Our content is bupivacaine mostly, but liposomal bupivacaine, if available, is good. But nowadays we have shifted to more sensory things, which is ropivacaine. We divide it into 2 parts. One is the deeper infiltration, and one is around the skin. So around the skin, I don't use adrenaline and ketorolac, where I use the pure dilution of the ropivacaine. So this is our preference for the block. Of course, one should be mindful of the arterial or venous puncture. If you're going too high, you can have a motor blockade, anesthesia toxicity. So it is shown to work as little as 2 ml. The toxicity is reported at 120 ml. We give far less, around 20 ml there. Of course, there could be failure of BOC, nerve injuries, and breakage of needle tip. One complication that I have not mentioned here, but in last 500 cases we have seen, is that sometimes we do puncture the femoral artery, and it's always important to aspirate it. And once that happens, I abandon the block. And because the needle are so small, it's like just drawing a arterial puncture. So that's it. Thank you for your attention. And any questions on the technique, you're welcome.
Thank you, Dr. Vaibhav. I think, did you have any time a kind of that it was not effective?
So see, because it's a multimodal analysis, it's very difficult to say that it has, whether one particular thing has worked or not, because it's not an all or none phenomena. So that's why we did a study where we compared it with USG guided versus non-USG guided at the mean VAS scores and breakthrough pain episode. So we found that they are comparable. It's very difficult because it's not a single intervention. Whether only the DACB has worked or whether so many other things that you do. You give periarticular anesthesia, you give pain medication, you give patch. So it's very difficult to say work or not work. Absolute differentiation is very difficult. So I use the standard Gelco needle, the intracath. You don't even need a long spinal needle, just that, because the area is very wide and the lowest point can be as close as 15 millimeter from your 2 finger breadth above your entry point. The adductor hiatus is just there. So the lower half of adductor canal is very, very close. As we said, in even the when you're doing subvascular approach, you are just there at just that point. So why let anyone from outside put something penetrating the skin, and that to a member of other team, when you yourself are in that area and can do that?
That's a wonderful thing. If there is no question, thank you, Dr. Vaibhav.
Thank you.
So now I'll invite Dr. Tomar to talk about defects on the tibial side of the total knee replacement.
Just for better management and paucity of time, we are just continuing with this chairpersons of the previous session, because there are only 2 or 3 talks left. So please be with us.
Good afternoon, everyone, and thank you, Shubhang and team for this invite. So my talk is on defect in primary TKA. I think we already have heard so much about the total knee arthroplasty, primary robotics, and all the details. And this is just to fill up this symposium. So bony defects in primary TK is a very frequent problem because most of our patients present very late and with great deformities. Identification of deformity, this defect is important to avoid malalignment. Otherwise, poorly managed defects may lead to early revisions. And in primary total knee arthroplasty, the defects are more on the tibial side. The various causes are osteoarthritis rheumatoid, because of varus deformity in the osteoarthritis, valgus in the rheumatoid, hypoplasia of the bones, osteonecrosis, post-traumatic, and the previous high tibial osteotomy may lead to bone defects in the tibia. So it is important to identify the area of the defect and assess the depth of the defect for proper management. And in primary TK, relatively the defect side is relatively harder and the sclerotic subchondral bone. So to classify, the classify is based on the Rand's classification. The depth it is basically divided into three types, A, B, and C. If depth is less than 5 millimeters or the condyle area involvement is less than 50%, depth 5 to 10 millimeters or 50 to 70% condylar involvement or more than 10, 70 to 90% condylar involvement. And Dodd described it central or peripheral, contained or uncontained defects. So in varus deformities that we come across most often, it is on more posterior medial side, a peripheral defect. And in valgus knee, usually it is the central defect, that is the lateral tibial plateau. And in bone defect, in the high tibial osteotomy cases, is usually on the posterior lateral corner of tibia, and we have to be careful about tibial slope correction and patellar tracking in these cases. Insole also modified, and the classification is based on the depth and the condylar area coverage. Our Anderson Orthopaedic Research Institute classification is very popular for the revision cases defects, but can be used in the primary TK defect also. Preoperative templating is important in all the cases, but it gives only tentative idea about the planning, and we have to be ready for what to cover those defects. But peroperatively, only the peroperative we are able to decide how this defects have to be taken care of. So the tip is, initially we take only 8 millimeter cut is preferred, and then measure the defect, and then they decide after how this defect has to be taken care of. And the various options are increased bone resection and using the thicker poly insert, which is the simplest option, translation of component away from the defect, use of bone cement or augmented with the screws, bone graft, autograft, or these allografts, metal bases, augments or intramedullary stamps, and metaphyseal consent sleeves may be used in the severe deformities. So increasing bone resection is the simplest way to deal with the defects. But as we go down, the strength of bone diminishes, and it diminishes by 33% if we go 2 centimeters below the tibial plateau. So we have to keep, maximum we can go down is at the level of head of fibula. We can't go beyond that. Translation of tibial component, if it is the condylar involvement is less than 50% of a single condyle, but it is not the preferred method because of the early loosening of the tibial implant associated with this. Filling with cement, if peripheral deficiency of less than 5 millimeters and the condylar area involvement is less than 10%, then it can be filled with cement. And most of the cases we do this only, but it is a least desirable option if more cement is to be used, because cement may fragment, may shrink, and may cause thermal necrosis. But in most of the cases, like when area seems to be bigger, so with reduction osteotomy, area becomes lesser, and if its depth is less than 5 millimeters, we can drill that area without removing the subchondral bone and can fill it with the cement. If the depth is more than 5 to 10 millimeters, for more than 5 millimeters up to 10 millimeters, it can be filled with cement without removing the subchondral bone, and can augment it with these screws. It provides screws only provides a level surface upon which it can seat the implant. So this is a case where the defect is around 10 mm. Can be the graft can be this can be cement with the screw augmentation can be used to take care of the defect. So bone grafting is a preferred method if peripheral bone defects are more than 50% of condylar area and the depth is more than 55 millimeters rather than using a cement. So we can use the autografts, and preferably we have to use the subchondral bone, the harder bone, and the graft which has to be used should be either reverse trapezoid type or the stab cut graft for the stability. So this is the technique that most of us keep on doing on regular basis. So we have to use the remove the subchondral bone and use the graft from the distal femoral cup or the proximal tibial cut. And we fasten in this fragment and fix it with the screws. And whenever cementing is done, we have to be careful that cement doesn't intrudes inside the host and bones in the bones graft surface. So this is a patient with the severe deformity on the posterior medial condyle, is almost 20 mm. So taken care of by graft fixed with the screws. Here, when deformity is more than 10 centimeters, so we need to use a stem also. Stem extension is to be used. Graft, whenever larger grafts are used and autografts are not available, can use these allografts also if the bone bank facility is available. Otherwise, then whenever graft is not sufficient, then the custom wedges can come for the rescue. They are preferred when the defect is more than 1.5 centimeters in depth. This provides excellent support. The other types of wedges are also available. So this is a simpler and attractive option, but there is questionable durability of wedge fixation to the tibial tray. So this is a case with severe deformities. We have to be ready because the graft doesn't seem to be available in these bones. So this left side was fixed with the wedge. The right side was fixed with was taken care of by the graft, and both stems were used in this case. Extended intramedullary stems relieve stress in deficient bone in metaphyseal area. More than 10 millimeters of deficiency defect is there. So it's indicated for defects greater than moderate size. Controversy exists in cementation of stem. So cementation is preferred only in the proximal part. So recommendation are small size defect less than 5 millimeters, filling with bone cement, medium size defect 5 to 10 mm, cement with screws or autologous bone graft. Large size defect more than 10 mm, so autologous bone graft with stem in young active patient and metal wedge with augments in the low demand elderly patient. More than 20 millimeter defects consider sleeve cones and semi-constant or constant implants. So to conclude, be biological as possible. Secure the prosthesis in two fixation zones, and bone grafts use should be preferred to preserve bone stock as patient may need revision surgery. These are my acknowledgements. Thank you very much for the attention.
In your practice, how many percentage you would use stem in varus bone cuts?
Stem in almost I can say almost 20% cases we need to use stems, because most of the cases come with the deformities and the defects are larger than almost 10 millimeters.
Thank you very much. Oh, now I invite Dr. Aggarwal from Shimla, and he will be talking on managing defects on femoral side in total knee replacement.
Good afternoon, everybody. First of all, I thank Dr. Shubhang and his team for inviting me. And thank you, Chairman Sirs, for giving me this opportunity. I will also like to declare right in the beginning that I do very little replacements as far as knee is concerned, but I'm primarily a tumor surgeon. So my talk would be on femoral defects, primarily in tumors. Causes of bone defects on the femoral side, these are the ones. And I have added oncological resections as the last, but that is. So as Dr. Tomar has already covered part of the talk, the bone defects can be contained or cavitary and non-contained or segmental. Classifications, he's talked about the RAND, there are DOR and INSAL classifications. But the classification that seems to be very popular today is the one he described as the Anderson Research Institute of classification or the ORI classification. The tibial defects are T1, T2, T3, and this is how they are sort of classified on the tibial and femoral sides. However, there are always, no classification is perfect. The drawbacks of this classification, the ORI one, which is popular today, it does not address the rotational instabilities, does not account for diaphyseal defects, situation where implant remains well fixed and patellar bone loss. And as mentioned here, no classification is ideal. So bone defects in TKR, most moderate and severely deformed primary knees have defects. Most revision knees have significant defects. How do we assess them? Preoperative assessment can be based on X-rays, opposite knee X-rays, CT reconstructions, and intraoperative findings. What to address in bone defects? Restoration of longitudinal, angular, and rotational stability, restoration of the joint line, soft tissue stability, and reconstitution of bone. And that is the joint line reconstruction part. That the need to restore the joint line also defines which bone defects need to be reconstructed. Bone defects that need to be filled between remaining bone and the implants, joint line restored using trial components stabilized by stems, and then MCL and LCR isometric and taut as normal. Just an algorithm defining what are the options available. Cement with screws, impaction grafting, metal augments, cones, sleeves, bulk structural allografts, and of course, if the epicondyles are missing and type 3 defects on the femoral side, a rotating hinge implant or a megaprosthesis is one that is preferred. Which implant? There are many options: posterior stabilized, unlinked, constrained, rotating hinge, or modular prosthesis. So the options are cement and screw, bone grafts, modular wedges and bone augments, porous, cones and sleeves, and megaprosthesis. Cement and screw, primarily meant for after bony cut measure, less than 5 millimeters and less than 50% bone surface area. 5 to 10 millimeters of defects can very well be reconstituted or reconstructed using a cement and screw. Increased bone resection on the femoral side, we have to be beware of, because don't try to resect the defect. The strength of the bone, as already mentioned by Dr. Tomar, decreases by 33%, 2 centimeters below the tibial plateau. Why not more than 10 millimeters? Because thermal necrosis, shrinkage of cement during polymerization and lamination. Cement augmentation, primarily meant for peripheral deficiencies of less than 5 millimeters and less than 10% of condylar radius. Bone grafts could be autologous, allogenic, impaction, or structural bone grafts. And these are some examples of bone grafting where the bone grafts have been used to fill up the defects, and then the implants have been positioned. Indicated for peripheral defects more than 50% of condylar area and depth of more than 5 millimeters and filling of central deficiencies. Autografts are available from bone cuts in primary TKR. In revision, iliac bone grafts can be used. Allografts, usually from femoral heads. For massive bone loss, distal femur or proximal tibia is used. So this is bone grafting technique. Exposure to the salient points are exposure to the bleeding bone, precise fitting of the graft onto the defect, rigid fixation with screws and wires, and then component coverage of the graft. The options for major defects is wedges, augments. They act as space fillers and substitute bone. The others could be metaphyseal fixation in the form of porous sleeves and porous cones. Indication where bone stock is poor, impaction grafting fails to achieve implant stability, and additional longitudinal and angular support is required. Advantages: biological fixation, fill large defects, immediate additional structural support, and also provide rotational stability. Disadvantages: lack of bone stock restoration, removal of additional native bone, and in case of revisions, the removal of these wedges and cones is challenging. So this is one of the example where the cones on the femoral and tibial side where the longer stem has been used to solve the problem of a femoral defect, a type 2A Anderson defect on the femoral side. Metaphyseal sleeves are appropriate for type 1 and type 2A defects, and the cones are appropriate for type B and 3 defects. And this is one of the pictures copied from literature where they have shown on a bone model how a cone can be initially placed inside the femoral side and then augmented with the implant. So these are just a picture showing a metaphyseal cone, and this is a radiograph of the same. The role of megaprosthesis, these are from my personal work, but they are primarily pertaining to osteosarcoma. So this is a young child. We did a 3D reconstruction of the entire area that had to be sacrificed so as to achieve wide resection of the tumor margins. And then it was reconstituted using the implant is 3D printed implant. And then we had used a rotating hinge platform design to reconstitute the defect. Another example, reconstitution of a massive distal femoral defect after wide resection of the osteosarcoma. This is a case where a giant cell tumor was operated with extended curettage and a sandwich grafting technique, got infected. First stage, removed the implant and the cement, applied an external fixator, used cement as a spacer, and then in the next stage, reconstituted the whole defect with a distal femoral rotating hinge tumor megaprosthesis. This is another example of a girl, 8 years old girl. Here I have used a 3D printed implant to bridge the massive defect after resection of osteosarcoma. This is a growing implant or an expandable implant as it is called. And again, it is 3D printed by this company because it doesn't come in off the shelf. Sometimes with these extensive procedures, you require additional procedures in the form of medial gastrocnemius graft, flaps and skin grafts to cover the defects which are left, soft tissue defects which are left after implanting megaprosthesis. Non-oncological use of megaprosthesis could be in revision TKR, infected TKR, and periprosthetic fractures with loose implants. And this is one such example where initially everything failed and there is a large type 3 Anderson defect on the femoral side. So everything got infected also, everything removed, cement nails, cement spacer applied as a first stage and then converted into a megaprosthesis. So this is just an algorithm for the same, defining what are the indications and the use of megaprosthesis and other defects on the femoral side. Thank you.
Have you ever used the megaprosthesis in non-union of the lower femur?
No, sir.
Sometimes the patient comes with the 2 or 3 surgeries in the lower femur and it doesn't unite. And I think it is very beneficial if we remove that part and replace it with the megaprosthesis and patient become mobile after a few days.
I agree with you, sir. That is reported as one of the indications for use of megaprosthesis in the lower extremity. The problem with megaprosthesis, because I primarily deal with the oncological resections, is infection rates are pretty high. In oncology, the infection rates of megaprosthesis are nearly to the tune of about 20%. And once it gets infected, the revisions are
very
difficult or impossible.
Yes.
I have had at least 3 or 4 situations in the past since I started doing this, where it had to be actually amputated. I mean, there was no other option.
Yeah, no other option is infection. But after trauma, I have seen that there is very little infection if you remove the part, because if even with 2-3 trials, the fracture doesn't unite. So I think it is better to replace it with the mega prosthesis and make the patient mobile.
Many of in trauma cases, the fractures in distal femur could be open actually. Again, the problem comes that open fractures, multiple surgeries is not uniting. The infection is controlled, but the fracture is not uniting. Should you convert to a mega prosthesis or not?
It's
an individual
But
decision.
you should rule out infection and only then attempt the mega prosthesis.
Quite right.
Thank you.
Thank you.
Again, extending is that periprosthetic fractures in femur after total knee replacement.
Yeah.
I think mega prosthesis is one of the
Yeah,
options.
it could be one of the options. Yeah, it is one of the options described both in text. And I believe now more and more people are actually doing mega prosthesis for non-oncological resections. Actually, primarily people started doing mega prosthesis for oncological resections like I'm doing. But gradually people are shifting to non-oncological indications of mega prosthesis use. And they are finding it to be a very reasonable alternative vis-a-vis other alternatives. Agreed.
Thank you very much.
Thank you, sir.
Last talk of this session is by Dr. Shubhang. And he will be talking on outpatient TK.
Thank you, sir. So the topic is outpatient TKR. Can we do it in India? Misconceptions about TKR. Very, very painful operation. Significant risks. You need to go into the ICU. It requires multiple blood transfusions. Takes 3 to 7 days in the hospital. Requires extensive physiotherapy. Requires walking supports for 4 to 6 weeks. So obviously outpatient is out of question. But the only thing constant in life is change. And if we do not progress, we will become irrelevant. This is a patient of ours. This is 4 hours after surgery. Same time, getting up and walking. Old man, right knee operated. You see the quadriceps power. He was able to get up on his own, obviously with the support of a walker. How to get this result? Obviously, do a perfect surgery. Manage your pain well. Pre-operative counseling and pre-operative physio, which is prehab. Well-motivated patient should understand what is the expectation from this surgery. So outpatient TKR, one is minimally invasive TKR, the physiotherapy, it's a team approach. Okay, appropriate patient, of course, you cannot do it for everybody. Pain management. Pain management has to be effective. Most of the surgical patients actually end up becoming like accident victims, as if a truck has hit them and converted them into, post-op pain. You do the TKR, you get out of the OT, but the patient is crying in pain and you think it's normal to cry in pain. It's not. It's too important an issue for the surgeon to just leave it to the juniors or just the anesthetists. In most setups, the anesthetists do not have a mindset for pain control. For them, getting the surgery done, high-risk cases, this, that, critical care, that is what it is. Their mindset of pain control is not there. It can actually make or break the success of a TKR surgery. So surgery causes tissue trauma, inflammation, leads to pain. So we can avoid it. Narcotics can cause nausea, hypotension, and malaise. And we avoid epidurals because they can cause hypotension and urinary retention. So that only then we can shorten the stay. So preemptive analgesia, preoperative, gabapentin and COX-2 inhibitors to be given in the morning before surgery. Tourniquet, it is believed to reduce blood loss. There are a number of studies, but it is disputed. Does not reduce the blood loss and may actually increase it with venous congestion if you don't use an ESMARC. Causes more pain and more DVT if the surgery is long, especially. And we want to abandon its use completely, but selectively. And we saw one PE in the last 2 years, unfortunately, but it is there. Not so much as what the Western literature says, but it is there. So intraoperating, you do a muscle sparing surgery with adequate incision. The rehearsed operative steps with a dedicated team will give you, the clean incision, clean dissection. Every time you have the same team, it is good. Use of tranexamic acid. Then you inject the capsule cocktail. Then you do a watertight but tension-free closure, and we put a Pico dressing on table. Pico is a vacuum dressing which is available from Smith & Nephew. It's a very good dressing. The picture is there at the bottom. You can see that Pico dressing has got a small vacuum pump attached to it, and then it keeps on. If there is any soakage in the wound, it will just take it up to 200 ml can be going in that. So there is no drain, no catheter, nothing else. Then you do an adductor canal block. It's a game changer. Blocks after the quadriceps motor branches have exited, so it's in the adductor canal. There is no weakness of quadriceps, only sensory block occurs, and patients can walk comfortably in 3 hours. So these patients on which we are trying this short stay study is going on. These patients undergo an adductor canal block, ultrasound guided adductor canal block. Trenexa, it's an antifibrinolytic agent, routinely used perioperatively to reduce blood loss. And studies and our own data show that it can reduce the blood loss by almost 1.5 grams. Unilateral TKR is almost never transfused in this center. This is how a TKR wound can look at 3 hours from surgery. So you have already heard this surgeon administered adductor canal block that can be given selectively, especially in subvastus approach. It works very well because you have already exposed the adductor sheath. Now, physio and rehab, of course, useful for the patients to have been shown the exercises pre-op. Jab OPD mein aaye, at that time we can explain to them that this is what you will do, because post-op sometimes they become, so resistant that they don't want to, they don't know, it's new for them. Explain that they can walk on the same day and may go even home. So the experience of the relatives and their friends is critical. They will always come and give you examples of, my other cousin or my aunt or my neighbor has got it done and she had very much pain, and then it doesn't work. Home support should be, home should be supporting a post-op patient with suitable bed and toilet facilities if you want to send them. Motivated patients, multiple comorbidities, encouraged to go home only if the patients also desires and it is medically safe. Mediclaim issues are there because, they mostly want 1 day stay in the hospital, but outpatient TKR is definitely a possibility using latest techniques. Now, our patients can go home when there is functional ambulation, their pain is under control, they have an acceptable range of movement. It's not necessary to give them 7-8 days of physio, get to 120 degree only, then send them home, and the wound is good. So 1 or 2 days. Currently, 60% of our patients are staying 2 days post-op. 38% stay only 1 day in the hospital. 2% can go home on the same day. Now, what we did was actually, we didn't tell the patient, we kept them in the hospital for 3 days, but we stopped their IV antibiotics, fluids, everything at the second day, as if mentally the team knew that this patient is discharged today. But we still kept the patient a day extra for physiotherapy, coax them, and on tablets, everything on tablets. Then we were confident after 100 cases that this is going to work. We shifted it down to 1 day. Now the patients are going 48 hours, but the actual medication and everything from our side, mentally he's going home on, then we know which kind of patients we are not able to. So it's encouraged that if you're doing volumes, you analyze your data, encourage your patients, and maybe, in a shorter or a lesser sort of bed strength available to you, the infection rates controlled, and the patients can go home faster, giving the surgery more impetus. So thank you for a very patient listen.
Which anesthesia you gave to the patient if you want to send the patient same day home?
Simple spinal anesthesia.
You don't, many anesthetists say that you should not lift the head and all that because of the headache fear.
Yeah, for post-spinal headache usually happens in younger males. does not happen. I've never seen a post-op TKR patient getting a post-spinal headache.
Okay.
So in young males, yes, it is noticed, especially your scopy patients, if you do them and make them sit up in the afternoon or something, or make them walk to the toilet, third or fourth day, they will report to you. Even if they go home on day 1, day 2, they will call you up. Sir, splitting headache is there, neck pain is there, that sort of things. But simple spinal works, I'm sure that's how it is.
Okay, thank you.
The ductal canal block is is crucial. Patient education, of course. Yes.
Thank you.
I don't know opinion about other surgeons, but I find it very difficult to send the patient same day, never ever.
So same day, we have never ever done it also.
Okay.
The talk is, can we talk about it?
Okay. And even at 2 or 3 days, patient still is not, I would say, fit enough to go, still having problems, mobilization problems and everything in our setup. In West setup, it's very different. They have a step down hospitals, they have a step down physiotherapy centers. So there they can, but in our setups, I don't know what is the.
No, sir, I would like to just say that I think it's not true. What you're saying probably was true. I think we have not just put enough effort to get to there. There's no great shakes in saying, if I'm sending them on day 1, all I'm trying to say is that the surgery is successive, repetitive, and can be made pain-free to give good results. When scopy patients also used to go home 3-4 days later, 20 years ago. Now, who keeps a scopy for more than 1 day? I mean,
definitely the length of stay has come down. Definitely, it has come down. And unilateral patients, they are ready to go.
So the only thing that matters is your tissue dissection, patient counseling, and pain control. That's it. So, okay, don't send them on same day, but you can send them on maximum day 2. Our 48-hour culture, this bacterial growth thing.
What about the DVT prophylaxis you use in these patients?
So we have a rule that anybody who's more than 60 kg, more than 75 kg weight and more than 65 years of age gets DVT prophylaxis. When they go home, first 10 days we use Xarelto, 1 tablet at night, 10 mg. And after that we shift to Ecosprin for 1 month.
So what about the bilateral cases? Can you send them home
No,
same day?
not same day. Our bilateral stay currently in this hospital is 3 days.
3 days minimum.
So a lot of patients, we stop all IV, everything at 48 hours. Okay. All antibiotics are stopped, IV fluids are stopped. Of course, selected cases. I mean, there are some patients who may even overstay 4 days, maybe 5 days, but that's very, very selective when you're expecting a complication or it's morbidly obese, you are not confident, or what botch-up you have done in the OT. The patient doesn't know, and it's a manageable botch-up. And then you just want to observe for another day extra, you will encourage them to give, you may even give extra antibiotics like that.
Okay.
But bilaterals cannot go home on day 1, at least in this setup. Even in the West, bilaterals, they don't send, they do only singles, they don't do bilaterals.
They do single, of course. Yes. Thank you very much.
Thank you, sir.
So I thank the speakers and Dr. Shubhang Aggarwal, who was the last one to be the speaker in this session. So may I request all the moderators and the previous sessions moderator and chairpersons to be on the dais along with the speakers, please. I'll just have the names of the previous session speaker also. Dr. Sumit Mahajan, Dr. H.S. Gill, Dr. Hariom Aggarwal, I think he has left. Dr. Ambu Sood, in case he is present, along with the moderators of this session. And the speakers also, please be on the dais, sir. Dr. Dilbans Panther, in case he is here. Dr. Jeet Kumar. Dr. Tomar. Dr. Vineet Aggarwal. Dr. Shubhang Aggarwal. May I request Dr. Abdul Ghani, in case he's present, to just come on the dais and give the mementos. He just left. Then I can request Dr. Iqbal Singh Ghai to be on the dais and have the honor of presenting the mementos to our honored speakers and the moderators, chairpersons.
I saw the pictures.
Lunch is also ready for all the delegates and the faculty. And another 20 minutes max, because it will be, yeah, another 20 minutes. I think it will be for 10 past 2 or 5 past 2. So we'll be there back here for the live session. That will be robotic THR Albert by Dr. Vaibhav Bagaria. The patient also will be ready within 10-15 minutes. So I will request the chairpersons of that session for the live surgeries. Will be having the moderators Dr. Sumit Mahajan, Dr. Ikmal Singh Ghai, Dr. P.S. Nagpal, and Dr. Abdul Ghani. In case you can be present just 5 past 2 o'clock on the dais, so we can start the live surgery in time. So I'll request Dr. Ikmal Singh Ghai, Dr. Sumit Mahajan, Dr. Abdul Ghani, and Dr. P.S. Nagpal to be here 5 minutes past 2 o'clock, sir. So let's meet after the lunch.
संबंधित करती है और क्या हमारे थोड़े बच्चों को आलो पढ़ो पता नहीं क्या चीज़ बताती हो हमारी स्क्रीन इधर दो इधर दो नहीं मैं तो बोलने के लिए खोल की खोल दो मैं पूरी खोल दे बोल आज स्क्रीन होनी चाहिए पूरी पिछले कुछ जो शर्म सर्दी की फोटो खींची ओए स्टाइल मार लो हुन संदीप दो चार खिंचे क्लिक कर आ स्क्रीन आनी चाहिए पूरी हाँ ये नहीं चिल करो चिल लाइफ का कुछ नहीं पता एचपी 14 ग्राम का है एचपी 14 ग्राम करना मैडम ने सर एचपी चेक करो मैडम जिन्होंने मैं क्या बात कर आपको बोलिए Hello, hello. Hello, Anna. Fine. अच्छा क्लोज क्लोज संदीप इधर है हेलो लंच रेडी कूपन क्लिक कर दो जेडी अच्छी होगी मैं फेसबुक पे पा देनी है नहीं चल रहा कहाँ जा रहा है कोई बात नहीं हम किसी से कम थोड़ी ना चलो लाइक ज्यादा बच जाएंगे जल्दी कर बात होने मेरे पैसे लग रहे रोटी खा लो आप मैडम नहीं मैं फ्रेश चावल लाई कितने पैसे खाते हैं कैसे कर मेडिसिन का मुश्किल ना
आप बताओ ना बच्चे की गोली खा रहे हैं आप बताओ बच्चे की गोली खा रहे हैं
Full 300. You're going. तुझे खाना कहाँ है? सारे खाना कहाँ है? हम खाना खा रहे हैं।
हाँ जी, हाँ जी। Can we all take our seats? We are going to start with the fourth live surgery of robotic TKR, Albert, by Dr. Vaibhav Bagaria, Mumbai. May I request Dr. Sumit Mahajan, Dr. Bal Singh Ghai to grace the dais as the moderators for this session. Dr. Abdul Ghani, I think, is probably leaving. We'll be having Dr. Shubhang Aggarwal also to join as a moderator in a short while. Just check, sir, in case if this mic is there in front of you. Are you able to communicate with the OT?
Am I audible?
Very much, sir.
Okay, so I've just started taking an incision. I'm doing medial parapetal. It's a standard medial OA in a 71-year-old male. Patient is under general anesthesia. So feel free to ask questions. It's a almost nearly completely correctable deformity. I put my femoral pins through the incision, hence I take a slightly longer incision. I'm creating a medial sleeve here to ensure that I can put my retractor there. Retract, please.
Dr. Bal Singh Ghai wants to talk to you, sir.
Yeah, please go ahead, please. Yeah, you're audible, sir.
Sir, please put the X-ray first.
Yeah, so we actually started a little early because patient was under anesthesia. X-ray is there. If someone can please focus on the X-ray. We didn't want to waste the anesthesia time, so we decided that we'll go ahead and put the pins by the time you guys come from the lunch. That's the X-ray standard median oil. Is the X-ray visible?
AP, please.
Yeah. You see, I'll release up to the mid-equator point here. Only releasing the DMCL and the meniscotibial attachments. Remove all the osteophytes that are there. So, as I was describing in my talk, there are 3 stages in which we balance the knee. One is the first one is the preliminary release that I'm doing right now. The second is juggling with the bone cuts, and third is fine-tuning the releases is required after the manipulation of the bony cuts. Can I have cautery at 40-40, please? 40-40. Removing the meniscus here. Thank you. Okay, once that is done, I go to the femoral side and remove the osteophyte that are there, slightly extend the knee. So the basics of the arthroplasty is remain the same, that you should remove the tight structure that you feel are contributing to your medial tightness. So before you go on to thinking about the bone cut manipulation. Once I have done that, I'll go and check if the deformity is correctable or not. So if you can see that now the joint is almost opening back to the equal to the other side. Can I have a focus on the incision? Please focus on please focus on the incision. Please focus on the guide. Yeah. You can see that earlier it had a viral deformity, but now I can get it back to the neutral. Okay, once I have done that, like back please. So the computer likes to see this area, this anterolateral aspect for the mapping. So this is I realized if you map it well, the computer is happy. So that's why I've cleared that area. This case is actually good for Gini as well, really, apart from the patellofemoral changes that we have here.
And would you do it in the lateral facet arthritis?
Yeah, this is a little bit too much for me. But normally, moderate arthritis, I would still go ahead and do it. So this is a difference between conventional and this, that you do a little more of cleaning around in this area, because I believe that if you mark the tissue well or mark the bones well, your work during the clean becomes less. So unlike conventional TKR, where I would not bother to remove these many soft tissues or see the exposure on the lateral side, here I would want it to be done. With respect. There was single one, blunt one. Single. Okay, I will use this. Yeah. Normally, I would use a blunt spike here. It's not there to subluxate the joint.
So you do the mapping for the tibia first, then femur?
No, I'll just clean the lateral side so that my mapping is good. Anyway, if we can't reach because I don't want to use these bulky things, so I'll just clear the lateral side and someone to subluxate. So once again, I would want to have a good exposure on the lateral side so that the mapping is good. The thing with the robot is that, we are discussing, garbage in and garbage out. So we want to have more accurate mapping when we are doing this. Some more. So once I'm done, this is good enough for my tibial mapping. I would have preferred to go use a blunt spike and subluxate forward versus right. You'll see. Now, everyone has a different way of putting pins here. To line back, please. So I like to put it through the incision. There's a bit of synovium here. I'll clear that. A small, smaller one, please. So I tend to clear the synovium here. It also helps me create a space for me to give the block, the direct or extra canal block that I normally give. Okay. So once I have the space enough, do not repeat it, please. Yeah. So by the time he's putting the pins, I'm putting the indentation here on the tibial side. If the camera can pan out, he'll see that we are both working in sync. There are two teams working so as to make us fast. Put the please. R3, please. So both of the pins are lying in the center. Just leave it. Yep. Good.
You can do the other way around also.
Meaning?
Other way around it may. Yeah, please ask me.
The other way around also, near to the joint.
You do not have to detect so much. I think because he has to leave room for the implant actually.
Yeah, I have to leave the room.
What's your experience with putting the pins in, like the second pin is in diaphysis? So are you comfortable with the diaphysial pins or you're more comfortable with the metaphysis?
No, I like pins, but when putting a diaphysial pin, it's always a unicortical pin.
Still any stress factors 3 months down the line?
So we have had one fracture, periprosthetic fracture, in our first 30 cases that we did. But then since then, almost 700, 800 cases that we have done, we have never had an issue. The key is to have it unicortically. In fact, if you put bicortical, what I have seen is that the whole of the the pin track is much more when we have a metaphyseal pin. And I will not hesitate to put some bone graft there when there are bigger holes. So when you're withdrawing this, you'll feel that there is a hole which is larger. Then in that case, you put some bone graft there. So I've started doing that. And I like my arrows to be in this direction. It gives the computer an understanding of how the plane is. So I don't like my planes to go this. If you look, if the camera is panned, it is in the line of femur, this is in the line of tibia. So I have got this sort of mental cue of how my knee is aligned when I look at these two images, and that is why I want them exactly in this direction. In unis, my pin will go like this and this. So one will be metaphyseal and one will be like this, because I'm not worried about the anterior flange here. Okay. Once again, I kind of do not use checkpoints like most people. I do it through here. The standard things. Right support loose करेंगे please. At this stage, I'll ask someone using the side support. People have difficulty in doing this, so the way is to put it in slight external rotation, hold it here, enter the quadrant of the 11 o'clock. That's it, thank you. So you'll see I'll enter in the 11 o'clock quadrant. So if the support, side support is not completely loose, you may have an issue. थोड़ा पीछे खींचेंगे side support, please. Yeah, thank you so much. So if we enter here, usually it is so anything below 1, I'll accept it. Then we do, if you see my hand, it is pushing the sole to make it weight bearing, neutral point connection. And then through the range, okay, through the range connection, side support tighten again, please. Again, back. And then you can map it for the boundaries, outside boundaries. And intermittently, if you leave the pattern, you'll see some blue areas. So those are the areas which computer wants us to map for sure to get an accurate thing. So I let the paddle in between and showed me the area that I need to mark. All those blue areas need to go to get more accurate. Always collect more points than what is demanded by the computer. The computer works on the principle of root square mean errors, and you want to minimize that error. Okay. Once you do that, I'm concerned about 3 things in femur. One is anterior knotting, so I'll take a special point here to tell me if whenever I have doubt that whether the special points are being notched or not. Then I go to the medial condyle, I'm palpating here, and I'm palpating the lateral condyle. So they are my checkpoints in case I feel that if there is a mismatch between the 2 points, the screen is gone now. So there is always a 2 check. So one check is what the computer has calculated from posterior condyle axis. The second is the epicondyle axis, that the green line that you are seeing. And third is what I am telling the computer. All 3 have to nearly match within 1 or 2 degrees. You'll see that I'm happy about where I have put my thing. The green lines are matching, the blue lines are matching, so I'm okay. I have not overruled the computer here. Okay. Let me try putting the spike once again. If not, then I will just hold this space. Itna hota hai.
So Vaibhav, you will always, Shubhang here,
yes,
will you always sublux and then do the mapping of the data? Is it necessary to do it?
It is not necessary. You'll see here that I can do it without it also.
Yes.
Okay. But it requires me to for the accuracy of the size. So you'll see it's only the antro medial which is the most important for the computer.
Yes.
So see, the only blue area that it is asking is on the anterior side. So I need not do it, but it's always good to have a good exposure because that gives you more accuracy when you're doing it. Okay, so as I said, even if now the computer has said it doesn't need more points, I'm still going on acquiring some more points than what is required to improve my accuracy. Particularly this area here is something that I found that if you map it well, it helps. Okay. So at this stage, the computer knows where the shimmer is, where the tibia is, how it is looking, and this is called as a warm-up screen. It gives you an assessment of pitch. So if anything is grossly wrong, happened wrong here, or your mapping has not been accurate, you will see here. So you'll see that the way the computer has positioned the implants is where it should be. So it's sitting right where it should be. So there is no gross error at this stage. Of course, we'll keep checking at every stage. And again, this is a CT two-dimensional view, which gives you an idea of whether the sizes are good or not. Size 5, and look at the size 5 and look here. I feel yes, 5 is what it is. Tibia is always inaccurate, especially if you've not got the posterolateral and intermediate thing, which we could not because we have not subluxated. So probably the tibia is oversized here because the computer has. So the way the computer works is it kind of puts the data that here to its database and maps it to the closest model that it has. So it's never 100% accurate, but it kind of roughly gives you what you are dealing with. So if you look at the screen, this is warm-up screen. You see there is 11mm cut, there's 10mm cut, which is 1mm more than normally you take. It is 9mm. So grossly you know that this is how you will do a conventional. If it is a simple straightforward like this, a case like this, you would expect your planning screen even before you have done anything to match your basic philosophy. At this stage, you can change your PS or CR. You can look, okay, the flexion is 7 to, the range is 7 to 119, there is 8 degree virus. So if you have had any errors, you will know that suppose it was showing me valgus here. Now I will know it is wrong. If it would have shown me 20 degree flexion deformity, I would know there is something wrong with it. So this is the warm-up screen just before the actual match starts. Next. So now we'll just take an unstressed range of motion. Since it's a varus deformity, I expect the medial side to be tight.
Well, one question.
Yeah.
I'm Dr. Joshi.
Yes, Dr. Joshi.
If the tracker moves in between,
yeah,
then your readings will be haywire, right?
Yes.
So how will you tackle that problem if this happens intraoperatively?
So it depends at what stage it has happened. Okay. So if it is very initial stage, I'll go refix it. Let me answer the question. So if it has happened in the initial stage, I'll retighten all my trackers, go back, do the registration again. If it has happened after I've taken a tibial cut and my pegs are made, I'll switch over to the manual. So it will depend. It will depend on what stage of the surgery you are in and how much you want to spend more time on it.
Thank you.
Okay, so this is unstressed. Now I'm giving a valgus stress, and you'll see that despite giving a valgus stress, it's only the lateral side that is slightly open, and in flexion, some decrease in the tightness is seen with the orange graphs. Now I'm putting it on the other side, lateral compartment. So in a way, I'm distracting the compartment and not merely giving a pure one stress. You'll see that lateral compartment is showing this. So you'll see that lateral compartment is slightly loose on stress. Medial compartment is tight throughout the range, more so in extension. This is the key point. Understanding this is the key. Next piece. Now, if you look here, this is the graph. This is showing what side is tight and what side is loose. So now here we can juggle to minimize our releases. If you look at 5.8 and 6.4, I'm happy with 1.9 and 1.6 because that's a sort of a natural opening that happens on the lateral side. So much so that just for ease of my mind, I put this as 11. Polio is 11. Although finally I'll use 9. So you'll see my lateral side is almost balanced at this stage. This is so if I do releases, so I got two options. Go with this plan and do releases immediately. But I don't want to do more releases. So I'll play with the screen to ensure that my releases are minimized. So let's see how I do it. Okay, so good. So I want the screen is gone again. So I know that both flexion and extension are tight medially. So what can be done? So I want all of you to think, what can change both flexion and extension? So what Hitesh here, he's saying, what tibia? He's saying tibia. So we alter tibia. So what can we do in tibia? I'll dial 2 degree varus. Please do that for me. Okay. So again, the screen is gone. We can actually still see this. Yeah, I can see that there, but not my screen. Okay. So I see that is there. So now, if you look again, it has become slightly tight on the lateral side. So what again, if it is both flexion extension, I'm touching the tibia. So please make it 1.5. Okay. So again, it has come back to 0. Now I still want, I'm not happy with the release, with the amount of release that will be required because it is 6.4 to 7.1. What else can we do? Can we do something in the femur? So we rotate the femur 3 degrees. We'll see what will happen. Okay. So you see my releases are decreasing. Okay. Now we can shift the femur component anteriorly. Shift. One more, see my special point are important here. So you saw that I shifted and now I'm happy with my flexion thing. It will come less than 4 degree, 4 tightness and my extension, my flexion is balanced and the releases that will be required is minimal here. Now I'm left with what can be done about the extension space. Okay, so can you do anything? Any suggestions, Hitesh? What can I do by this? If I superiorize femur valgus. Okay. Valgus. Let's do femur valgus. Are you happy with that? No, that's not what we want. I want the lateral side to be unchanged and medial side to decrease. So what will I do? Dialing some more varus in the femur. Let's dial 2 degree varus. Okay, and now increase the cut to 10. Okay, so you can see here that anyone with a flexion deformity, slight extension is a male. I'm happy for him to have 0.4 looseness in extension. It's nearly 4.8 and 0.3, and my overall alignment is 3 degree varus. I'm accepting it at this stage because I feel that below 4, any deformity, any tightness will go once I take a tibial cut of 2 millimeter or 1.5 millimeter. Because for every millimeter of the tibial cut on the deformed side, 2 millimeter opening happens. So if you look, it's roughly there. Flexion is definitely well balanced. If at all, there might be slight tightness in extension, which I'll tackle once the time comes. Okay, so I'll proceed with this.
So what is your limit for varus and tibia and for femur?
Individual component 3 degrees, overall component 5 degrees. So I don't want my HK more than 5 degree deviation on the varus and 2 degree on valgus, and no component to be more malign or 3 degrees to be neutral. So individually I will not put more than 3 degree tibia or more than 3 degree femur. Overall I'll put 5 degrees. So if there is 3, then 2 can go in femur.
You are happy with the altered mechanical alignment?
Yes. So this is within the domain of, because it's robotic. If you look at the outlines and the survival rate of the mechanical thing, they say that up to 5 degrees does not impact survivorship. So for me, it is 3 degree varus overall alignment. If you look at the screen, so I'm happy. There is still an error of 2 degree possible to maintain the traditional 5 degree mechanical alignment philosophy. Okay, anyone, any other thoughts on that?
Would you proceed with that on the medial side? That much tightness that you have kept for your release?
Right. So I've not kept, so as I said, 4 millimeter, I'm absolutely happy. Only on the extension side, it is 4.8. So it may require some amount of releases. But let's see once we do that. So as I said, it is a 3-stage process. The first was the primary release, the second is the bony alteration, and third is fine-tuning the releases. So I've left for that fine-tuning for later.
Are you happy cutting posterior femur up to 13 mm?
Yes. So because if you look at, go back please. So go forward. No, show the sagittal cut. If you look here, the sagittal cut, now it is surface matching. On the first screen that you are seeing that it is clearly, you can scroll through. So you see, you are not cutting too much, except you see here, so go to the lateral side first. The lateral side, it is match to match.
with the posterior condylar offset, I think we are getting a 1 or 2 mm less on that.
Yeah, so
So for 9 it is cutting 10.5, right?
yes, yes. 9 is cutting 10.5 and it is externally rotated, so it's cutting more of tibia to balance it on the flexion. So that is why you see 13 there. Okay, so this process I've seen will restore the joint line. I'm cutting minimal tibia here, only 1.5 tibia, and I'm using an 11 poly. Traditionally, we will cut 2 mm on tibia and use a 9 mm poly. Correct? For most cases. So here, if you look here, it's 1.5, and I'm choosing to use an 11 mm poly for my planning. So I'm happy with this configuration. As long as I didn't see on that side to cut, go back to the cube first thing. There is too much of bone cutting on the posterior side, on the lateral side. I'm happy because as I said, my entire decision is based on recreating the normal side, which it is, which is the lateral side in this particular case.
Is there any concept of a rotating hinge, like we can base the rotation? You did acceleration medially, laterally, or in the center in Corey?
The hinge point chain, no,
Hinge point.
it's a fixed one.
The fixed center.
It's a fixed center. Yeah. Proceed next. Okay, everyone, any other question on that?
I think we are good to go ahead.
Yeah. Okay. We'll do the femur first. Yeah, so what I'm doing, we'll do the distal and then I'll show you the all bar also, just to make my pegs, to make life faster. I'll do that when I show you the all bar also. I'm just doing it to make the pegs first, and then we'll switch over to the all bar. One of the problems is the dust that comes out of the system. So I always keep my hand like this, and you'll see. Oh, this is even hard. So again, at this point, I will check. I'll check how much the bone is cutting. So you will see that this is green is only 1 mm. So I'm not cutting too much of this receiver. If this would have been the same color as this, I would again recheck whether I'm cutting too much of femur. So I always like this picture. So in robotics, I always should have one more extra check when you're doing the surgery. So this is my check that I'm not cutting too much here. If this would have been the same color as this, I would go back and recheck. I'll proceed with cutting, and you'll see this is how I've kept my hand, and I can look at you guys and still work on it, or I can close my eyes and still do the surgery, and it will be ensured that only the right thing comes. So you'll see that I'm looking at you guys and still I'm able to operate. Literally, because the robot is so sure of where it is cutting, and my hand also knows where I'm going, I can look at you and still cut the whole.
You can actually demonstrate the rotating handpiece on your hands. It's not going to cut anything.
Yeah, yeah.
Or on the string.
Yes. So in any tissue that you go, suppose I come here, so it is not moving out only. So if you see here, there is nothing happening here. So once again, as I said, I can look anywhere, I can talk to anyone while this procedure is going on, not even looking at the screen at this stage. And my hand will know where to go. And in the robotic bar, it will cut exactly where I have to cut. So you want all white here. Yeah. Now for this is as Shubhang said, this is like playing your video game. So the green part is the tip of this, and the blue is your back of your device.
Irrigation tubing, Dr. Vaibhav?
No, I don't use. I like to use minimum things that come cables and this that come to my table.
Yeah, great. But that section irrigation, you know, all the debris that gets produced, it does definitely help a little bit.
Okay.
Yes, it obstructs your.
Yeah, and I don't like. I'm a bit worried about the sterility and other issues. So I just want least amount of movable things in the trolley. Even if you look at my handpiece, it comes between the two assistants. So it's never free floating because you may be just doing something else and it is touching somewhere which I don't like. So that is why the way I put my handpiece is also in a very particular way so as to minimize. You have to just align it properly.
Sometimes it behaves stubborn, right?
Yes, it does.
Especially this head hole.
Yeah.
You put your thing and you're like, I'm absolutely in the place, but it still doesn't go in.
That is fun of video games. Na? Sometimes they can throw googly at you so as to keep you engaged. How good or how bad you are, especially in front of your friends.
I think it's got nothing to do with good or bad. You are good.
No. In front of your friend, when you want to show off, just try to play this spoil sport. Try to play this spoil sport when you want to show it off at the right time. Then you can do it blind.
The robo has a mind of its own. Absolutely. And this Kiran, if you guys call it the real intelligence. So, it's insulting to the surgeon, though.
Yeah, the real intelligence cannot be matched to human stupidity. Na? So I'm happy with this. It's almost done. So you okay. So at this stage, I normally do not use an all bar, but we will demonstrate that all bar thing. But before I do that, as I said, I always let me check once more any anterior notching. So what I normally do is one, I check the cuts. So there is a ridge here which I want to take off. So sometime when there is a cartilage, the computer will not map it and will show. So it's showing the cuts are okay, but the flexion is there because there is still a ridge there. So if you look here, there is a ridge here, and this notch, this osteoid, I'll remove once again that to ensure that what we have done is correct. So it's still showing that thing. We'll see how, because the selection will not matter at this stage, because in any case, we'll be, so it's almost there. There is a small ridge over here, which is causing the issue, but I don't want to remove it because it's just there at the ACL. We'll see once I make the peg hole how it behaves. Right. So at this stage, I'll check my whether there's any notching or not. As I said, I believe computers, but at the same time, I always do this mechanical check. We'll do all that. We'll do all that. Yeah, just doing it to show that it is. I'm again checking it here. Normally, this is what I will do. I will take a cut at this stage. Because it's an all bar demonstration, I'll go back to all bar. You'll see that it is not notching here. And once again, I'll put this here to see how I'm behaving in terms of this. So I'm happy with this. As I said, this flexion sometimes changes when I do this. It's okay. So you'll see when I put that ridge was not obstructing my thing. So at this stage, I will go and take cuts. But because we are demonstrating an all bar, I'll use an all bar here. So normally you can take a stock of anterior chamfer, posterior chamfer, and the anterior posterior side. So define please. Define.
how's your mindset changed after you switched to robotics? Like you have started picking up, which normally in like you would in manual technique you would miss. Any changes like any finding you find in your patients which you find more often than you?
See, in my mind, my introspection has increased for sure. I introspect more because I can see it on screen. So what alignment to give to that particular patient has definitely changed. So I think what robotic has done is force me to think much more when I'm on planning screen. In terms of patient thing, and this is a debate, where is the evidence of clinical benefit? So when there is no direct evidence, or there can never be direct evidence because you'll never have a large enough series, and by the time you will have a large enough series, 50% of world would have probably moved to the robotics. Is the fact, but there are surrogate markers. So my patients have been started to going home earlier. So my average length of stay has decreased from 0.5 to 0.8 days. My poly use in last 2 years of a 13 poly is only 1. So I'm cutting obviously less tibia than I used to. So I think if you're cutting less tibia, you're using lesser size of poly and your joint line restoration is better. And overall the pain, I think, is better. But again, pain, as I said, is subjective. We use multimodal things for the pain. So we don't know what really works. But it is a gut feeling that yes, because you are doing less releases as a surrogate thing, your pain will be less. So
very well said actually. That is a point. The poly has come down. Like earlier, sometimes we used to use 13 poly, but after robotics, the maximum is 9 or an 11 poly. So we do save a lot of bone when we are doing a robotic knee. Something I've picked up in my cases, normally we don't see so many hyperextension cases, but after robotics, I started picking up patients who are like slightly hyperextension, having around 4, 5, 6, 7 degrees of hyperextension, which normally clinically looks very straight. So
yeah, as I said, it forces you to introspect. You can see what is, you cannot unsee once you have seen it. If you are asked, if I'm doing something and it is showing something on the screen, it will force me to start thinking, what's happening there. You will see all bar, it's sort of a time consuming thing. But I hope that you've got a gist of what you need to do with this. I would rather prefer a saw at this stage because it's already almost everything is done and my tracks are created. I'll put a jig to make the whole process faster. So you'll see there is no notching here up. Here we'll give a watch, please. Watch, please. One of the reasons I do not like that much all bar technique is the amount of debris that it generates. On the other hand, if you look, the surface is perfectly rough for good cementing. Watch this. Watch the more.
So actually the idea was not to trouble you.
No, that's okay. That's okay. I'm just telling the advantages and disadvantages of the whole system.
So the idea was to show the versatility.
Yes, yeah. No, and I agree with it, and I completely believe that that is how we should know all the capabilities. And there are certain things, like for example, when you do revisions, we use all the burr technique here. Yeah. So
do you think that his generation is more with straw than burr?
So I think if you irrigate well, both are equal. Okay? So no, I'll just use the jig only. So at this stage, just to complete my posterior cut, I'll use the jig to make it faster. Okay, jig please.
So just quick point, taking this heat generation thing. So in saw blades also there is a lot of heat generation, depending on whether you're using a new blade or not. TC, I mean, I'm not saying Biotech is a very good drill. We've got 4 sets. But in general, I'm saying that you see they are faster, they are more aggressive drills. So they generate more heat.
Yeah, so Smaller one. Two.
Any changes in your physio protocols or like the patients who feel like easier to move their knee, better flexions? How's your implant placement when you see a post of X-rays?
Yeah, I would love to say that. It would be really unsafe to say that because patients are so diverse. To make a generic comment, okay, my patients are very fast, recovery, I would love to say that. And I believe that that is the selling point. But it's really very difficult to be very scientifically true when you say that because there is such a wide variety of patients. But as I said, see, if I'm cutting less bone, if I'm relieving less soft tissue, obviously the patient should will recover faster. Okay, so now I'll proceed with the tibia. Please, grabber, please. Grabber, please. Grabber or even a nibbler will do. So I'll remove the lateral meniscus. Nibbler देंगे. Hold on with the nibbler.
Sir, how is your experience of using robotics in obese patients? Like, do you think it is more of an advantage or it is like more of a hassle?
No, I think it's much more advantageous because your acquisition of data normally in whatever thing you do, I think it is a combination of what landmarks do we register in our brain from the robot. Obviously, in an obese patient, your ability to register landmark in your brain and within robots are challenging. But I said that in robot, once you acquire the system, and you've got a lot of checks, and there is an objectivity to it. So I believe in more complex situations, you have got more advantage of using robotics, but you will be able to use it for more complex situations if you are able to do it in lesser complex situations. So to be used to the robot is very important. But please, welcome to. So normally what I'll do, you hold it here, is I'll come in between the two hands of the assistant here. Okay. Press on it, more on. So again, bit of juggling here. So if you look at the screen, white is what I want to go. Once again, I can look at you and operate with confidence that the bar is not going to over-affect when it is doing. One advantage of dialing Varas is that sometimes when the bone is sclerotic on the medial side, it kind of takes care of that as well.
Yeah, the lessons we learned from robotic also help in our conventional.
Of course.
Because we have started dialing external rotations according to the patient's need, and our fixed 3 degrees. So there is a lot to learn.
Yeah, so as I always say, technology is a tool. It makes you better in terms of execution, but most importantly, what it does is it gives you objectivity. And if you are a sharp observer, you will know what works and what not. Just to make process faster, I'll just nibble a few areas, nibble a piece. one of the downside of using the robotic bar is that you do get carpal tunnels very easily and early in your life. Wash, please.
Is that treatment also covered by the company?
Depends how you negotiate it. Everything is covered. Everything comes with terms and conditions. If you're a good negotiator like Shubhang, I'm sure it will be covered. So using straw will make it faster, but you must know how to use it as an all bar also.
So you saw you just put it like a manual jig and you take out 2 mm less than the normal and then you finish it off with a burr or
sometimes freehand, sometimes jig. Depends. But certainly if I'm cutting more than 1.5 or 2 mm on the affected side, then I will surely take a freehand cut. It will make my surgery much faster. And it also gives me a kick to see how good I am at it without jig. Proper figure what, please? So the last corner, I prefer to use a osteotome. Again, because although the bar will stop when it touches the soft tissue, there is a latency to it. Or even though it is a wired one, the future robots will be wireless, latency will be a much bigger issue. But even in the wired ones, there is an issue of latency. So I don't like using the bar at the last corner there. Wash and mop. Mop, please.
So we have a very good pulse lavage, which is, I don't know if they've given it to you. Is there pulse lavage on table?
Yeah, so there is a pulse lavage there. Okay. So this. Hold this. So after every 8 minutes, it will ask you to check. So you can see the accuracy of the cut. It's 0.3, 0.1, 0.2. So I'm happy with my beautiful. Give that again. Only the edges near the patellar tendon, I'm a bit, as I said, I'm a bit hesitant to use my bar because I'm using all bar because of the latency of the bar. I don't want to take any chances there.
That's true. And have you ever noticed in the Kori that when you're mapping your tibia, if you jump over an osteophyte on the lateral side, then you will always see a piece of bone. I mean, on the screen, you will see the purple mark remaining.
Yeah. So you use a blue thing, then it kind of goes away sometimes.
Yeah.
I'm removing the remnant of the lateral meniscus. I will leave the edge, but you see, I planned for 11, but I knew that I want to use 9 only. Okay? Because 2 millimeter opening I want. Okay, so you see, they're sitting good. I like it. I'm just seeing, I feel happy about this. But let's see what the computer says, whether the computer is happy or not. Okay. But as I said, I had planned for 3, but it's showing 5 for giving the error of 2. As I said, this is still in my domain of this. It's hands off. And you'll see that when I'm pressing this, it goes to 1 degree extension, which I like. Virus is 5, which is okay. As I said, from 3 to 5, 2 degree error, I expect during execution. But with that, my balance, you see, I did not need to do any extreme releases. We'll see how the range is now. You'll see extremely good 140, 143 in going. Okay? If I leave it, this is almost going to 140 degrees. Okay? Now, the final thing is to check how does the balance feel like here. And you'll see slight lateral opening, which I'm happy about. You'll see it's only 1 millimeter to 2 millimeter opening, slightly more in extension, and otherwise a flat graph. I'm happy about this. Any comments, Shubhang? Anything else in that you would have done differently?
Good balancing.
Well, so this is what I want with minimum release and a virus of 5 degrees, which is even by mechanical standards is okay and acceptable. Okay, so at this stage I'll remove the pins and proceed with the cementing. And if you look here, the stability is good, the tracking is good, it's a CR knee, well balanced both in flexion and extension. Okay, so I'll go ahead with cementing now. We'll remove, at this stage I remove the trackers because once you have started cementing, there's no point in keeping the trackers. And I also believe that when you cement the tibia side, because there are pin tracks, you will also see the start oozing out, which I believe decreases the rate of the start embolism. And while a significant start embolism is rare, you do see some cognitive changes in patients if you have done bilateral. That also has stopped now since we started using robotic. Because the quantum of fat tissue that goes into the blood, I think that affects only beyond a certain point, it becomes clinically very apparent. But if you are sensitive to little changes, patient will report that they are not completely cognitively aligned when you do bilaterally. So that used to happen when you do conventionally. Of course, they used to recover in a few days to 4 days. But with the use of robotic, I think the fat embolism, because you are not penetrating the canal, has gone down significantly. So we'll remove the insert this tracker and pin right now. Cement can be started to mix. Cement mixing chalu kar sakte. Remove it. Cement you can start mixing.
That was a beautiful demonstration, and I think you can carry on with the cementing and rest of the procedure, and I think we can continue with the talk over here.
Yeah, thank you everyone. Thank you for Shubhang.
I would like to take this opportunity to thank Dr. Vaibhav for this excellent demonstration and the entire team in the OT, the anesthesia team, first of all, Dr. Pooja Aggarwal, Dr. Harleen Sandhu, Dr. Jashanpreet, and the Ortho OT team and the anesthesia OT team and all the supportive staff. You have done very well. One of the surgeons have given exceptional comments about you, which we will be later.
Beware of your assistants now.
But after the case is done, all the OT staff and everybody in the OT please can join us for lunch down here. Also, I would like to thank my associates, Dr. Nitish Kapil, Dr. Devdutt Banerjee, and Dr. Gitesh in the OT for the great show that they have put up.
Thank you, really.
Thank you, everyone.
Thank you.
And Dr. Vaibhav, we can close this and we'll start the talks here.
Yeah, please do that. The team was great here. Even though I was not operating in my concern, we ensured that everything seems pretty routine. Thank you, everyone.
Right. Thank you so much.
Thank you, Dr. Vaibhav. Please, the moderators, please stay in for the ceremony. We just want to offer you a token of love. Dr. H.S. Gill, can you just come and have the honor of facilitating our moderators for this session, live session? Next will be talk by Dr. Deepak Joshi, and I'll just name the chairpersons as of the show. Chairpersons will be Dr. Amit Pathak, Dr. Raminder Singh, Dr. Mohit Arora, Dr. Vaibhav Gandhi. In case they are available, please join us on the dais. Thank you, sir. Thanks a lot.
I'm going to talk about management of instability after primary total knee replacement. Post-TKR instability is the third biggest cause for revisions, that is almost 20%. And 80% to 90% patients are only satisfied after primary TKR. There are multiple reasons and factors contributing to this, but one of the factors is instability, and it is often underappreciated. The classification of instability is extension, genu recurvatum, flexion instability, mid-flexion instability, and global one. Again, according to the time factor, it could be acute. That means acute instability presents within few months, and another is chronic, which occurs beyond this early period. Acute instability can occur due to immediate component malalignment, failure to balance flexion extension gaps, and attenuation or rupture of the PCL in CR knees, as well as collateral ligament damage while doing picrusting or releasing the medial ligaments. And chronic instability occurs because of polywear, late ligamentous dysfunction, and malalignment of components, which over time can cause loosening. History taking in such cases is very important, and thorough history taking, and you should rule out infection in these cases before going on for diagnosis of instability. Clinical examination again is equally important. Overall limb alignment, gait pattern should be checked. Patellofemoral tracking should be done. Varus valgus and anteroposterior instability should be noticed in clinical examination. Radiologically, we should do coronal and sagittal scanograms and CT scans to diagnose mass rotation or the quantity of bone stock that is available around the implant. In extension instability, it is again divided into symmetrical and unsymmetrical. Symmetrical extension instability, in which the knee is balanced in flexion, but it is loose in extension. And this occurs because of excessive distal femoral cut, and the joint line is elevated. The remedy for this in symptomatic patient is that distal femoral augmentation to restore the correct joint line height. If you take an excessive tibial cut, then flexion and extension, both the gaps are loose, and the remedy for this will be to use a thicker poly insert. Extension instability in asymmetrical conditions, it means you have incompletely released the ligaments, either varus or valgus, and in that case, it is necessary to adequately release the ligament and correct the deformity, and you should not accept the trapezoidal space in primary surgery only. So I think doing primary surgery and following all the principles is very important. Again, unrecognized iatrogenic injury to the collaterals can cause asymmetric instability, and you should not shy away from this, especially this MCL tear. You should either directly repair it during surgery, or you also use augmentation while repairing the ligament. Genu recurvatum is rare, and it can occur due to neuromuscular disorders as well as valgus deformity with tight IT bands. Even in RA patients, you can have a genu recurvatum. You should always check the strength of the quadratus muscle before going for surgery. And the remedy for this is to use distal femoral augments or under resection of the distal femur. And you should keep your extension space tight. In case of neuromuscular disorder patients, you should use rotating hinge with extension stop. Now, this flexion instability is diagnostically is very challenging. Patient can get serosanguinous effusions which are repeated, and there is usually instability while getting up from the chair or ascending and descending the stairs. This is a very challenging situation because the underlying causes are the undersized femoral component which was used in primary TCAR, excessive resection of the posterior femoral condyles. Then if CR knee is used, rupture of the PCL can cause flexion instability, as well as if you have taken excessive tibial slope. There is very limited role for non-operative measures in such cases. In symptomatic patients, you should increase the posterior condylar offset through larger femoral component or use posterior augments. And you should, if the tibial slope is more, then you should address it properly. And in spite of all that, it still is unstable inflection, then you can resect the distal femur again. There should be no hesitation in using more constrained implants in such type of cases. Mid-flexion instability is a subjective feeling of instability, and it occurs due to excessive elevation of the joint line. As the joint line is elevated, you can see that patient, the X-ray look good or TCAR looks good but feels bad. In 90-degree flexion and extension, you have equal gaps, but in mid-flexion, PCL collaterals and posterior capsule is loose, and that's why you get this mid-flexion instability. So the typical scenario is in flexion contracture, you have excessively cut the distal femur rather than doing a proper posterior release or removing the posterior osteophytes. In such cases, the joint line will be elevated. What is the accepted position of joint line elevation? Not more than 8 mm from the preoperative position. Now, whether to use multi-radius or single radius femoral component is a topic of debate nowadays. Also, whether to use PS or CR, whether that can prevent mid-flexion instability, again, that is a topic of debate. So this is the 30 mm distal to the medial epicondyle should be the joint line. And in primary surgery only, you should aim to restore the joint line and balance the gaps properly. In here, robotic technology can significantly increase the accuracy and achieve an almost anatomical position of the joint line as compared to the mechanical one. This paper has been published by Dr. Vaidya recently. Then comes the global multiplanar instability. It is again a challenge, and instability occurs in more than one plane. Patients usually have multiple operations in these cases, and you should be ready for rotating hinge or hinge prosthesis to salvage such type of situations. So in conclusion, instability occurs in almost 20% as a cause of dissatisfaction in patients, and there are early failures in total knee replacement because of instability. The focus is shifting from survivorship to that of functional capacity and patient satisfaction, as we have been discussing since morning. And it is always good to avoid primary surgical errors to produce instability in the primary surgery only. Diagnosis of this functional instability presents a challenge. Proper history taking, clinical examination, and appropriately classification should be done before going for surgery, because each type of classification will require different type of surgical approach. And robotic technology might help in reducing these instability issues. Of course, the long-term studies are still awaited, and the question is open for jury. Thank you very much.
Very nice talk, sir. Any questions from the audience? Okay, if there are no questions, we can move on to the second talk by Dr. P.S. Nagpal.
So, first of all, I'd like to thank Dr. Shubhang for having me over and also conducting such a nice academic fest. And the live surgeries demonstrated were very well done. So, as we know, robotic TKRs are actually gaining a lot of interest in the younger as well as every age group, and I believe they are here to stay. So, it is all about how to adapt a new technology, because at times it does get frustrating, but when you believe in the benefits, that is when you actually start doing it better. So the most important thing is to start your training before you actually plan to buy it. So do your robotic trainings, and once you get your own robot, if you are feeling some obstacles, do call in a surgeon, a proctor who's already doing it. So that helps, because your OT setup needs to have a trained person training your assistants, because you might be doing the things right, but your assistants might not be well aligned. So there is not much literature published about robotics and the techniques. So talk to the experts, webinars, and the company should also have a good troubleshoot, because the robots do give errors on the spot. So you need to be good with your team management in the company also, because if there is some troubleshoot, there should be somebody who a contact person who should be there. So the mindset has to be very important, and that comes when you actually believe in the advantages of the system. It is always a question, because busy orthopedic surgeons, they always believe that robotic take care takes actually 5 to 10 minutes extra, so whether it is worth it. But once you start seeing the advantages of it, you actually believe in spending those extra 5 to 10 minutes, because that is what your patient wants, a better result. So and also you can only tell your patient once you believe in it. So you can sell it if you believe it. Training and understanding is very important, because you need to build a relation with the robo. It is no less than a girlfriend, because it will show tantrums and it will misbehave in the OT, but over time you actually need to build a relation. Be patient, because you'll see such times in you are shouting at your assistants, the robo is misbehaving. You have to devote time and never give up. You can shout, you can scream, you can cry, you can swear at your assistants, but don't give up. Just stay patient and things will smoothen out with time. The results which we get, they are actually what builds the belief. Patients actually walking second, third day and wanting to dance on your second days. That is what we all do this surgery, because it's a life-changing surgery. You need to believe in the concept. So believe in the concept, and that is how you actually start. Coming to the technical part, the pre-planning, as everybody says, is most important, because if you put shit in, shit is going to come out. So spend some time in planning when you are registering. Do register well, do plan well, and you will get good outputs when you are planning well. Some things which we don't actually see, handling of all the robotic things, that is very important, because proper cleaning, this is actually a part which the doctor himself doesn't see, but this is very important, because if the cleaning of the parts is not well done, there will be some errors coming up. So your assistant should be well trained on how to clean the robotic parts. There are errors which come up, so over time you actually get to know what the errors are, and you are careful that those errors are not done. This is all a part of the learning curve. So the more you do, the errors will stop coming and they'll actually smoothen up. The pin sensor position, as we've seen in most of the surgery, I prefer a metaphyseal pin position, which doesn't come in the motion like the robo arm. And actually, we also had a few stress fractures with the shaft pins. That is when we shifted to the metaphyseal pins. And in the obese patients also, a metaphyseal pin on the medial side is easier, because otherwise the fat patients, they will have their tummy and the trackers keep moving, and also the splatter that comes, the water that comes, if you are placing the trackers medially, they won't get the water splash, so you will have an uninterrupted surgery. The arrays should be facing towards the robo. The robo placement is very important, and your team learns over 1 or 2 months, and then the things start go smooth. Gap check, as we see, we need to do the gap checks very well because sometimes they show less gaps. So I normally put in an osteotome inside to see the gaps while doing a varus and a valgus thrust. And this is the most important. You should know what all options we have. So for a femur or a tibia, like in the last case, if we want to open up both the flexion and the extension gaps, that is when you touch the tibia. And if you want to just address the flexion gap, you have to adjust the rotation of the femur. And if you want to adjust only the extension gap, you can just adjust the distal femur varus or valgus. So knowing all your options, you can flex it, extend it. In my robo, it also gives you an rotating origin. So you can hinge it either medially or the laterally, and you can actually play with a lot of options. The more you play with it, the more you can use it better. So sometimes the robo position comes in between. So it is good to experiment or go the unusual way. Sometimes you have to place the OTS in an unusual manner, but it is okay because it should work. It should see the sensor. So even if you have to put it in a different position, that doesn't matter. Keep changing. So the as Dr. Vaibhav was also saying in the last case, it is safe. Even if you're not looking at the robo, not looking at the patient, talking to somebody, and it is doing its job, it is safe. So over time, you actually develop the trust in the robo that it is going to go in the region which is marked. The CORI is a haptic system, so the cutter will come in if you go away from the area. QS is a area marked, so it will not go out of that area which is marked already. So do it, verify it. The verification option is there so that you are clear whatever you've done is actually working. The more you do it, the more you learn. So it is all about numbers. The more you build numbers, then you also have to manage the workload. So that needs, you need to build a core team. You can't do everything. Build a team so that your stress is also less. Marketing is also very important to build numbers. So you can go the conventional way or the different way. And your relationship with your patient matters. Do give them time, even if you don't have, just spare some time, because the personal touch is always a healing touch, and people do actually feel good about that. And whatever you are doing, also you should teach, because not much literature is there about robotics. So the people who are doing, they should pass on that knowledge so that everybody can do this technique better. So in summary, we need to practice, keep on practicing, and you'll keep getting better on it. Track your progress, track your time, work harder, get feedback from the OT staff or whatever the assistants are there, and teach, study. That is how you learn. Thank you. Thank you for a patient hearing. Any questions?
Very nice talk, sir. You have really covered up minute details.
Thank you. Thank you.
I
so
hope
much.
it will motivate the younger surgeons to take up robotics.
Thank you.
May I now invite Dr. Professor Ramesh Singh for his next talk.
I think with the time of the robotics all around, we are talking about something which is non-robotic probably right now. Maybe in the days to come, we will have a lot of robots in this thing also identifying what the organism is. There might be something, and there might be something a lot to do with the defects, whatever there are. So probably the things will keep on developing right now. So right now, this thing is what Insol said about a two-stage reimplantation as the gold standard. And from that time, it has been replicated many times. The indications are very specific, that when infection is the level, when no organism is defined, when we have a systemic manifestations, when the pre-op cultures are difficult to really define the resistance also, sinus tract there, and inadequate soft tissue cover is there. We understand the first stage is always a removal, excessive debridement, irrigation, seaming, and all that. This debridement is expected to be really radical, and especially going down to the posterior capsule. That is what is understood. we must take out whatever the synovium, especially in this area where we can't access usually. We might need those tools to get it, so we must have adequate inventory. And now comes the question, how do we remove that implant which is already there? So there are various tricks of getting that out. Whenever if they have a good stability, still they can be taken out. And then the cement needs to be removed. If you have the option, you can use the simple tools or the ultrasonic remover. And then this medullary cavity needs to be properly reamed at. Irrigation becomes a very important part, that it must be adequately irrigated, and we have a lot of fluid which must irrigate all this area. Even normal saline has been supposed to be reasonably good. Then comes the stage that after we have cleaned, we put a spacer. Spacers could be our own self-made. Spacers could be this thing with enough of antibiotics, because routine spacers, routine antibiotic cement doesn't have that level of this antibiotic which we are looking for. And depending upon the sensitivities, we can do some of the mixing wherever required. Now with the question whether we are static or articulating, static are good for this kind of a situation when the wound cannot be closed, there is a massive bone loss, and where the limb needs to be given a static position, where you do not, where you're not expecting the movements to happen, and articulating is static is required for all these things. And then the antibiotic loaded dynamic spaces are required, where you are expecting a movement to happen, the soft tissue structures are okay, the muscles are okay, and then you can accordingly have a appropriate position, the way they can be put in. Outcome as far functional score is concerned is not supposed to be very different in them, though the range of movement itself has been much better with those where these articulating spaces have been put. The doubt remains when to do the second surgery. There are many in between. Antibiotics are given for 4 to 6 weeks of period. Thereafter, these need to be off, and then definitely we have to test it up whether this is okay. And there is a varying opinion which whether you use 2 weeks of antibiotic IV and thereafter oral and something. And there are reports which say even orals are sufficient. So thereafter, it actually depends on the kind of the load the patient has got it. We still believe till the time we don't get anything better, ESR and CRP, to rule it out, especially the combinations have been supposed to be too good. There are those inflammatory markers which have been said to be useful for this kind of a situation. So now the reconstruction, now this comes like a revision surgery. So you have to be very careful that regarding the exposure, whether it could be a stiff knee. So we have to be very careful. How do we do a skin incision? How do we do the arthrotomy? How to go between the tendon, the suprapatellar pouch area? And very important remains a quadriceps snip, which might have to be taken in this kind of a situation. We have to go under the scar tendons also. Medullary release becomes very important. Adherence removal is an important part to remove the soft tissue and scars from that area. And likewise, the patellar subluxation also becomes quite important at that stage. Then we need to take care to reach the posterior side, where we have to release reasonably. A repeat cleaning, just like the primary cleaning, it has to be a good debridement at this stage also before getting over to the reconstruction by putting all these revision kind of a instrumentation. Restitution of joint line is very, very important. And if there is a bone loss or trabecular, that is something which needs to be done at that kind of a situation. So I'm just going with one of the examples here. This was my own case 15, 20 years back where I did it. And then this was the arthritic rheumatoid patients also. I operated his both the sides. After 2 months, he developed that kind of a lesion over there. You can see over there around the area. So you can see the x-rays also. And then at that stage, I didn't remove it. I went for the straight debridement retention, cleaned it. It was okay for some time. But again, after a year, he again developed a problem. And this stage, so he settled, but second year again, he became symptomatic. At that stage, the things seemed to be little more. So at that stage, I thought of going into debridement. And again, 15, 20 years, we did not have these kind of a spacer. So we went for a static kind of a spacer. Observed it some time. Thereafter, we did the reimplantation as a second surgery after some time. And this was the reimplantation probably in 2011 or 12. I did this reimplantation. And this is his outcome at 6 months. And this is after 4 years. Then he did reasonably well. And then 6 months old, then this is another case. That was the case. So subsequently, now this is again, I can say about 10 years because he has been coming to me. So for last 7, 8 years now, he's doing very well. So that doesn't have a problem. But the attempt which I made for the retention did not succeed. And within first year, second year, he had a problem. Till the time I didn't really radically go for it and took it out. This is the another case with the kind of a situation which came as infected, not my own case, but anyway, it can be anybody's case. So this is the debridement spacer, we put it up. And 3 months later, when all parameters are okay, so this is taken to be 2 months to 4 or 5 months of a time. They say you should not go too long a interval. Again, there are problems. Too short interval could be risky, but even too long a interval is likely to be a problem. And thereafter, you go for this kind of a fixation, and this is reasonably out of. If those patients who cannot manage without antibiotics, there is something called antibiotic suppression, very specific kind of a candidates who cannot be either operated upon, or it is expected that surgery is not likely to improve their functional outcome, and patients who refuse surgery can be on something like antibiotic suppression. But overall, whenever we look for periprostatic infection, which is a reasonably big problem, technically, let me edit that we get a reasonable number of these cases now, because the total volume of TKR has increased so much, the complications accordingly they have to come. I mean, nobody can say I'm a very, very clean surgeon. Everybody gets these cases, and we have to be open for it. And definitely we must know what best we can do. And definitely we must be first to recognize and not to take on medicines, because this is not a medical disease. It is a surgical disease, so we have to be reasonably radical about the surgical procedure. Delaying the surgery actually complicates the problem further. So as soon as this thing, I still remember, if you know, Professor Rai used to be there. I'll take a minute about his this thing. He was so good. Once we were doing a thesis with him about infections. Incidentally, he was so clean and careful, he never got any infection. So thesis went, it was for infection, we never got a case. So the thesis had to be written something about this thing. But then he was always very clear. He used to do one case and he used to close all the OTs, everything. Then he used to do. I'll take a minute. So once it was done, he came out in practice that one of his best friend in his lifetime got his TKR done with him. He's a rheumatologist, very famous name. I don't want to quote it. He got his TKR done. And he developed a problem on the 4th, 5th day. And now Dr. I could not really dare to touch him again. And not touching that proved to be so bad that that professor retired had to get amputation done. And still he had lot of many problems, lot of many discussions. Eventually he had a malignancy also and we lost him. But a person could not make a decision to his friend to do the same thing, which he was doing for whole the lifetime. So probably we have to be very careful about something that whosoever it is, if there is a slightest of doubt, let's open it up. And that was his principal lifetime. Whenever there is a doubt, he won't do any surgery till the time that case is not done. So probably that was a very big thing. Thank you.
Thank you, sir, for enlightening us on such an important topic. And now I would like to invite Dr. H.S. Gill, sir, to give talk on debridement and implantation in septic total knee replacement.
Thanks, Dr. Shubhang, for having me here. I'll be speaking on Dyer. So most of the pictures and the text are taken from this book on knee arthroplasty by my friend Mrinal, and the chapter is written by Dr. Mohanty. So Dyer basically is before what Dr. Sain said has to be done. So Dyer has to be given a chance. So it is debridement, antibiotics, irrigation, and implant retention, basically to save the joint. And to do or not to do, basically, and when to do. That is exactly the thing that we all should be knowing. Like Dr. Sain said, that patient was not taken up for surgery, landed up in amputation. So when it is to be done, as you suspect, it should be done. Joint age, if it's less than 3 months, and if it's a late hematogenous infection of short duration, maybe 3 to 4 weeks, stable implant, healthy tissues, and an immunocompetent host. So all these things, they have favorable results. And however, there is no evidence that it should be done as an emergency. So first you basically optimize the patient and correct all the comorbidities in that patient, malnourishment, coagulopathy, and uncontrolled blood sugars, HB, etc. And remember, the surgery done at the wrong time and the wrong indication can be a disaster. So Dyer is not a solution in chronic infection, in presence of sinus tract, or in loose prosthesis, or even in all polytibia, because you can't reach the back of the joint. So avoid Dyer probably if the duration is more than 3 months, patient is immunocompromised rheumatoid, ESR more than 60, CRP more than 100, or the culture has grown MRSA or a gram-negative bacteria. And the organisms, so these are the bad organisms, the staphylococci, the enterobacter, the enterococcus, the fungi, and if it's a multi-drug resistant, so they have all unfavorable results. However, there are recent studies which have come up. They say that the success rate is 90% irrespective of the involved organism. And when you have opened up the joint, at least take the standard 5 samples from the synovium, implant bone interface, implant surface, synovial fluid, granulation tissue, and the tissue samples, they should be sent rather than the fluid samples. And always explain to the patient about the explantation. If you find on surgery the implant is loose, you have to remove it. So take this in the consent, otherwise medical legal issues can come up with this. And always do a thorough debridement and a radical synovectomy. Be as ruthless as possible in debridement. And of course, it goes without saying that poly has to be changed. And usually because of the swelling, the soft tissues are lax. So probably you would be needing a thicker poly. And always do this metal cement and the bone interface curettage. And goes without saying that unabsorbed sutures, they're the source of infection, so they also have to be removed. And a copious lavage. Copious lavage with normal saline is good enough. And you can use diluted betadine and add antibiotic also, antibiotic solution of gentamicin and the cephalosporins in it. And if you are using the pulse lavage, they say the high pressure lavage system that will push the infection further deep down. So use a low pressure lavage in this. And there are new agents like the acetic acid, the chlorhexidine. So these are the anti-biofilm agents, but not standard as of now. And one can use adjuvants like stimulant or collagen fleece or antibiotic beads along with dye. So arthroscopic lavage, this does not allow adequate debridement. You can't reach the posterior aspect of the joint. So it's usually not advocated. Now, this is the topic which is very controversial, use of antibiotics. We as orthopedic surgeons only know of 2 antibiotics, Supercef and Amikacin. So rest of the antibiotics, we should all depend on a physician and your local hospital cultures and recommendation of the microbiologist. So usually 2 to 6 weeks, they are to be given IV. And after that, probably oral antibiotics, and the maximum antibiofilm activity and high oral bioavailability are with the rifampicin and quinolones like the ciprofloxacin. And again, duration is very controversial. Some give it for 6 weeks, some 3 months, or a patient which is not fit enough, then probably we can carry on with the suppressive therapy. And of course, ESR, CRP are the best prognostic markers in this. This is an example of a infected knee, left side infected, dire appropriately early, and the patient is infection free. So the treatment depends. It has been shown that success rate for dire is usually ranging from 9 to 90%, and the success is if there is no infection for 2 years after dire. And various prognostic scores have been given, like the click score and the crime 80 score, whether the dire would be beneficial or not. So the click score is basically K for kidney failure, L liver cirrhosis, index surgery, cemented processes, and CRP. So if the score is more than 4, then the failure rate for dire is 60%. And similar goes for the crime 80 score. So the future perspectives are we have to destroy this biofilm. So antibiotics, they have to penetrate this biofilm. So biofilm agents, they are being researched. Biosurfactants for drug delivery are being researched. And newer implant material also are coming, being researched for TKRs in which the biofilm will not form. So at least in those cases, the dire probably would have more success rate. So these are the various outcomes of various studies in literature, and the success rate in various studies is to the tune of 84%. So to conclude, I would say that as Dr. Sen also said that as early as possible, one should go in. So if it's a case of Dr. Shubhang, I will say I will do surgery straight away. But if it's my case, I probably will keep on giving antibiotics and keep on delaying. So the dire thing is beneficial, best results if you do within 3 months of surgery, and in the late hematogenous infection, less than 3 weeks onset. Poly, of course, has to be changed, and post of antibiotics for 6 weeks to maybe even 3 months have to be given. And immunocompromised, MRSA, poor local soft tissue condition, these patients are not good candidates. And of course, the progress is monitored by the clinical exams and inflammatory markers. Thank you.
Any questions? Thank you, sir, for such a wonderful talk. Now I would like to invite Dr. R.R. Sagar, sir, for talk on mega processes in knee.
Good afternoon, everyone. I thought I'll be missing the talk, so I didn't. But thank you very much for the patience. And thank you, Dr. Shubhang, for giving me an opportunity to come onto the forum. But I'm a bit odd man out here, since I'm basically a practicing orthopedic oncologist. I do more of a mega processes, but not as beautiful technical surgeries like you guys do it. So, since Dr. Shubhang has just joined, thank you, Dr. Shubhang, for giving this opportunity, and it's always a privilege to meet you. The topic assigned to me was the mega processes for the tumors of the knee joint. So 8 minutes is a very less time, but I'll try to cover just distal femur and proximal tibia. And what do we want in a malignant bone tumor surgery? Do we want a patient salvage? The challenges are totally different. The life is important, then the limb is important, followed by the joint motion if I can restore, and early weight bearing of the patient, and of course the adjunct treatment should not be delayed. Now, before 70s, we have been trained during our era to do amputations for malignant tumors, but then better chemotherapy and all, it has led to limb salvage. So what does this include? We need a section followed by reconstruction, and that is how we get the function. So we plan the thing, where the incision has to be given, how to do the wide resection, and after resection, how the specimen looks like, and finally, the defect which we are left with, how to reconstruct it. So before limb salvage surgery, we have to have a biopsy report, neoadjuvant therapy done, proper imaging done after the treatment, and then restaging of the disease is done. We plan the wide resection and make sure that this function comes at least equivalent to amputation in the era where we get lovely prostheses as well. And be aware of the terms like satellite lesions, skip lesions, because they can be the cause of disaster. The challenges are, this is where my challenge comes in, sometimes the wrong biopsy incisions, major vascular involvement, some neurological involvement, some infection, some important muscle involvement, where the challenge comes for the resection. So you look at into all the various areas, looking at the skin, muscle, nerve, artery, bone, looking at the MRI pictures, and then you mark your areas, how I'm going to resect it out. And is there any pathological fracture, or is there any surgical intervention done? All this checklist is very, very important. Some examples, for example, these patients had multiple large biopsy incisions, multiple biopsies, wrong sites, and hence more skin loss.
And then issues related to the muscle involvement, which compartments, which muscle involved, all this is homework is done before the surgery. And then correct length alignment is obviously very important, and adequate soft tissue coverage is very, very important. And then we plan what is my longitudinal extent of the resection, what is my circumferential extent of the resection, and finally I plan where my surgery is going to be done. And this is how, after the planning, we go in for the mega processes, which is supposed to be potentially curative, and sometimes in palliative settings, probably in this arthroplasty forum, and maybe a revision arthroplasty, that is where mega processes come in, and that's probably why Shubhang asked me to speak on it. Well, of course, in terms of from oncology point of view, this is a big advantage because of its modularity and not affected by adjuvant treatments, and patients can walk immediately. Some clinical examples: proximal tibial resection, 16 centimeter of osteogenic sarcoma, which was excised after neoadjuvant chemotherapy. And this is how the section was, good soft tissue coverage, and hence the good result. And this was done, I think 2006 or 7. I'll show you some. These are some of my old patients who have been doing well so far. Then another distal femur section, thought it as a benign tumor, operated somewhere else, and curettage was done, but actually it was an undifferentiated pleomorphic sarcoma, excised, and this is how the intraoperative stability and the postoperative stability comes for the distal femur resection. Next, this is one of my first, not the first, rather first in Jalandhar, in fact, way back in 2003, where this chondrosarcoma was excised. He's still surviving, the longest surviving mega process I have. And this is how the results are. He's from Himachal and still pretty doing well. Then this is another child which had primarily a metaphyseal lesion of sarcoma. So thought of an epiphyseal sparing megaprosthesis, which was designed by myself. And this was, in fact, the idea was taken from the Stanmore prosthesis. And we were in touch with the IITN people, and you can see how the stability was achieved with the distal epiphysis. And 4 weeks down the line, this is how this child was doing. So this is kind of epiphyseal sparing megaprosthesis. So now these things are available, but when not to do limb salvage surgery, this is when you have poorly positioned biopsies, major neurovascular bundles, fungating and infected masses. Now, examples: multiple skin incisions. These are the places where I dare not do it, or these are all cases which have been collected by me during my own practice, and how the fungating mass probably will not do it. Then sometimes these surgeries are done, platings, etc., thinking it's a traumatic fracture, turned out to be tumor. And this is again a distal femur, thought it's a traumatic fracture, but actually it was a tumor. These are the cases where it becomes very, very difficult to do a limb salvage. And sometimes the major vessel is involved, and it's better not do it. In terms of vascular reconstruction is not always possible. Involvement of the popliteal artery, this old man, finally we decided to do an amputation. And this was another case. Now, so large fungating masses, which are not uncommon in our practice, they also pose a big challenge. And a late referral for a limb salvage is obviously a no-no for megaprosthesis. Now, it's very important once you tell the patient that I'm going to do a joint replacement, he compares it with a surface replacement. I mean, if you compare the results, the risk of infection in these megaprostheses is much higher than your conventional arthroplasty. Implant survival is much lower than the conventional arthroplasty. The risk of subsequent surgical failures, procedures is much higher than this. So this is very, very important that when I talk to the patient, they compare results of megaprosthesis with the surface replacements. So this is where the communication is very, very important. So I conclude by saying that limb salvage is the standard of care for the management of sarcomas or in failed arthroplasties where the extensive bone loss is there. It is safe if we follow the principles well. Thank you very much for your patient listening.
Thank you, sir, for a wonderful talk. Any questions? Now I would like to invite Dr. Shubhang, sir, to give talk on setting up a multi super specialty hospital.
So I think there are not many people in the hall. So unless somebody wants to set up a hospital. Huh? You would like to?
Yeah.
Okay, fine. So, then we have one more, my partner, Dr. Naveen Chitkara. He can speak on digitalization of a hospital. If you're okay, we can just do this. Tomar sahab, boliye. Bole kya? Okay, thank you everyone for patiently waiting in the hall. Okay, post lunch. And so this is going to be a quick overview of how to set up a multi super speciality hospital. So first thing is, it's oh, दोबारा उठा लिया. Anyway, I think we should just go forward without the slides till this. I think they have given up also. They have been working for 2 days. And so the idea is, it is a dream. Most people want to do a setup because there is a misconception that if I have my own setup, I will do better. We have gone through that. I have also gone through that. And it is usually this thing that if you have your own hospital, it will be all glory and no other problems. So that's how we also started, but it is a big difference. Okay, so it's not necessary that things will change for you as far as peace of mind or time for your own self, or these things will change if you have your own setup. But still, there are definitely some advantages. If you want to start, usually it is a dream. Now we need to discuss the why and the how of it. The why, like I said, most of the times it is a dream. So that's all you need to know, right? But the data says healthcare has become one of India's largest sector, both in terms of revenue and in terms of employment, right? The hospital industry in India stood at $61.7 billion in 2017, and post-COVID, there is a CAGR of 16 to 17%, and it has now reached $132 billion, which is more than doubled in 5 years. Rising income levels, greater health awareness, say especially post-COVID, increased precedence of lifestyle diseases, and improved access to insurance are the key contributors to this growth. The sector is expected to generate, it's gone again. Laptop to theek hai. Is expected to generate 40 million jobs by 2030, Indian hospital industry. But like I said, there's a slide saying dream again. So the benefits of a multi-super speciality hospital, you get high quality staff with focused experience, which is difficult to get in a nursing home, peer support from patients with similar injuries to patients, specialized patients and family education resources, more options to participate in research and other relief activities, in fact, access to services which are not found in most rehab centers and otherwise, and specialized long-term support available to
patients. Now, how to do it? First thing is you need to identify the land where you're going to do it. Then is the finances that you need to do, how you need to arrange. Then is the infrastructure. Then comes the permissions and the actual logistics of doing it. The land. There is a requirement for almost 1 to 2 acres of land to set up a good multi-super speciality hospital, basic, okay, where you want everything under one roof. If you want to do just 2 specialties, 3 specialties, you can. That doesn't fall in the purview of a multi-super speciality hospital. The location of the setup plays a vital role in OPD footfall and subsequent growth. In the future years, you may need to expand and get out. But I think accessibility in a tier 2 city and downwards is the most important thing. And in any, like we say in practice, it is ABC, accessibility, behavior, and competence. And in that order. So accessibility to the hospital also, approachability of the doctor apart. Accessibility to the hospital is important because the OPD footfall is what gets you everywhere else. So if your OPD footfall is low, obviously you can't expect the surgical footfall to automatically increase on its own. The cost of land, it varies majorly from various places. Then comes the finances. ये चलेगा कि नहीं चलेगा? लैपटॉप तो ठीक है यार, अभी 2 टॉक 3 टॉक दिए हैं इसमें. Okay, reboot it. अच्छा, leave it. एक बार आप वहां से स्क्रीन ऑफ करके चलो. The initial investment for the setup requires a budget of 50 lakhs per bed. So if you want to do a 100-bedded hospital, a multi-super speciality, this is a ballpark figure. It can vary, okay, but it is usually 50 lakhs a bed. A state-of-art unit requires a construction duration of almost 18 to 24 months. Okay, once everything is decided, then it comes like that. And the running cost of a 100-bedded multi-super speciality is approximately 5 to 8 lakhs per month per bed. So that's the calculation that you need to do to be able to, that you need to, pay your staff, you need to pay the overheads, you need to pay the maintenance. Overheads includes your electricity, water and other charges, and then the salaries of your doctors or whatever revenue sharing of your doctors, and then take something home for yourself also. So 5 to 8 lakhs per bed per month. Next question is where to get this money, right? So you can put it yourself if you have it. Number 2, you can get it from somebody, which is private equity. So it is not a bank, but it can give you money. Then is the NBFC, which is non-banking financial corporations like Bajaj Alliance and other people, but their rate of interest may be a little obnoxiously high and they have very low tolerance for default. Well, hopefully nobody should default, but they have very low tolerance and they can, they can be nasty. So then is debt, which is the bank. Okay. So the idea is start low, go slow. Let's say if you want to do a 100-bed hospital, you don't open 100 beds at all together. Plan for 100 beds, see essential services, space them out in such a way that you can have all the essential services and some beds to start off with. And then you can, do basic things and around that, and then go for everything else. Debt is the best equity. So they say, we'll get you private equity, we'll do this, we'll do that. But the debt is the best equity because the bank doesn't sit on your board of directors. The bank has got no say in how you run the setup, what you want to do. They will never object to anything. As long as you are furnishing the interest, they are happy with whatever you do. Whereas in private equity, the biggest disadvantage would be they will come and sit in your board. Now, there are 2 types of private equity investors. One is a strategic investor and one is a financial investor. So the strategic investors are those who want to be a part of your growth story. and run the setup for you. And the financial investors are those which want to be a part of your growth story, but they don't want to run the setup for you. You will take money from them. They will say, मैं अपना 5% बैंक में लेता हूँ या 8% वहां से लेता हूँ, तुम मुझे 10% दोगे, या they will project कि 15% आएगा, and they will, take that money. They give you that money, let you run the setup, have a little control on certain things, finances, but you will run the setup the way you want to. You are still the owner. Nobody has any objections in what you're doing. And they will, after 4 years or 5 years, they will exit, take their money, and you make your money, they make their money. That's what it is. Then is the infrastructure. A multi-super speciality hospital should provide the following services. We've exhaustive list of departments, everything, but mainly it is everything under one roof. Everything under one roof means the patient enters, and for nothing the patient should be sent out कि आप उधर चले जाओ, उस lab से ये करा लो, वहां से X-ray करा लो. This increases the confidence of the patient if you have it under one roof, because they don't have to run around and everything is available there. And this also increases your own performance and outcomes, because sometimes it's time dependent. You're not waiting for a report to come. You are not waiting for a permission to come. So things like that. Then are the permissions. So you need municipal corporation to start the building. You need to start the construction. You need municipal corporation to finish the construction. And then what I have not written here is the municipal corporation to check if there's anything else. It's a continuous, it's a permanent marriage with them in a way. So then you need the NOC, architectural plans have to be ready. From the fire department, you need permission. You need the permission from the pollution department, water, air, biomedical waste disposal. You need commercial electricity permission. You need AERB, that is Atomic Energy Regulation Board, for all radiation equipment from CARM to the smallest mobile X-ray to a dental X-ray to an MRI to CT scan. You need permission from the ARB. Then you need storage of oxygen. If you have a large plant, you want to, in a multi-speciality, obviously you will need some sort of facility. If you are planning to put a liquid oxygen or store it, you need permission from the explosives department also. So that's why more than 1,000 liters, if you have to store oxygen, you need permission from explosives department. So that is why all these tanks, they tweak it, and they say the tank capacity is 990. So it's not more than 1,000 liters. So you don't need explosives permission, but you still need permission to store oxygen from the fire department. Then you need permission to take out groundwater and use it. It is actually for everybody, but definitely for hospitals, because then doctors become easy targets, and hospitals, they definitely need groundwater usage clearance. Then you need clearance from National Highway Authority of India, NHAI, if you're on a highway, if the building is planned on a highway or abutting the highway. Logistics, you need to, once the hospital construction is done, you need to be prepared for doing the branding of the hospital. You need to have a huge human resource, hiring doctors and staff. Role of the HR comes there. Advertisements, question mark hai, how much is allowed, what is not allowed, needs to be seen. Then F&B, cafe, canteen, and patient diets. You need implants and consumable supply chain. You need medical record keeping, and you need an in-house laboratory facility. Okay, so what we are saying, branding is something we can do. Human resource, this is a repetition. You need to do regular health camps, checkups, and awareness to build that. Brain and brawn, both will go into it. You don't think it is going to be easy, but nothing is easy in life. Okay. Stress, so you should share it. It will definitely create a lot of stress in your mind, mental, physical, emotional sometimes, but you should share it with your family or your colleagues. And then, you should know that there has to be a time. Don't just take it on your own. And if you're not able to do it, there is always another chance. Okay, what can be outsourced? Food and beverage, definitely. Canteen and patient diets can both be easily outsourced. You reduce your stress. Laundry, you don't need to outsource it. Security, you can outsource it. Housekeeping, you can outsource it. Implants and consumable supply chain, you can outsource it. Laboratory services, you can outsource it. So you need to run Radiological services, you can outsource it. So these are the services that you can outsource, but out of which, surgeon also, then multi-speciality nahi rahega. So out of which, I would suggest that you should keep the laboratory and radiological services with you for the revenue part of it, so that you can set off your other expenses a little easily. And that is it. All the best if you are planning to build. Sorry, pharmacy, I forgot. Do not outsource. Thank you, everyone. So we have another small talk, if you permit. My partner, Dr. Naveen Chitkara, neurosurgeon. He's a.
I sent him the link. He's going to join on Zoom.
Okay, open it. He is traveling, so we requested that if he can talk on Zoom, so he will now. So till he sets up Zoom, I think we can just do a closing ceremony. Yeah, so that it's के बाद टाइम सुनाओ वहां के बैठ के सर की सुन लेंगे हम वो तो Zoom पे ही है ना. हाँ यस
अभी ज्वाइन हो गया.
Dr. Naveen, good evening. Can you hear us?
Hello. Okay. Can I request all the speakers of this session to be on the dais, please? Kara Zafar is there in the audience. Can you just do the honors of facilitating our speakers and the chairpersons of this event? Sure.
Thank you. Already finished. No, it's okay. For every talk that you get, you get something. Chocolate. Hurry, we have chocolates also.
Yeah.
Thank you. For sparing time. Thank you. For staying back.
थोड़ा मिठास के साथ ऐड करते हैं सर चॉकलेट्स.
खाते में काम आएंगे.
थोड़ी कम है सर. So the last talk of this regional meet, this is going to be from one of the I think innovator and one of the creator of this space in this segment from Dr. Naveen Chitkara, who is master in doing it. I think nice to hear it from him.
Just a moment.
Sure.
That's why, but how? Okay, the first is I'm on the first slide, which is your introduction. ठीक है. Right, that is your MBBS MS 45 articles. Yeah, right. So join up with the problem.
Good afternoon, everyone.
Yeah. Good afternoon, sir. Are you able to hear us, sir?
Hello?
Yes, yes, I can hear you. Yes.
Please go on.
तुम कहाँ हो? मैं तुम्हारा घर पर इंतजार कर रही हूँ। मुझे आने वाले हैं। तुम्हारे लिए
Okay,
सब
Vikasi, can I have my first slide, please?
Yes, sir. It's on.
Uh, can we go on the next slide, please?
Yeah, sure, sir. Right. We're on the next slides now.
Yeah.
Get set up.
Colonel Zafar is there chairing the session?
Colonel Zafar.
Colonel
No, actually,
Zafar is there?
so there are 6 people in the hall, but we every sound from the stage, we are listening to you.
Okay.
Colonel is there, Dr. Vinder is there, Dr. Deepak Joshi, Dr. Tomar, Dr. Amit Pathak, 7, 8.
Okay, good afternoon, everyone.
Team.
So, this is a very interesting topic. So, let me start. Hello. Can I have the screen, please?
There is a background noise. Can you please?
So, someone has to mute. You have to be putting the other people on mute. So, this is a very interesting topic where if I just start, you are going on your rounds in the ICU and you've got a patient who is sick, and suddenly the computer tells you that this is the best antibiotic which you have to give to the patient. Look for that technology which is coming on. Vikasi, can we mute the other people?
There is some.
आज ही मैंने जाना है ऐसा कभी नहीं सोचा क्योंकि आज मुझे एहसास हुआ है कि
Your side, sir.
No, there's no noise from my side. Okay.
Can you
Next
read?
slide, please. Yeah, I can read. Yes. So let me go to the next slide.
But I hope you are not in a movie theater.
No, I am not in a movie theater. Can I have the next slide, please?
एक मिनट छुट्टन शुरू हो गई भाइयों तेरे को जब बोल दिया तेरे को काम नहीं है छोड़ के
आराम से 8 दिनों का समय होता तो मैं जानता हूँ बहुत कुछ किया जा सकता था लेकिन बदकिस्मती से हमारे पास इतना समय नहीं
And log in again.
सागर का दास यानी तुम्हें देखने के लिए कल आ
Dr. Mean, are you able to hear me? I think he's going to rejoin.
I can hear you. Can you hear me now?
Yes, we can now.
Okay, so let me start.
Fine now, sir.
Okay. So, as I said that it is a scenario which is going to come in next new future is in next future is that you go to your rounds in the ICU and suddenly the computer tells you which antibiotic is to be given to the patient. So that is the technology I'm talking about. Can I have the slides, please?
Yes, sir. We have your next slide which says why, what, and how.
Can you show me the slide, please?
लेकिन आज ही मैंने जाना है ऐसा कभी नहीं सोचा क्योंकि आज ही मुझे एहसास हुआ है कि
I think because I'm traveling and this is the border area, there might be some issue with the signal. Can you hear my voice?
Yes, we can, but there is background noise, sir. It's not that clear.
So it is that background noise. I'm not sure. So if I talk about this technology, the biggest hurdle which comes for the technology is the adoption of technology.
It seems to be some mixing of signals, sir. Some
Yes.
going on, so that's why.
So, Dr. Naveen, what I suggest is because it's absolutely, there's no point listening because Sunnira, we'll go through your slides if you are okay.
Yeah, that's okay.
So we'll just go through your slides and I'll come up and speak on your behalf. If I have any doubt, I will call you.
Yeah, sure.
So Dr. Naveen is extremely good at digital solutions, and his
The software that we use at NHS hospital is made in-house by him. So he's a neurosurgeon and he's also a software geek. Okay, so that's how he made it and developed it over the last 10 to 12 years. Okay, version 1 to version 8 now. So what the slide says, why should I adopt? Okay, so the thing is, when you, like I said, you make a hospital for, okay, I will be the boss and I can control everything. Okay, I have grown up with the system, everyone should be adjusted with it, you know, so, but you don't really know. And you have this false impression in your mind that everything is going well because there will be people next to you or just below you who will give you only that much information that is okay for you to hear. Everything else will be hidden and there may be a disconnect from, you know, the lowest rung, maybe a technician or a class 4 or a staff nurse to the next level, and you may have a disconnect and may get fed with wrong information, and cost can go spiraling up if the right people are not in the chain, right? So why should I adopt it? Because the question is, what is the lifespan of a business actually? So we don't know. Okay, we don't know. Something which is working today, suddenly robotics is taking the world by a storm. Tomorrow something else may come. You know, like I said, the change is a constant that that's the only constant in the world. So disruption, because you need to do something which is disruptive and which can, you know, give you an edge over the others. Only 10% people are ready to go into that disruption mode because 90% will say we are in that comfort zone. Arey kaun mehnat karega, you know, and why get it? Because it's behavioral change also. So let's say you are used to writing a prescription कि भाई मैं तो एक कैल्शियम एक विटामिन डी एक ये लिखूंगा फटाफट हाथ से 4 चीजें लिख के भेज दूंगा. But a software will make you, government of India will tell you write generic and write in block letters. So that's a behavioral change. You will say, मैं क्यों लिखूं? मुझसे इतनी तेज एग्जाम में लिखाते थे, you know, मेरी handwriting ऐसी हो गई है, मेरे को आदत पड़ गई है like that. But a digital system will change that thinking. Initially it is difficult, but then you get used to it. So I have to understand this also. So sir has written that there is the technology in healthcare it's a pyramid. So that the base is patient care, the hospital management, you know, and then luxury, accessory, necessity, digitization. Yes, it is definitely not luxury only because you have to spend money on it. That's all. It can be put in that category. But it's an accessory definitely because it's helping you grow, and necessity it is becoming because then it speed up, keeps you in charge. Really, you can do self-appraisal, you can analyze what is happening, and in the future it will help you to survive. Your financial KPIs, where are you in the market? Your revenue will increase and your expenditure will definitely decrease if you have strict control. Let's say if your stock is checked, pharmacy, there's no pilferage, and you know that if 10 tablets were bought, 10 have been sold or not, you can see it, and instead of counting, they can, you know, physically counting is different. Then what is the technology? One technology is for patient care, technology that improves results, makes processes faster and more accurate. There is these robos, lasers, navigation, 3D imaging technology, etc. Like 3D printing, they wanted to do a talk today on that, doctor, but we couldn't do it. And one is a technology for the hospital processes, so which is less dependent on humans, accurate, hassle-free, improves the outcomes and makes it a lean system. Now, lean system means that there is less manpower, minimum manpower involved in a lean system. So if you say that I want this chair shifted from this auditorium to the OPD 2012, and how many people do you need to do for that? So sometimes a chair there may be 4 people who will go to shift that chair, or if a good efficient person, he may be 1 who will lift that chair, but you know that 1 is dangerous, 4 is superfluous, 2 exactly are needed to lift it and go. So you can, the processes, you know, if the technology can tell you, okay, bhai, this is the kind of chair, this is the kind of door that is there, that is the route that has to be taken. And so you need 2 people who will do justice to this work. You don't need less, you don't need more. That sort of thing. Now, how to do it? One is digitization, one is digitalization. Digitization is if you have the first step electronic. So patient comes in, you give an electronic prescription, type everything into the computer, complaints, chief complaint, everything, which the software at NHS became paperless on 1st of January 2024, the OPD. And very soon we are introducing the, Dr. Naveen only has devised the IPD module where the entire hospital should become paperless. So you have a key like some certain corporates do. You have a key, you plug it in, and that's your signature. So you have access only to that record. And if you've left the key in and somebody fiddles with the record, you're medically responsible for that. Medical legally also responsible for that. Digitalization is conversion the existing paper record to paperless record. So in the process of digitalization means a patient has shown me in the month of November with a paper prescription and now comes in the month of February for a follow-up. And now we are giving them a paperless prescription. So that is digitalization. So all your patient record is scanned, digitalized and kept inside. So EMR, like that is electronic health record. All insurance companies will ask for EMR. Billing makes it easy. With a software, you know, all the charges can be fed in. It becomes very fast. You don't miss anything. You don't add anything extra. It is transparent to both the service provider and the person who's receiving it. Procurement and store management, definitely you cannot do without digitization. You know, scanning softwares like barcode is a very common thing now everywhere, but scanning softwares can help. Store management softwares can definitely help. HR management also, like in our HR module, we've got, when we, I don't know if they follow it, but we put, let's say somebody, even hobbies are added. If Aniket is good at, let's say, cricket, football and basketball, and he's good at dancing. So if you want to make a team for dancing competition, you can just filter dancing as hobbies and then 5-6 names may pop out. So, and you can choose something. It's an, you know, odd example, but that's what can be done. BME management, dietary services management, of course, porter management, which room porter kitne aapko chahiye? You need 8 or 10 or 20. And which room there has to be a call, what should be the order, what should be the timing, and it can be very efficiently managed with lesser people without overburdening them. Of course, feedback, then we know that Google reviews are a big thing these days. And, you know, if somebody doesn't like the way your security guard spoke to him at the gate, he can change your impression to people. So how, like we said, I, me, myself, I am the boss has to be taken care of. So that attitude will go. If I, me, myself is there, the boss also needs to have self-appraisal, understand what's happening. And it has to be like he has written idiot proof. Okay, so it's difficult to make systems which are idiot proof, but because you will say, bhai, ye live surgery shuru hoga, to aisa kar dena, and the idiot drops the burr down. So you can't help it, right? So, but the software can be, the system can be an idiot proof. I don't know what the parabola effect is. Transition from a paperless to a paperless healthcare setup. Challenges in the adoption of technology, behavioral change. So if you say, I see 70 patients a day, kaun type karega, sir, I don't want to do it. Or if I say, okay, you help me do it, you know, so everybody has to be slowly got on board. NABH digital standards, NHS hospital is now a member and we've applied for NABH digital standards platinum grade, and very soon we should have it. It's the number of points that they check, that like they give you a green building, they will give you a platinum grade in NABH digital standards also. Sorry, there are no results. He will have to speak. So I think that's the gist on behalf of Dr. Naveen Chitkara. Thank you, everyone. And then I just take this. Should I close? Dr. Goyal? Thanks. I think I'll only close. So, just once again, thank you. All the faculty who have traveled all the way from their busy practices from various parts of the country. And it has been an absolute honor to host you guys and listen to you and interact with you. Some old friends, some new friends. And thank you everyone in the NHS team who has patiently worked and made this show a real success in real words. So I'm extremely happy with the way everything went. Of course, there is always a new learning. We know where we falter, and there is always a new day to change and improve. So thank you everyone. And a special mention to Mr. Sharma, who's not with us anymore, but he will still be the CEO for all these events, and to the actual CEO, Mr. Vikas Kalia. So thank you everyone, and wishing you all the best.
Sir, your mobile. This also yours. Okay, boys, thank you so much. Thank you, backstage. Every time one is nothing for the work you have done. Thank you.